one and all present. I'm Dr. Pooja Chaudhary, and on behalf of the Society of Pediatric Intensive Care, Kolkata, I take this opportunity to extend a very warm welcome to the East Zone Pedicriticon 2024. We have a very tight schedule in front of us, so without wasting any time, we are going on to the oral paper presentations by the PG students. These paper presentations will be judged by a very esteemed panel of judges. We have Dr. Bandya Sahu ma'am, who is Professor and Pediatric Intensivist at Kalinga Institute of Medical Sciences, Bhubaneswar. Dr. Joydeep Das sir, who is HOD Pediatrics, ex-Professor of Pediatrics of ICH, Kolkata. And Dr. Pradeep Kumar Jena, who is Professor in HOD, Department of Pediatrics at SLN Medical College, Koraput. I hope all the delegates are ready with their presentations and wish you all the best. I request all the judges to kindly take the place on the dais. You have a time of 7 plus 3 minutes. All the best.
A warm good morning to everyone. Esteemed judges, my dear friends, I am Dr. Subhashri Sahu from Tata Main Hospital, and welcome to my presentation on comparison of non-invasive positive pressure ventilation and high flow nasal cannula in children with acute bronchiolitis, a randomized controlled trial. As we all know, bronchiolitis is the constellation of clinical signs and symptoms of viral respiratory tract prodrome followed by increased respiratory effort and wheezing in children less than 2 years of age, and both high flow nasal cannula and non-invasive ventilation have found to improve oxygenation and decrease work of breathing in bronchiolitis. However, there are few studies comparing the efficacy of one over other. In the literature review, Sachdev et al. Conducted a RCT on comparison of HFNC versus NIPPV and inferred that possibly they are equally efficacious in treatment of bronchiolitis, whereas Zhang et al. Conducted a meta-analysis of RCT and inferred that with HFNC group there is higher treatment failure, but the intubation rate and length of PICU stay were comparable with both the approaches. The hypothesis of my study was non-invasive positive pressure ventilation is non-inferior to high flow nasal cannula in treating children with acute bronchiolitis. The research question was, is NIPPV non-inferior to HFNC in treating acute bronchiolitis? The aim of the study was to compare the efficacy and safety of NIPPV and HFNC in treating children with moderate to severe bronchiolitis. The primary objective was to compare the efficacy, and the secondary objective was to compare the adverse effect of treatment with each of the modalities. Coming to the methodology proper, the study design was a randomized controlled trial conducted in pediatric ICU of a tertiary care center. The study period was 2 years from April 1st, 2023 to March 31st, 2025, a period of 2 years. The sample size was 84 with 42 in each group. The data that I am showing here is an interim analysis of 50 observations with 25 in each group. This is the sample size calculation by our in-house statistician. The inclusion criteria were children aged more than 1 month to less than 2 years of age, admitted with a diagnosis of moderate to severe bronchiolitis as per modified Woods clinical asthma score. The exclusion criteria was refusal to participate, recurrent wheezer, children with chronic illness, or children needing mechanical ventilation for any reason. The scoring system that we have taken is modified Woods clinical asthma score, which takes into account oxygen saturation, inspiratory breath sound, expiratory wheezing, accessory muscle use, and cerebral function, and gives a score from 0 to 2. The score 0 to 3 is taken as mild bronchiolitis, score 4 to 6 as moderate, and scores of 7 to 10 is taken as severe bronchiolitis. All participants of moderate to severe bronchiolitis were admitted to PICU and put on either NIPPV or HFNC allocated by computer-based simple randomization, and data was recorded in pre-designed performa. Appropriate statistical tools were used whenever necessary. The initial NIPPV setting was a PEEP of 5 centimeter of water, and peak inspiratory pressure of 15 with a maximum allowed fraction of oxygen was 60% with a target SpO2 of more than 94%. The initial setting for high flow was flow rate of 2 liter per kg per minute with maximum allowed oxygen was 60% and SpO2 target was more than 94%. Coming to the outcome, our primary outcome was decrease in the score by at least by 1 point after 6 hours of intervention or need for mechanical ventilation that will be termed as treatment failure. The secondary outcome was number of days of intervention, duration of PICU stay, or adverse effect with the respiratory support. Coming to the criteria for the treatment failure that we have taken are SpO2 of less than 94% on 60% of FiO2 or partial pressure of carbon dioxide more than 60 with pH of less than 7.2 and SpO2 less than 94% on PIP of more than 20 centimeter of water on NIPPV, apnea for any reason, or clinical discretion for mechanical ventilation, or need for mechanical ventilation for any other cause such as poor respiratory effort or patient going into shock. The modalities that we have used is non-invasive ventilation mode on staircase ventilator and high flow machine. And in both the modalities, we have used optiflow nasal cannula as the interface. The total eligible patient during this period were 50 and simple randomization done on 2 groups with HFNC having 25 patients and NIPP having 25 patients. In both the groups, we had 1 treatment failure each and rest of the 24 patients in each were successfully treated. Coming to the initial demographic parameters, as we can see here, the more number of patients, like 70 to 80% patients were males and 20 to 30% were female, but they were equally distributed in both the groups. The same is true for age and weight distribution also. Coming to the baseline characteristics of patient randomized to 2 groups such as pulse rate, respiratory rate, saturation, pH, lactate, partial pressure of carbon dioxide were equal in both the groups, such that both the interventional groups were having similar baseline characteristics. Coming to the severity scoring at admission, 88% of patients having on HFNC group had moderate bronchiolitis and 12% has severe bronchiolitis. In NIPPV group, 84% had moderate bronchiolitis and 16% had severe bronchiolitis. Coming to our outcome proper, after 6 hours of intervention, the scoring was again done and the primary outcome that we have taken, decrease in score by more than equal to 1, was seen in 60% of HFNC patient and 72% in NIPPV patient. But as we can see in the graph, this difference was marginal and not statistically significant. Coming to pulse rate and respiratory rate comparison at 6 hours. At admission, they were equal statistically, but at 6 hours, as we can see that there is significant decrease in respiratory rate by NIPPV, but the pulse rate remains statistically similar. Coming to the days of intervention, days of weaning, and days of ICU stay between the 2 groups, they are statistically similar. Marginally higher days we can see in NIPPV group, but this was statistically not significant. In both our intervention groups, we did not record any nasal injury or pneumothorax, but there was 1 treatment failure with each group which was treated with invasive mechanical ventilation. In our discussion, as seen in our previous study, we see that the NIPPV and HFNC are statistically equally efficacious in treating moderate to severe bronchiolitis. Reduction in score and respiratory rate is marginal in NIPPV, but statistically not significant. The limitation of our study was that it was an interim analysis, it was a single center study, and blinding could not be done. Coming to the conclusion, we can conclude that HFNC and NIPPV are possibly equally efficacious in decreasing respiratory rates, days of intervention, and days of PICU stay. Such, NIPPV is non-inferior to high flow in treating moderate to severe bronchiolitis. And what does this studies add? It adds that NIPPV is a safe alternative. As we saw, there is similar side effect and no incidence of pneumothorax with the interface that we have used with both the modalities. These are my references. Thank you.
odds ratio?
No, sir.
No, so how you have got the interpretation? Your p-value is absolutely beyond the range. It is not significant at all. My one question is, another clinical question is, your study population includes 1 month to 2 years. So how you have excluded the cardiac cause? For example, your unregressed pulmonary hypertension, superimposed bronchiolitis. So it should be excluded from study population otherwise.
Sir, the children who had cardiac causes, so we have our own echo machine and we are doing evaluation for any more respiratory distress that has not been resolved by conventional treatment, and we are excluding the population then.
Yeah, it's a very tricky zone, so we need the help of pediatric cardiologist in ruling out of this pulmonary hypertension. So anyway, I think if any question. Okay. So any question? Okay. Next.
Thank you, sir. Thank you, ma'am.
Let's proceed for the next talk. So please try to complete your presentation within 7 minutes, okay?
Yes, they have to complete within 7 minutes. And the question and answer 3 minutes, please. Request to judges.
Calling our next delegate on stage, please. Dr. Agrani Panda, who's a junior resident at Medical College, Kolkata.
Good morning, everyone. Respected judges, I am Dr. Agrani Panda, Junior Resident, Medical College, Kolkata, and I am here to present our work on evaluation of real-time neutrophil gelatinase associated lipocalin, that is NGAL, directed renoprotective strategies in critically ill children in Pediatric Intensive Care Unit. So, acute kidney injury is a very common and serious complications in PICU settings occurring in 10 to 40% of the children, and it develops very rapidly over hours to days, and there has been a lack of reliable AKI risk assessment system that hinders our ability to provide appropriate preventive measures in a timely manner. So current definition of AKI given by KDIGO states on serum creatinine and urine output. Then the creatinine may not be deranged until late. So there has been search for newer biomarkers like NGAL, kidney injury molecule, tissue inhibitor of metalloproteinase, and others. So NGAL has been shown as a newer biomarker which rises within 2 hours of kidney injury, much before the traditional markers. Now, there has been several studies about NGAL in predicting AKI severity, progression, recovery, and its association with clinical outcomes, but there has been a lack of implementation studies for NGAL guided strategies against the standard therapy. So our objective of the study was to compare the incidence of AKI in PICU settings in patients admitted with a PRISM score of more than 10 for real-time NGAL directed strategies versus standard therapy. And the secondary objective was to find association between secondary outcomes. Now, we have done a single center prospective parallel group open label study for a 12-month period, and this is a 5-month interim analysis of that study, including 60 patients, and after getting the IC approval and informed consent for all the patients. These are our exclusion criteria. The primary exclusion was done for pre-existing renal disease, UTIs, major congenital or Charcot anomalies, and parents who are not willing to give consent. Patients were also excluded subsequently if they develop AKI within 6 to 12 hours of PICU admission. We have taken an NGAL value of 406.5 nanogram per ml as a positive cutoff, as this value was obtained by a study done in our institute only previously. So this is our study flow. We have included the patients according to the inclusion criteria. After excluding the patients according to primary and secondary exclusion criteria, we have taken total of 50 patients, and out of them, 31 had a NGAL value more than cutoff on any of the 3 readings we have taken. And we have done a computer-based randomization into group A and group B consisting of 16 patients and 15 patients. For group A, we have taken NGAL-directed renoprotective strategies, and for group B, we have followed standard AKI management protocol. The renoprotective strategies included avoiding avoidance or modification of nephrotoxic drugs, fluid restriction or optimization to avoid overload, and optimizing perfusion by use of ionotropes. For the standard AKI management protocol, we have done as per the KDIGO criteria, and we have assessed both the groups. Now, these are our assessment parameters. The most importantly outcome parameters were development of AKI, cumulative fluid balance at day 3 and day 7, need for RRT, mortality and length of hospital stay. Statistical analysis was done as per the data type. Now, 31 patients who has the NGAL value more than cutoff, out of them 13 developed AKI in total, which is a 42% incidence. In demographic parameter, there were no significant difference between the two groups. There was no difference in severity parameters as well, like shock, need of respiratory support, mean PRISM score, or organ dysfunction. When comparing the lab parameters, we only get a significant difference in serum urea value in the group B with a p-value of 0.04. When comparing the NGAL values at 3 readings, 6 to 12 hours, 24 and 48 hours, we got significant difference with a higher value at group B at 24 hours and 48 hours, but no difference in 6 to 12 hours values. When comparing the outcome parameters, 9 patients of group B, that is 60% developed AKI, whereas in group A, 25% developed AKI with a significant p-value of 0.04. We also got significant relation of fluid overload at day 3 and day 7 with a higher value in group B, as well as the mean interval of AKI development were shorter in group B with a significant p-value. The correlation coefficient shows there was with NGAL, day 3 and day 7 fluid overload was showed a positive non-linear correlation with a greater value in a group A. This is our graphical representation of the results. So, we have got a positive association for AKI incidence, the mean interval of AKI development, and the cumulative fluid balance, whereas we got no significant difference for need of RRT, final outcomes in terms of mortality and length of hospital stay. So, in the previous studies which were done for NGAL directed strategies or NGAL, the AKI incidence was found more or less the same, but the study done by Dr. Goldstein and folks and Dr. Jean Philippe Roy and folks, they showed a significant difference in outcomes in terms of 7-day fluid accumulation, length of hospital stay and mortality as well, which we did not found in our study. So it has been shown a promising early biomarker for renal injury, but in our study, we have found a better preventive value for NGAL-directed strategies, but no difference in the outcome. So it needs a larger multicentric trial that may find otherwise result. These were our limitations. The sample size and study periods were inadequate, and there was difference in homogeneity between the two groups, and we did not do the long-term follow-up, other than the statistical limitation of the study design itself. So we like to conclude that the integration of NGAL to take early preventive measures can be beneficial for critically ill children to reduce the development of AKI and its complication. However, large-scale trials and long-term studies are warranted to solidify this finding and establish a clear guideline for clinical practice. So these are our references, and this is our study at a glance. Thank you.
Okay, so your only significant finding is your fluid overload. Fluid overload p-value is very much significant.
And sir, AKI incidence, the incidence of brain.
AKI incidence. So probably it's a very good, helpful tool for a clinician, because sometimes we could not find any cause of this unnecessary fluid overload. So in spite of getting a very restricted fluid, the baby is gaining, So that is what is a very good study, and your presentation is nice. I have full support for you. Any comments?
Why you excluded in the first 4 to 6 hours those developed AKI?
Sir, because that was a resuscitation period for most of the patients, and it would have developed functional AKI or transient AKI, because patients are coming from the rural centers to tertiary center. There may be a transient AKI which we have resuscitated with a initial fluid, given initial fluid bolus and things. So we have taken the, after the 6 to 12 hours, that is a post-resuscitation period after coming into our ICU.
This was urinary or serum
This
NGAL?
is, madam, urinary NGAL test. We have kit for that.
Okay. So what is the cost?
We got it for free from the government. We have our supply. We have the kit supplied in our ICU.
Okay. Fine.
Thank you.
I now call upon the next presenter, Dr. Amrita Rai. She's from SSKM.
A very good morning, respected teachers, seniors, and my dear colleagues. I am Dr. Amrita Rai. I'll be presenting a study on the clinico-epidemiological profile and predictors of ventilator-associated pneumonia in PICU in a tertiary care hospital in eastern India. Ventilator-associated pneumonia is a major cause of mortality and morbidity in PICU. It is defined as new onset pneumonia in a patient on mechanical ventilation for more than 2 consecutive calendar days on the date of the event, with the day of ventilator placement being day 1 and the ventilator was in place on the date of the event or the day before. The objectives are to determine the clinical and epidemiological profile, predictors, and outcomes of VAP. It was a prospective study done in the Pediatric ICU of Department of Pediatric Medicine, IPGM E&R, over a duration of 4 months. All children aged 1 month to 12 years who were mechanically ventilated for at least 48 hours were included. Those with tuberculosis, pre-existing chronic lung disease, and primary immunodeficiency were excluded. This shows the summary of the study protocol, where after fulfilling inclusion and exclusion criteria, all the cases were taken. CRP and procalcitonin was sent on day 3, and the modified clinical pulmonary infection score was done in all. Those with a score of more than equal to 6 were categorized as VAP, and those with a score less than 6 were categorized as non-VAP. In the VAP category, mini-BAL was taken and was sent for aerobic culture and sensitivity, and a growth of more than 10 to the power 4 CFU per ml was taken as positive. The outcome was assessed in all the groups in terms of MODS, number of ventilator days, and mortality. So it showed the incidence of VAP was 50.5 per 1,000 ventilator days, mean age of the population being 3.5 years, interquartile range being 5.5 years, 72% were males and the rest 28% were females. Among the 43 patients who were included as the sample, 20 developed VAP, that is about 46.5%, and the rest 23 were categorized as non-VAP, that is 53.4%. Among the 20 patients with VAP, 40% developed early VAP, that is within 96 hours of ventilation, and the rest 60% developed late VAP, that is beyond 96 hours of ventilation. So among the patients with VAP, 60% were culture positive, while the rest 40% were culture negative. On analyzing the organism profile, Acinetobacter baumannii was found to be the most prevalent organism, which was multi-drug resistant, having intermediate sensitivity to colistin and imipenem. The other organisms reported were Pseudomonas aeruginosa, Burkholderia cepacia, E. coli, Streptococcus pneumoniae, and Streptococcus mitis. Now, on evaluating the underlying pathologies for which the patients were initially ventilated, CNS cause was found in 45%, 20% being malignancy and congenital heart diseases each, and the rest 15% were pneumonia. Now, on studying the duration of ventilation, with the incidence of VAP, it was seen that those who were ventilated for less than equal to 15 days, 39% of them developed VAP, while those who were ventilated for more than 15 days, almost 85.7% of them developed VAP. The p-value was 0.023, which is statistically significant. Next, we studied certain biomarkers of VAP, namely CRP, procalcitonin, oxygenation index, and predicted probability of combined procalcitonin and oxygenation index. Let's see these parameters in a bit more details. The area under the ROC curve was maximum for combined procalcitonin and OI, closely followed by OI, then by procalcitonin, and lastly by CRP. At a cutoff of 2.56 nanogram per ml, procalcitonin had a sensitivity of 90% and a specificity of 52%. At a cutoff of 90 milligrams per liter, CRP had a sensitivity and specificity of 60 and 65% respectively. OI at a cutoff of 9.3 had a sensitivity of 60% and specificity of 91%. Combined procalcitonin and OI had a fairly acceptable sensitivity and specificity of 60% and 91% respectively. The outcomes were studied in terms of MODS, mortality, and number of ventilation days. On comparing the VAP and the non-VAP group, the percentages of MODS mortality was significantly higher, but the p-values were not significant. The ventilation days was also higher in the VAP category as compared to the non-VAP. Similarly, on comparing early and late VAP, MODS mortality and ventilation days were higher in the late VAP group, but the p-values were not significant. Now, our study was compared with various other studies done from different parts of the world, one being from PC Roy, one from AIMS New Delhi, the others from Switzerland and Italy. The incidence of VAP in our study was 46%, while the others reported an incidence ranging from 36 to 47%. The common organism profile found in other Indian studies corroborated with our findings as well. On using procalcitonin as a biomarker, we found at a cutoff of 2.56 nanogram per ml, the area under the curve was 68.3%, while in the study by Cotter et al., they found at a cutoff of 0.97, area under the curve was 71%. Hence, concluding, multi-drug resistant Acinetobacter is the most common organism. There is no significant difference in mods, number of ventilation days and mortality in the VAP and non-VAP group. Procalcitonin is a good biomarker for screening of VAP. Combined procalcitonin and OI is a better marker for diagnosis of VAP. Certain limitations of the study were the sample size was small, anaerobic culture and fungal culture could not be done, serial measurements of biomarkers need to be studied further. Thank you.
Okay, thank you for your nice presentations. Tell me, in which way you collected the samples for culture?
So we took the sample by the mini bell technique. It's a non-bronchoscopic method of collection. We used a 12 French suction catheter which was inserted, wedged till resistance is felt. Then amount of saline was instilled based upon the body weight of the patient and it was aspirated back.
You got so many cases of positive.
Yes, sir. We found about 60% to be culture positive.
Did they respond? All culture positive responded to the sensitive antibiotics?
So in our setting, the most common organism was multi-drug resistant Acinetobacter having only intermediate sensitivity to colistin and imipenem. So we used mostly these antibiotics. In case those who were not responding, we empirically added antifungals as well because we couldn't do fungal culture.
So what is the clinical implication of your study?
And the clinical implication is that by using the modified CPIS score and using these biomarkers...
Don't you think this is a quite old score? What is the newer...
Yes, madam, certain newer scores like V plus score is also available, but that is dependent on lung USG, which becomes very subjective and observer dependent. The results would not have been reproducible. So we used this score so that we could objectify our results. And we tried to mainly study the biomarkers like oxygenation index, worsening of the required...
Clinical implication?
Madam, we can pick up VAP early and maybe while doing this study as we can know about the organism profile.
How you can pick up early from this?
By using the biomarkers like procalcitonin, which was being sent on day 3, we found that it had a sensitivity of about 90%, which is a good, so it becomes a good screening tool.
So don't you think you should have taken some newer, rather than taking the VAP, classifying it as a VAP, what are the newer terminologies used for the VAP? What is ventilator-associated event and condition?
Yes, madam, ventilator-associated event is when there is increase in FiO2 more than equal to 25% or increase in MAP more than equal to 4 for sustained for two consecutive days. That is ventilator-associated event.
So I think maybe this should have been a better classification rather than this old study.
I have got only 2-second question. Your p-value is very much significant,
yes,
but
sir.
area under the curve only 68. Do you have any explanation?
So maybe the sample size is small for us, so...
No, sample size is not responsible for area under the curve. So anyway, next speaker.
Dr. Aditya Haldar.
Hello, very good morning everyone and respected judges. I am Dr. Aditya Haldar from Kolkata National Medical College. Now I am presenting my study that is transcranial Doppler and optic nerve sheath diameter measurement and its correlations with clinical outcome in suspected raised intracranial tension among children in tertiary care center, a prospective observational cohort study. Here is the agenda for my today's presentations. As we all know that managing intracranial tension in pediatric age group has challenging because of developing veins and its vulnerability, and interventricular transducial catheter is the gold standard, but it has has its own complications. So non-invasive method like transcranial Doppler on middle cerebral artery with flow velocity measurement and optic nerve sheath diameter measurement has a valuable real-time parameters for monitoring, and research is ongoing to validate this, and aims of the study to utility of TCD and ONSD in detection, early monitoring, and prognostications of pediatric ICT. Evidence support that point of care ultrasound based measurement of TCD and ICT values, ONSD values are a significant assessment tool for emergency and critical care settings. I would like to tell something about transcranial Doppler. Was first reported in 1982. It is measured with a low frequency probe that is 0.5 to 3 megahertz and relatively thin part of the bone like temporal bone. Here image showing some part where we can assess the TCD, and TCD measured with flow velocity using a Doppler shift formula, and we have measured pulsatility index, that is systolic velocity minus diastolic velocity by mean velocity, and resistance index, that is systolic velocity minus diastolic velocity by systolic velocity, and the measurement was taken PI as 0.92 plus minus 41 as increased, and RI is 0.56 plus minus 13 as increased. Here is the image showing that measured PI and RI value on MCA, and in optic nerve sheath diameter was measured with liner probe 3 to 12 megahertz in supine positions, and it is measured 3 millimeter posterior to the globe where the optic nerve is entering, and the value is taken as 4.21 plus minus 0.66 millimeter. Here is the image of some measured ONSD, and in our study we have measured the TCD and ONSD value at the time of PICU admissions after 12 hours and after 48 hours, and using this data to evaluate the outcome and severity of neurological damage. Aims of my study was to monitor raised intracranial tensions by using non-invasive method like TCD and ONSD and assess the clinical outcome. This study was conducted at Pediatric Intensive Care Unit at CNMCH, aged between 1 to 12 years of age, after obtaining ethical clearance and informed consent. So data collection was done by sex age, presenting complaint and durations of illness, and clinical assessment was done by GCS, pupil, CNS examination, arterial blood gas, cerebrospinal fluid, and radiological findings, and ultrasound based measures were done by TCD and ONSD, and children were divided into two groups, group 1 for significant USG findings and group B for no significant USG findings, and study design was over a period of 1 year. So along the 50 children, my inclusion criteria was suspected raised intracranial tension, no active convulsion during the procedure, stable vitals, and reactive pupils. Exclusion criteria was active scalp infections, no scalp injury, congenital CNS anomalies, neonates, and children with hydrocephalus. So some procedures was done during the studies, and scoring parameters are mainly for GCS and modifications of GCS for younger children, and outcome was measured on the parameters by hospital stay and final outcome on discharge and death, and analysis was done on the basis of outcome difference between group A and group B. So here is my some result. We have seen that this pie chart showing the child presenting with seizures have more prone to become positive in TCD and ONSD, and we have seen that frequency polygon showing that children presented with unilateral or bilateral fixed dilated pupil has a higher chance of severe brain injury, GCS score having 3 to 8. This graphical representation showing that if those child having radiological findings have been positive for USG, and children having increased cell count in cerebrospinal fluid have higher chances to become positive in TCD. So this statistical table and contingency table analysis that measurement of TCD PI value at 12 hours after admission at PICU have an P value of 0.005, which is statistically significant, and we can say that elevated value of TCD PI at 12 hours of PICU admission is associated with longer hospital stay, as PI RI value or resistance index value also have a statistical significant with P value of 0.005, and it is also elevated value of RI associated with longer hospital stay, and ONSD also shows the same significant associations and a P value of 0.005 at 12-hour measurement of elevated ONSD associated with longer hospital stay, and we have measured the value after 48 hours, and that is also we have got the statistically significant value, P value of less than 0.001, which is strongly associated of increased PI at 48 hours being associated with higher mortality. RI value is also statistically significant, and it is also P value of 0.001, and it is also increased being associated with higher mortality rate. ONSD also shows the same, and ONSD also statistical value of P value of 0.008, and with increased ONSD at 48 hours being associated with higher mortality rate. I would like to discuss something about that. As said by Harold Bode at 1989, the transcranial Doppler ultrasonography is valuable valuable diagnostic tool in pediatric neurology. And in 2008, Chaira Rova et al. Termed that transcranial Doppler stethoscope for brain, and it has serves a versatile and reliable tool in neurocritical care. In our study, we also have found that TCD, PI, pulsatility index, and resistive index have a very statistical significant in respect to hospital stay and discharge, that is death. And in conclusion, we would like to say that this study reinforced the importance of integrating TCD and ONST into routine PICU monitoring protocol, and this technique can enhance early detection, continuous monitoring, and effective treatment, ultimately improving outcome for affected children. And despite of bring promising results, severe limitations should be acknowledged, that is sample size, single center study, longitudinal follow-up, and validations of study, large-scale studies needed to confirm the diagnosis, and technological advancement and clinical guideline, establishing evidence-based clinical guideline for TCD and ONST. Here are some of my reference. Thank you for your attention.
Okay, good presentations, good topic also. But have you compared the outcome with the detection methods? You compared only the things present already.
Yes,
but the course of management, does it help? You have not compared with the course of management in that.
Yes, sir. I actually measured with the clinical outcome and prognostications.
Who was doing those ultrasonologist or intensivist?
No, sir. Actually, one radiology professor has come and learned us, and my mentor, Dr. Rupa Vishwas, she was also a radiologist, so she has always guided me for this my study.
What was your golden standard with which you were comparing?
Sir, actually there is no such values. So one study was done in 2022 by Sarawat and all with PGI Chandigarh, and we have just taken their standard value to evaluate our study.
Yeah, nice thought and nice presentation. And your PI is, in one slide I have seen the degree of freedom is 3 and chi-square is significant, p-value is significant.
Yes, sir.
And your this optic sheath diameter,
yes, sir,
is degree of freedom 1 and PI versus optic sheath. So there is correlation is not that anticipated.
Yes, sir. Actually, I haven't anticipated between these parameters. So individually, I have compared with the outcome.
Anyway, it's good.
Thank you. Thank you for your attention. Last of all, I would like to say this use of this machine can bring some cute smile. So thank you.
Thank you to all the delegates and also to our esteemed panel of judges for giving us their valuable time. Before we move on to our next talk, I'd like to request Dr. Pradeep Kumar Jena sir and Dr. Joydeep Das sir to kindly step out to receive your mementos, sir, and for the felicitation. Ma'am has a session here later in this room also. The felicitation corner is outside. Thank you very much for your time. We'll now be running a talk by Professor Arun Bansal, a man who obviously needs no introduction. He's a professor at PGI Chandigarh and an emeritus professor at the Pediatric Intensive Care College.
Good morning, everyone. I thank the West Bengal Academy of Pediatrics and Dr. Sarkar for giving me an opportunity to speak on multimodal neuroimmunology. start with a case. This is Master R, who is a 6-year-old boy with a very acute history of fever and headache, followed by sensorial and abnormal movements since last month. His fever was intermittent, low to moderate grade. His headache was throbbing and generalized. And on the day prior to presentation, he had lethargy, decreased fluid intake, and became somnolent. And just prior to presentation, he had few episodes of abnormal posturing which lasted for 2 to 3 minutes. There was extension of all the limbs with abnormal uprolling of items. But there was no history of any URI symptoms, no GI symptoms. There was no history of decreased appetite or loss of weight. There was no jaundice or any contact with tuberculosis, and there was no animal bite or history of recent vaccination. The past, the birth, the development, immunization, and the family history were non-significant. On the primary assessment in ER, his airway was open and stable. He was breathing at 25 beats per minute with normal efforts and had saturated at 99% in good health. He had bradycardia and high blood pressure. The pulses peripheral and central were good volume. It was warm on touch. ECG was normal. At low GCS, 9/15, pupils were equal but sluggishly reacting. The motor activity was classic and sugars were normal. The temperature was 39 degrees Celsius and there were no other any skin markers present. He was classified as primary brain dysfunction with level 2 emerging. On detailed neurological examination, there were no evidence of cranial nerve palsy. He had decreased power but tone was increased. The DTRs were brisk and planters were upwing. There were no meningeal or cerebellar signs. The respiratory, abdominal and CVL systems were normal. So immediately he was intubated. He was started on first higher neuroprotective measures. As a pseudo-anesthesia, midazolam and fentanyl were added. To control the seizures, he was loaded with phenytoin followed by levetiracetam. As in hyperosmolar therapy, we use 3% hypertonic saline as a bolus followed by infusion to control these episodes of dizziness. So his primary diagnosis was acute meningoencephalitis, state epilepticus with dizziness. The aim of the management in this case was to maintain optimal hemodynamic and respiratory support, to ensure his oxygenation is adequate and he is adequately perfused in the brain. We wanted to break his raised ICP and cerebral edema cycle and his compromised cerebral blood flow at the earliest. And also in that while we wanted to maintain adequate cerebral perfusion pressure. So if we go to the physiology of the brain, so we all know what non-pulmonary doctrine is, which is basically an increased cranial pressure exerted by the brain, the blood and the CSF. The brain constitutes the main component, but 10% each of blood and CSF plays a role in that. Any disturbance in any one of these three components can result in decreasing in the volume of the other two. But once the limit of compensation gets exceeded, raised ICP rises. Open continents which are present in infants or in open sutures, they are not protective and they may also be associated with pathological increase in ICPs. That has to be noted. So if you see this diagram, you will see on the left hand side that the body tries to compensate when there is any disturbance or increase in the volume inside the brain. But after a certain level, this compensating mechanism gives way and the ICP rises significantly given with very minimal changes of the volume inside the brain once the autoregulation is lost. So what is autoregulation? Basically, it is the cerebral blood flow is usually maintained constant over a wide range of mean arterial pressures. On the right hand side, if you see the this diagram, you will see that the pressures, the cerebral blood flow is usually maintained between 50 to 150 millimeters of mercury. But if it falls below 50, the vessels dilate, the cerebral vessels dilate and try to provide more blood to the brain. And MAP increases above 150, the vessels try to constrict, get vasoconstricted and try to restrict the blood to the brain. So, but as it increases beyond this 50 or 150, this autoregulation mechanism is lost, and then there is a direct proportionate between the MAP and the blood flow. What are the normal values of raised ICP? It ranges between 5 to 15 millimeters of mercury, but in infants, newborns and younger children to older children, it gradually increases from around 1 to 6 millimeter to 10 to 15 over a period of few years. But what are the other thresholds for treatment? So we label ICP anything about 20 as intracranial hypertension. If you are not able to measure it, any signs and symptoms of raised ICP, if they are present, we assume that the ICP is about 20. And if a child has sustained ICP more than 40 millimeter of mercury, that is indicative of severe life-threatening raised ICP. What is cerebral perfusion pressure? It's the pressure at which the brain is perfused. So basically, it's an indirect surrogate marker of the cerebral blood flow. So cerebral perfusion pressure of the is basically the difference between the mean arterial pressure and the intracranial pressure. We don't have the exact values for the different ages of the children, but what we know is that we have to target somewhere above 40 to 50 in infants and toddlers and more than 50 to 60 in children. Anything below 40 is associated with mortality. So coming back to our case, this child continued to have multiple episodes of seizure. He was started on midazolam infusion, which was high to 30 mics per kg per minute, and then required phenobarbital coma, leprosamide, and was shifted to ICU. So when we were shifted to ICU, the monitoring of raised ICP in ICU becomes very important. What are the various methods in which we can monitor the ICP? It is invasive and non-invasive. Invasive is the gold.
We apologize sincerely for the mix-up and slightly time delay. We'd like to extend our gratitude to Professor Arun Bansal sir for giving us his valuable time and taking the time out to record this message for us. And also to Dr. Shankar Das sir, who took out his valuable time to chair this session. I'd like to request sir to please step out for the felicitation. We'd now like to move on to our second panel, which is an acute encephalitis syndrome beyond infection. This panel will be moderated by Dr. Somnath Gorai. Dr. Somnath Gorai is a consultant pediatric intensivist and PICU in charge at Bhagirathi Neotia, Newtown, Kolkata. This panel will also be moderated by respected Dr. Kalpana Datta ma'am, who is professor in HOD Pediatrics, Medical College, Kolkata. And this panel will have panelists, Dr. Jashodhara Chaudhary ma'am, who is a pediatric neurologist at NRS Medical College and Hospital. Dr. Manas Mahapatra, who is Assistant Professor of Pediatrics at JIMS. Dr. Shaili Das Gupta, who is a pediatric intensivist at Peerless Hospital, Kolkata. And Dr. Ratan Kumar, who is a pediatric intensivist at the Tata Main Hospital, Jamshedpur. I request our moderator and chairpersons to kindly take their place on the dais, please. I request all the panelists to take their place on the dais.
Okay, good morning. Good morning, everyone, and thanks the East Zone Pedicriticon team for inviting me and letting me be the chair of this important session, acute encephalitis syndrome, which is a umbrella term that coined by WHO, and now it contains many diseases and mimickers of acute encephalitis syndromes are there, and it will be moderated by Dr. Somnath Gorai. I think without wasting time, please start your session with the panelists.
Thank you, ma'am. Thank you all audience and my panelists. So today we are going to discuss a bit about acute encephalitis syndrome. I'll go through a case and we'll take up a few questions which are the common challenges we'll face during this. Before going into the my case, just a few slides regarding acute encephalitis. So acute encephalitis syndrome by WHO, they defined as any inflammation of brain caused by infection or host immune response. And pathologically, it is typically inflammatory infiltrates in the brain parenchyma surrounding the blood vessels. But in 2013, one acute encephalitis, the diagnosis of acute encephalitis, that case definition was given by International Encephalitis Consortium. They showed that one major criteria, that is encephalopathy or altered mental status more than 24 hours, has to be there, along with some minor criteria as explained here. Two minor criteria if present, then it is possible acute encephalitis, and if it is more than three minor criteria are there, it is probable encephalitis. In 2017, one write-up was came in Indian Journal of Medical Research. They conclude that AES the use of AES term must be avoided. So again, there is a confusion. So whether we can use acute encephalitis or acute encephalitis syndrome, because acute encephalitis syndrome is a umbrella term for all brain pathology, and probably we should avoid using this term. Now, incidences of acute encephalitis. So globally, it is 3.5 to 7.54 per 1 lakh patient years. And incidence in India is around 4.2 per 1 lakh population per annum. So what are the causes of acute encephalitis? We can divide it grossly at infective and non-infective causes. So infective causes we all know. Now among non-infective causes, autoimmune, vascularitis, edema, metabolic or toxic encephalopathy, drug-induced or mitochondrial diseases can be kept. So what are the incidents? And this is a very interesting slide because there are so many studies I put up here. You can see that diagnosis came only 23%, 37%, maximum diagnosis we get here 65%. So overall, up to 50% cases, there is no diagnosis. And then comes what is the common. Not only in India, you can see this paper, also they, in US children, the clinical settings and etiology identified around roughly 50% cases of encephalitis in children. Of unexplained cases, more than 60% lack of identifiable causes with comprehensive research testing. So almost 50 to 60% cases, we do not know what is the diagnosis. So what is the most common cause? So it is infective or non-infective? Probably non-infective causes are more common because nowadays we have panel, so we can see almost all infection we can see with CSF PCR, and even acute encephalitis, autoimmune encephalitis, for that also we have panel. But again, if it is negative, then probably seronegative autoimmune encephalitis we are dealing with. So keeping that in mind, let us go through these cases. This is a 13 years old female presented with abnormal movement of all 4 limbs, probably generalized colic seizure and altered sensorium. History of fever since 4 days, agitation during the same duration. Also, she has history of decreased interaction and some sort of child become depressed or aloof in last 1 month. Parents has noticed. Developmental history was normal. There is no past significant history, and immunization as per age. So when child lands up in year, how to go ahead? Dr. Ratan, can you please?
So in emergency, we usually do for all sick children, initial assessment, then primary assessment, secondary survey, like that. So for initial assessment, we used to see, it is done very rapidly and even without touching the child. You can look at the child and you can have initial assessment impression. So we used to see ABC, air appearance. It is not airway breathing circulation. It is appearance, work of breathing and circulation. So in appearance is actually synonymous with central nervous system assessment, breathing with respiratory, and circulation. We used to see the circulation to skin, which is actually represents the cardiovascular. So in appearance, the mnemonic is tickle, that is tone. We used to see the position of the child, whether looking flaccid or is having some flexion in the limbs. And then is the child interacting? Is he or she following a bright object, having eye contact? Then consolability and look and gaze. Then speech, whether the child is having age-appropriate speech or cry, strong cry. Then breathing, we used to see any abnormal breath sound or features of respiratory distress, like abnormal head bobbing, retractions, nasal flaring, or is the child gasping, or what is the position the child is taking to have a comfortable or better air entry. So that will lead to us to the diagnosis whether child is in respiratory failure or. And then we used to evaluate the circulation to skin just by seeing the skin color, and that is either maybe cyanosed, mottled, or pale. So this initial assessment is done in emergency rapidly without even touching the child. And then we do a little detailed primary assessment in which A, B, C, D, E is airway, breathing, circulation, disability and exposure. So in this child we can see saturation is 88%, so there is poor oxygenation, but bilateral chest was clear. In circulation there is tachycardia, little tachycardia, and then in airway, as I forgot, neck position was done, started on oxygen and initial suctioning was done, and because saturation was low. In disability, the child was actively convulsing, so injection lorazepam was given. GCS was low, 7, so we understand that child needs intubation and securing the airway. Blood glucose was 148, and exposure, no external or injury or temperature was normal. So initial stabilization in emergency.
Yeah, so basically we should follow always pulse protocol for any sick child, and accordingly, as Dr. Ratan says, that we should go ahead and stabilize the child. So here we stabilize the child. Airway breathing circulation was monitored, and ECG monitoring, oxygen therapy was given. After lorazepam, convulsion was a bit controlled, but that blood gas shows that high carbon dioxide, and rest of the reports are almost normal. Lactate was normal. So from initial impression, what is our initial impression? So probably child is in febrile status with respiratory failure because CO2 is quite high and saturation is low. So what are the causes? Our differential diagnosis can be acute infection or acute infectious encephalitis, can be autoimmune encephalitis or non-infectious causes, some central nervous system vasculitis, or some even you can consider toxins also here. So after initial stabilization, due to worsening GCS, child was intubated and appropriate measures were taken. So what are the measures to be taken prior to the intubation? Dr. Saili, can you just elaborate?
Yes. So here the child was convulsing, so we have to keep in mind the child might have a raised intracranial pressure. So while planning for intubation, I need a team. I should keep a senior person also, and it is preferable to give a 3% saline infusion before intubating the patient. Now coming to intubation of the patient, we should go, the positioning is very important. The sitting position should be done. We should avoid either hyperextension or hyperflexion of the neck, because in any case that can increase the intracranial pressure. Now we have to pre-oxygenate, and in this case rapid sequence intubation is required. Regarding rapid sequence intubation, we need a sedation and a muscle relaxant. Now coming to the pre-medication, we can give glycopyrrolate. Sedation, we have a battery of drugs. We can there is etomidate, ketamine, midazolam. It was a myth previously that ketamine should be avoided in a child who is having a convulsion or where there is a chance of raised intracranial tension, but the recent studies have shown that ketamine actually increases the cerebral perfusion pressure. So in this case, I would like to intubate the child with a small dose of midazolam, 1 mg per kg, and with ketamine 1 to 2 mg per kg, along with glycopyrrolate. Sedation is gone. Coming to the neuromuscular blockade, I can give rocuronium because this is very short acting. So by rapid sequence intubation in children, it has been seen a success rate of 52% and a complication rate of 61% can be achieved.
So Dr. Manas, please tell us regarding what are the measures we can take regarding raised ICT?
So in child who admitted with acute encephalitis syndrome or acute CNS insult that manifested at seizure, altered sensorium, so we have to suspect raised intracranial tension in the children, and prevention of and management of raised intracranial tension is the crucial part of neurocritical ICU. So starting with general measures like putting the head end elevated at 30 degree, keep the head at midline, that is important. So we have to maintain the temperature. So fever to be treated with paracetamol aggressively. We have to maintain normal blood pressure to be maintained at normal, preferably above 50th centile to our heart side. That will help to maintain the cerebral perfusion pressure. We have to maintain the blood sugar to be in the normal range, that is hypoglycemia and hyperglycemia. Here the cut-off upper limit of sugar is 180 milligram per DL. So that to be prevented, preferably our target sugar is within 80 to 160. We have to keep in this range, so that we have to maintain. So now we should not expect the bradycardia, hypertension, and irregular respiration. That is the crushing triad for the impending herniation. So this is the late phase. So initial phase, the altered sensorium, that is enough to suspect the raised ICP, and we should not wait to get the report for ophthalmological checkup, that is like papilledema or optic nerve sheath diameter. We have to wait for that. So we should not waste time. So the general measures have to be started very early. Regarding pharmacotherapy, drugs between mannitol and 3% NaCl, both can be given. Both are comparable in efficacy in reducing raised ICP. However, we have to be cautious before giving mannitol, because mannitol can cause fluid overload. So if the child is having associated cardiovascular instability or cardiac problem or having anuria, oliguria, in this case, or hypotension, we should avoid mannitol. Mannitol itself, it can cause diuresis and can aggravate the situation. So here 3% NaCl is very important. So even for mannitol also, we have to be cautious so that the osmolarity should not raise more than 320. For 3% NaCl, it is safest, and it can also decrease the brain inflammation. So we have to increase the sodium bit up to 145 to 155 range. We can go up to 160 range. So 3% NaCl is safer. If there is acute ICP surge, then bolus of 5 ml per 3 to 5 ml per kg 3% NaCl can be given over 1 hour, followed by infusion to be given. Now regarding ventilatory management, optimum ventilation is needed, of which maintaining normal oxygenation, that is keeping the PCO2 level above 60 and saturation above 95 is also the cornerstone in the neurocritical care. Adequate ventilation is important. Our target is to keep PCO2 level around 35, that is below 40. It should not cross over 40. Now if there is acute surge in ICP, or impending herniation, acute reduction of ICP to be done, or if there is pupil asymmetry, that also indicates uncal herniation. So acutely we have to reduce the ICP in very short time. The measures we can take, apart from giving bolus 3% NaCl or mannitol, ventilation, that is short-term controlled manual hyperventilation for over 10 to 15 minutes. In an attempt to reduce the PCO2 above below 32 or around 30 to 32. So these are the primary and basic first aid management. Apart from this, seizure control, adequate seizure control is important, because child following status epilepticus protocol. So if child is not responding in this management, we have to go the next stage, that is decompressive kinetomy or barbiturate coma, or therapeutic hypothermia can be given, or therapeutic lumbar punctures. All those are the next step of management. So the extent up to which a child is needed, it depends on clinical assessment and case-to-case basis.
Yeah, so thank you. So basically 3% NaCl or mannitol you should start, and controlled ventilation is very important. We cannot just make the carbon dioxide so low that cerebral perfusion goes down, or vice versa. I cannot. So this is a very bedside. You should sit there and monitor ATCO2 and in between blood gas also. But if neurosurgeons came in scenario, they'll invariably start mannitol, whether you start 3% NaCl or not. So this is a separate discussion. So in our case, we'll suspected etiologies, antimicrobial also started, antiviral, antibacterial, and doxycycline was started. And regarding selection of AED, so after giving lorazepam, we should, child was still convulsing, so we should go for second tier and third tier management. So what are the selection of AEDs? Dr. Jasodhara, can you just elaborate?
Yes, before mentioning that, one thing now it has come, if in a bigger child, like the 13-year-old child, if she comes to the ER and we cannot find an access, now there is a Rampart trial where it is said that you give IM midazolam. That is more superior than a delayed finding of access.
If you're going to, I think many residents are there, it is not AED, it is anti-seizure medication. It should be anti-seizure medication, not
anti-seizure medication.
Because many residents are there, so you should write it anti-seizure medications, not the AED.
Now it is called anti-seizure medication because it does not affect the mechanism, but just controls the seizure. So that is what. So Rampart trial in Lancet, it was published that in a large child, you can give 10 mg IM midazolam, and that acts superiorly than a delayed finding of an IV access. So for the status epilepticus, as we know, there is a protocol. After the IV lorazepam and or the diazepam, we start with fosphenytoin or levetiracetam or valproic acid. Now we have to judge the case. For example, if you are seeing a fires or a fever-associated refractory epilepsy, there may be a possibility of SCN mutation underlying, so it's better to avoid phenytoin there. Then it's better to use levetiracetam. If you are suspecting something metabolic or mitochondrial, then it is always better to avoid valproic acid because that will lead to worsening in this child.
And phenobarbital, if there is no ventilatory support, then it is again better to avoid that. So it will depend case to case basis. Then we start with the long-acting anti-seizure medications, and after that it is not controlled. Then we go to the infusion. Then again we need to have a ventilatory backup and start the infusion and increase the infusion in a slow rate. And then again, as Dr. Shaili said, that we can add IV ketamine when the midazolam dose reaches about 1.6 milligram per kg per hour, because it's necessary then. And then intubation is mandatory, and a continuous EEG monitoring at least 1 hour, because we need to know whether we are achieving the target or in the EEG monitor. Again, if it is not controlled even then we give the anesthetics. Start with the anesthetics. We can start with pentobarbital. There are trials with isoflurane. And apart from that, we can start the adjuvants like pyridoxine, if not added, especially in a very smaller child. Immunotherapy, in the suspicion of autoimmune encephalitis, and ketogenic diet, which recently a very good paper came up, ICU application of ketogenic diet. In some patients it works really well. So these are the options, and then even if it is not controlled, we say it's the super refractory status. Recently we had VNS is coming up, the dietary approaches are coming up, and other monitoring like the surgical methods are now coming up. So this is very short, the management and this thing.
Yeah, thank you. So basically the second line drug, anything we can use, but this study came up, it shows that probably we should avoid phenytoin, and other drugs, either valproate or levetiracetam or phenobarbital, can be used. So in our case, the basic blood came, that blood reports that CRP and procal was almost normal. Procal was 1.2, CRP 0.63, blood culture later on came no growth, and urine was also normal. Slightly high SGOT, SGOT, and other reports are completely normal. So after initial stabilization, we, because MRI will take time and we do not have MRI, so we go for CT scan. And CT brain shows no abnormality, no midline shift. So after doing CT, we go for CSF study. CSF shows 12 to 15 cells, around leukocyte 80% polymorph, with protein was high, 154. Sugar was 94, concurrent CPG was 106, and culture was negative. And we sent viral panel also, that CSF PCR, which was negative. Autoimmune panel we'll send, but it came negative later on. It takes 7 days time. So we stabilized the child with inotropes, 3% sodium chloride, mannitol was also added later, and blood pressure was maintained. So regarding EEG and MRI, so continuous EEG monitoring, as we explained. Now whether EEG will help us to diagnose anything, or EEG monitoring is just a supportive investigations during the course of the management. Dr. Jasodha,
yes,
can you
EEG is
elaborate?
essential, and all ICU specialists should know the EEG, when to do and how to read. Especially now it is mandatory to have at least 1 hour EEG recording. Why? Because non-convulsive status epilepticus, even if you do not see the seizures, it needs to be controlled, otherwise the patient will worsen and it is not. So that is very important. NCAC, I am not going into details, there are even criteria to see the Salzburg criteria, what kind of NCAC it's happening, and where, what is the prognostic value. Then again, the response to treatment. And also, it's very important to determine the etiology, because I have seen from practical experience, the MRI is negative, but we are getting PLEDs, that is periodic lateralized discharges, which is very characteristic of HSV. Again, extreme of delta burst pattern, which is rare, but if we see the EEG regularly, it is seen in autoimmune encephalitis, and that is a normal finding in neonatal EEG, the delta burst pattern. So we have to see this, and the therapeutic target. For example, the burst pattern, the suppression pattern, we often, after giving this, especially the IV anesthetics, we see the EEG recordings and see whether we have achieved the goal. And as we see the generalized periodic discharges, this depends with the prognosis. And quantitative EEG is a new term, because we know AI is now infiltrating all parts of medicine, and soon an AI knowing doctor will replace the older doctor, maybe, possibly, if not AI. So quant EEG is the thing that machine learning, so it just deciphers the EEG readings and from which part of the brain it's coming, and gives you the information overall. So it becomes very easy for the doctor to know which part of the brain is more affected than the others. So it's a visual thing.
So these are the important things. Apart from that, many details are there.
So later on we did MRI, and MRI shows T2 flare hyperintensity. So slightly regarding MRI.
So MRI is also very important, and another very important thing we are now finding, and it's been proven in literature, HSV, as we know, is a very common thing that leads to autoimmune encephalitis, and we are seeing so many HSV encephalitis in our ICUs, government as well as private setups. So we are saying when a child is having HSV, if the child is having contrast chiral enhancement, that child is more prone towards getting autoimmune encephalitis. This has been said in literature also, so we can almost predict. And the telltale markers of autoimmune encephalitis, we should see the basal ganglia if there is any hyperintensity. We should see the temporal lobes as well, because temporal lobe is affected in HSV, but in HSV it's more or less asymmetrical. Or in the autoimmune encephalitis, we see the basal ganglia, the external capsule is affected, that is called the claustrum sign. So there are few signs, and also, but the HSV and the autoimmune encephalitis may be mimicking. Another very important thing has come up. Recently a doctor's child also came up. If it is MRI negative, PET scan is an important modality now, and there are scoring systems. So if we do not find anything and we have the ability to do everything in such an institute, PET scan can be done now to detect.
Yeah. So EEG, MRI, and later on if needed, PET scan is needed, because many of the times we get MRI is normal, but in our case we had some findings. So so our provisional diagnosis is autoimmune encephalitis probably. So we, after ruling out possible infection, we given IV immunoglobulin. Pulse therapy of methylpred was started along with that. And we saw a significant response in first line therapy in 1 to 2 weeks. So how to approach in further management and different in the first line treatment? Dr. Ratan Kumar?
So well, there is various institutes have different policies based on the disease severity and also age of child. Because we have as first line therapy the various options, like either we can start with pulse methylprednisolone or methylprednisolone plus IVIG, or IVIG alone, or plasmapheresis. Now it has been mentioned even in in cases of like severe encephalopathy, it is preferable to give dual therapy or upfront plasmapheresis. Then there are also other considerations, like suppose you have a adolescent child whose weight is around 50 kg. If you go for the cost effectiveness, definitely plasmapheresis will cost less in this child compared to IVIG, which may be a 100 gram a good volume also. So either monotherapy or combination this, or then if one fails, then second line, then the other drug of first line can be, these all are the options. So the cornerstone is immunosuppressive therapy, and the options high-dose steroid, IVIG, or combination, or plasmapheresis.
So basically, the practical issue is that plasmapheresis will take big things. I mean, it needed access, needed machine, needed expertise. So for practical purpose, usually you go for IVIG plus methylprednisolone, because plasmapheresis has, again, strict monitoring is needed. Sometimes we have lost one child during plasmapheresis because sudden onset cardiac arrest. Recent happened in one case. So that's why plaques was second option for practical purpose, but study shows that plaques plus steroid have better outcome than either alone, so dual therapy. But there is no RCT plaques versus IVIG or plaques versus steroid. So practical purpose, usually we start with IVIG and methylprednisolone. If not responded, then probably you'll go for plaques.
So
what are the next management options?
Yeah. So then after the first line, which as I told, plasmapheresis or IVIG or combination, or then if, or one followed by the other. Like in many cases, the intensivist and neurologist even choose to do whenever they feel that the case is having severe encephalopathy, rapid onset, and bad prognosis, probable bad prognosis. Even they do upfront plasmapheresis followed by immunotherapy considering that although there is this like almost 15 kilodalton above the molecular weight of than 15 kilodalton will be removed by plasmapheresis. So IVIG components can also be removed by it. So whenever they suspect that we will have to go for another therapy, do plasmapheresis upfront followed by IVIG, and then suppose you have done given IVIG in a steroid first, then also you can do the plasmapheresis after this. If it fails, if there is no good recovery, signs of recovery in after completing this, even you can wait for 5 days. And then after this, the second line therapy are other immunomodulators like rituximab, cyclophosphamide, or in refractory cases or relapsing cases. And if that also doesn't work, then third line therapy includes various antibodies.
So we'll discuss in second line management. So what are the second line management, and what is the common practical things you should keep in mind before starting rituximab? Dr. Saili, can you explain?
Yes, the non-responders are treated with rituximab or cyclophosphamide, but we should use it very wisely. Before starting rituximab, we should test whether there is any infection like TB, HIV, or hepatitis B. Rituximab is a monoclonal antibody against CD20 that causes B cell depletion, and which ultimately leads to reduction of the CD4 and CD8 T cell receptor responses. So the B cell measurement should be done 2 to 4 weeks after dosing to check for B cell depletion, and 3 to 6 monthly thereafter to check for the B cell repopulation. Now, coming to the cyclophosphamide, this is another alternative. These also have a broad immunosuppressive effects. Monthly intravenous infusion of around 500 to 1000 mg per meter square body surface area should be given for around 6 to 9 months.
Yes. So now coming to the third line management, we have options botulinuzumab, tocilizumab, or methotrexate. Dr. Jasudhara, can you just explain?
Yes, I'll explain by a practical example. We had a patient and who was refractory to rituximab. How to understand that? The CD1920 population was less than 1%, but the patient was not responding. As there were refractory seizures going on, movement disorders going on, the patient was having behavioral issues. So that time we wrote to Dr. Dalama, who has actually has got these position papers on autoimmune encephalitis. And then he said that actually bortezomib, it is written in literature, but on practical experience it is not working as well. So it is better to use in those cases cyclophosphamide in an increased dose, the monthly doses. This was his practical opinion. But theoretically, the third line management, they have given bortezomib, which is used in malignancies, tocilizumab, which was very popular in COVID infection. Yeah. Why? Because autoimmune encephalitis may increase the IL-6 values. So that is one option. And methotrexate, intrathecal, steroids. These are the options, but actually we never use this.
So anything about MMF?
MMF can be used well if the patient can afford, and azathioprine is very toxic drug. It leads to very much immunosuppression and neutrophil. Another important thing that we have to again re-emphasize, hepatitis B screening and tuberculosis screening throughout the treatment is very necessary, because we have seen flare-ups and patient coming with disseminated tuberculosis post-treatment of autoimmune encephalitis. So this is very important.
So basically long-term management can be needed. That is the crux of our discussion, and maintenance therapy and later on continuous monitoring with team approach is must.
And duration, actually there is a position paper now update. So duration they are saying it's 6 to 12 months. In the severe encephalitis 2020 there is an update. If you give steroids or MFF, it's 6 to 12 months.
So what are the further measures? So we need to give supportive treatment, which is very important for PICU purpose. So what are the supportive measurements we should keep in mind and we should maintain?
So whenever we are treating a child in pediatric intensive care unit, apart from treatment specific for the disease, other general supportive measures have to be taken care of, like stress ulcer prophylaxis, general care for general nursing care. That is, we have to ensure that is care of the oral cavity, prevention of exposure keratitis. So every day every shift we have to check for the pressure source. So that have to be prevented. We have to strictly follow the infection control measures, hand washing, and in 5 recommended conditions. And strictly we have to ensure the bundle care in the ICUs, that is VAP bundle for care for prevention of CLAVC or COTI. So these are very important. These will add to the comorbidities and will increase the hospitalization and cost of treatment, all those things. So other things, if the child needs prolonged ventilation, then tracheostomy have to be done to prevent the subglottic stenosis. And the most important part is the nutrition. So first thing is the child it's a child. They have very poor calorie reserve, and children have high basal metabolic rate. So calorie expenditure is more. Though we know in acute illness the calorie requirement is less, still because of this disadvantage in pediatric children's, so we have to maintain the nutrition or calorie. We have to give calorie above the basal calorie requirement to prevent the catabolism. And so we have to start feeding, preferably as early as possible, preferably within 24 hours. If there is no contraindications for GI, or if there is no hemodynamic instability, child is not needing a high ventilator support or high dose of inotropes, then we can start feeding using enteral route within 24 hours. And the choice of feeds could be the rice water, dal water, so liquids, or commercially available milk. We can start with that also.
So though it is a small slide, but I think for PICU purpose and to prevent mortality, we want to treat the child, that is fine, but to prevent mortality, this slide is most important. I think we should support it as a intensivist. We should keep everything in mind. Nutrition is very important for proper outcome, infection prevention, hand washing, and obviously if you're doing tracheostomy, needed proper tracheostomy care. So your nursing team should be trained with tracheostomy care and pressure sore prevention. And sometimes we need to use air mattress or special beds for them. And for nutrition, yes, enteral nutrition always preferred, but sometimes even child, there's severe refluxes there's vomiting. So sometimes for long-term treatment, we may need to put a PEG tube also. So what are the prognosis? What is your experience and regarding the prognosis and long-term management?
So it's very important because all parents will ask, and we need to know very clearly before counseling them. So prognosis depends on the subtype, because we know intracellular antibody-mediated autoimmune encephalitis associated with the malignancies, tumors. We have seen also, so recently in ICH, a patient presented with hyponatremia, a small child. So they are often associated with intracellular antibodies, and so they have a worse prognosis because these immunomodulators, say the steroids, IVIG, do not work well. Also the antigens mediated cell surface, they have a better prognosis. But however, we have to tell them the movement disorders and the behaviors, they persist for longer duration, even after therapy. But according to literature, 85% respond well, and the rest of the 15% of them, some do not respond and some take a very long time, for example, 2 years to respond well. So it's very important on the parents' part to have long-term patience, and the therapy need to be modified also.
Yes, so long-term treatment is necessary, and we should counsel them properly. Many of them needed repeated PICU hospitalization for pulse dose therapy, and even with other infections, they can land up in PICU. So regarding that part, we should explain properly. That is not a short-term disease. Child can go home, but you have to be very cautious for parents and needed long-term therapy. That counseling, and this should be clear. So what are the take-home message? So AES, though are rare overall, but needs prompt suspicion and treatment, because now we have management. Even if it is seronegative, we can start treatment as early as possible. Obviously, multidisciplinary approach is needed, not only PICU team, but your neuro, sometimes surgical, and your nursing team has to be very trained in treating such a long-term patients. Neuroprotection is very important. Although we are thinking, as I told, that only 50% cases we get diagnosis. Among them, though infection is common, but if you add this non-infectious part, so that probably autoimmune encephalitis is now one of the commonest cause of acute encephalitis syndrome. And long-term management is needed and proper counseling is very much necessary. Before ending my talk, this is one of the movie you can go through for residents. This is a Brain on Fire. This is a kind of autobiography written by Susanna Kalhan, her experience, and is one of the first diagnoses for autoimmune encephalitis, and is a very good movie. Thank you.
Thank you, Somnath, for having the comprehensive management of acute encephalitis syndrome. Coming to the question sessions. Actually, I would like to comment few things as you have discussed in then. So it's very important to identify the cause at the very outset, depending upon the geographical distribution, depending upon the season, and depending on the patient still. And as you already said, the initial assessment, that is trias, A, B, C, D, E. The exposure also to be considered as in the term of trias. Then, as Dr. Manus has said, the management of raised ICT, among which I want to add few things, that is the noxious stimulus should be avoided, painful stimulus should be avoided, patient should be kept in a euvolumic. And your patient had a 6.9 pH, and that should have been considered while managing the patient because acidosis was there. So these things also to be important as the part of management of anti-seizure medications. Then Dr. Jashodhara said about the herpes can mimic autoencephalitis. I want to add that it can cause also autoencephalitis. If the post-herpetic patient comes with the autoimmune encephalitis. And then the supportive management is quite important, as important to manage the specific cause. So nice discussion. Now it's open for the discussion from the audience. If you have any question, you can ask. Thank you.
Yes, I have got one question to the panel, that I encountered this kind of fever, convulsion, unconsciousness, and a myocarditis, and within 24 hours, it's not working. So within 24 hours, the central nervous system and heart. I was, as well as a serious infections, and patient party was very much anxious, parents are very much anxious. So my inner gut was compelling me to start a methylprednisolone because it will help, but within 24 hours without any investigation, I have started 10 milligram per kg, but patient died. So how early we can start, we can think of steroid plus biological when two organs are affected.
I think IVIG you should consider IVIG here for personal.
Yes, IVIG steroid plus biological probably the
IVIG
answer in such cases.
IVIG is one negative point here because we don't want to do fluid overload. And IVIG is the volume.
That we have to adjust accordingly.
One thing is very clear, when the multiple organs are involved, the brain and the heart.
Within 24 hours.
Yes, most probably it is viral.
Yes.
Most probably it is viral.
Yes.
It is viral because you have to consider the age also. What was the age of the patient?
Yes, age is just 2 years. 2 years and presentation is loose
So when a viral myocarditis leading to viral encephalitis, I don't think there is any role of steroid at first, because if there is something you are missing with the bacterial.
Because of myocarditis. Because of myocarditis.
IVIG has
myocarditis, so it is giving a clue that this could be a viral etiology.
Sir, exactly, that was a viral etiology, but if there is only autoimmune encephalitis suspicion, there is an AN, American Academy of Neurology, as well as AAP combined guideline. Do not wait for any results, but start with immunomodulators. And dual thing will be helpful more, as sir said, plasmapheresis plus corticosteroids, but it is not applicable in that patient who is having, of course, viral myocarditis most likely.
Plasmapheresis is very much intensive procedure, that is out from our window. So main thing is IVIG, steroid, and probably biologicals. So and it should be aggressive within 24 hours.
Exactly, because they said do not wait for any results.
Yes, patient will not die of AES, patient will die of myocarditis.
No, but how can you use biologicals without having the other investigations and all? IVIG you can use.
No, for that patient we cannot use. He is patient. No, not 24 hours, but such patient immunosuppressants won't apply because probably the patient died due to viral myocarditis, not due to brain.
Rightly said, American, they have a non-infective causes of encephalitis, and we are having maximum cases of the infective etiology. That's the difference between the other countries. No? So I think Dr. Ali will want to ask some questions.
I have very poor knowledge and understanding about this autoimmune encephalitis. So I am trying to understand. So basically, when the CSF, when the MRI or EEG is, everything is normal, but still we are labeling as autoimmune encephalitis. So I want to understand how, where we have proven the inflammation in the encephalogram. By brain biopsy, or is there any specific marker in blood or CSF from where we can say that there is an inflammation in the encephalon? So that is one question. So the available autoimmune antibody that is we are doing, that's most of the time that is coming out to be negative. So how we are sure that there is inflammation? Second is, what is the pathophysiology? It is a single hit model, or it is a multiple hit or continuous model of pathophysiology. So if it is a single hit model, like a predisposed, genetically predisposed individuals had a viral infection, then immunosystems work in a different way, and that leads to inflammations. Or it is a continuous model, like you have a tumor or you have autoimmune disease going on, that is giving you this continuous inflammations. Because if it is a single hit model, then if I wait, like I will give first steroid, IVIG, then we'll wait for plasmapheresis, then we'll give these biologicals and so on. So if it is a single hit model, then by natural course, the patient may improve without even any interventions. But if it is a multiple hit model or continuous hit model, and we are not able to identify what is going on, why it is happening, then what will be our end? The immunotherapy or the things, how many days we will continue? The years or month? That's I am trying to understand now. So please, if you can clarify.
So sir, regarding your first question, as per the latest defining criteria, we have classified the definition into possible, probable, and confirmed autoimmune encephalitis. So whenever you have clinical symptoms, just based on clinical symptoms, you can level it plus or minus paraclinical. Just based on clinical symptoms, you can level it as possible autoimmune encephalitis. Then after that, you proceed for various investigations, including imaging, antibody profile, and your other brain biopsy, and all these are much invasive. So if antibodies are positive, then you label it as confirmed autoimmune encephalitis. If that is negative and your paraclinical tests are suggestive, then then even it is negative, your first clinical was positive, even paraclinical is negative, you can label it as probable or seronegative autoimmune encephalitis. So it is so because you have to do early intervention, and the prognosis will change based on that, based on your timing of intervention, based on your.
Please use mic.
So patient is presenting with the acute encephalitis syndrome. So either we have the infective cause, we or either have a non-infective cause. So what else you are thinking? If you do not have the infective cause, and his patient is with coming with the organ dysfunction and severe or low GCS. So what is your other diagnosis? Suppose it's infective is ruled out. You have done the scanning, you have done the LP, you have done the facials. Infective is ruled out. So if it is not autoimmune, what is your diagnosis? Autoimmune encephalitis is recently been identified, last 20-25 years. So previously they were treated as without immunosuppression, and we know that the prognosis was not good. Now they have started. Suppose after down the line some third diagnosis also comes, then you can think at this point of time, if it is not infective, so what else do you have to do, right? So you cannot, either patient is going to die, or sometimes it may recover. So I don't know, but so far we have the evidence. Whatever evidence we have, it is for the treating aggressively if you can rule out the infective.
May recover, but the prognosis and residual issues will remain if you start it late.
I think we can conclude this session.
I think we can end here, and the rest of the discussion can be then the lunch time and any other time, okay? So we are running late. Thank you for all the panelists. Thank you, moderator, for a nice session. We are declaring the end session over here. Thank you.
Thank you.
Thank you to all our panelists, moderator and chairman. I'd request all of you to step out for the felicitation, please. We're now moving on to our second panel, which is that of traumatic brain injury and the role of pediatric intensivist. This session will be chaired by Dr. Joydeep Roy, sir, who is the principal and professor of pediatric ICH, Kolkata. I request sir to kindly take his place on the dais and introduce the chairperson. Introduce the moderator and the panelists, sorry.
I think moderators should come to the dais. Dr. Muhammad Ali. He is DM in, first of all, he is the DM in critical care. That is one of the important things. And he is affiliated with Medical College Kolkata. His designation is DG Consultant in PIC.
So I will request my panelists to come into the dais and they briefly describe their interest and their educational qualifications. So, ma'am, Banda Shah, ma'am, please. Second, Kostov sir, Dilip Datta sir, and Dr. Shamim. Please come and take your seats. So, please briefly introduce about yourselves, one by one. Yeah. Next presentation.
Hello, myself Dr. Bandya sir. I am working as a professor and pediatric intensivist at KIMS Medical College, Bhubaneswar.
Hello, myself Dr. Kaustubh Chaudhary. I'm currently working as a senior pediatric intensivist in Apollo Multi-Speciality Hospital, Kolkata. And yeah, so recently we are managing one case of 4.5 years old traumatic brain injury patient. So that will be helpful while we are discussing this case as well.
Good morning, everyone. My name is Shamim, trained in pediatric intensive care. Right now, I'm working in Pediatric Institute of Neurosciences as a consultant in pediatric neuro ICU.
Hello and good morning. I'm Dr. Dilip Datta, consultant neurosurgeon, Narayana Super Speciality Hospital, Howrah. So at Narayana Super Speciality, we deal with a lot of pediatric brain injury cases, and I'm here to discuss with all of you today. Thank you.
So we'll start our discussions. So we have experts. So they have their basics knowledge as well as they have gained their knowledge and experience over the years by taking care of the traumatic brain injury patients. So here, before going to my presentations, I will request all of you, if you go to the evidence, like the presentation that I am doing, that is based on the evidence of Brain Trauma Foundation's guideline, that is 2016. That is Pediatric International Traumatic Brain Injury Guideline, that is on 2019. And another is Seattle Guideline, that is on traumatic brain injury, that is also on 2019. But before going to that guideline, so these guidelines are basically based on the evidence from the high-income countries. And that is mostly adult-based. So in low middle income countries where the problem is more, the mortality is more, we have limited researches and experience on that. And in pediatrics, the evidence is little less. So whatever evidence that we are going to show you, that is based mostly on the adult experience. So if you go to the epidemiology of traumatic brain injury, it is the second most common cause after hemorrhage, the mortality in a case of polytrauma or the trauma. And it is said that it is a silent epidemic. That means over the time, the incidence of the traumatic brain injury is going to be high, and it is predicted in 2030 it will be like epidemics because of the urbanization and globalization of these countries. So the estimated incidence nowadays is around 1,000 per lakhs populations, and most of the cases are mild traumatic brain injuries. And there are multiple causes of traumatic brain injuries like falls from the height, road traffic accident, or physical assault, or maybe because of the other accident like drowning or the burn injury and something like that. So mortality rate till now it is reported in 20 to 50%, and that depends on our countries. So in pediatric patients, among the whole trauma, like traumatic brain injury, only 8% are pediatrics, and all cause of traumatic brain injury related mortality, only pediatrics contribute only 5%. And in a pediatric like epidemiological study, in India also, around 20 to 30% of emergency visits is because of the trauma. So we have to understand the basic management of traumatic brain injury. And if you see the graph, the mortality in pediatrics is less as compared to the adult. So our overall outcome in traumatic brain injury management depends on the pre-hospital care, how we are stabilizing at the scene, and how we are managing the patient in the hospital, as well as after hospital discharge, the rehabilitation care. And if you see the difference between the high-income country and a country like us, there is gross difference in each and every state. There was a study that was done between the UK and the AIMS Delhi, and they found the striking difference, at least in the pre-hospital care. The good pre-hospital care given in UK study is around 90% of the cases, where in India, it given only 8% of the patients, and that has huge implications in the overall outcome. So this is the classifications of traumatic brain injury. So mild, moderate, and severe. We know this is based on the GCS, but only GCS can't be sufficient. So there are various guidelines that has come up with the classifications of TBI, but none is actually sufficient. In basic pathophysiology, that is very important, being an intensivist or managing the patient of the traumatic brain injury patients. So there is two things. One is primary injury that happened at the time of the injury. So that will cause cellular disruptions, and there will be infiltrations of the ions, particularly the calcium, that will come into the cells, and that will activate the other enzyme systems and will injure your cells. And based on this primary pathology, you will have some predicted secondary injuries like excitotoxicity with NMDA receptor activations, mitochondrial dysfunction, free radical injuries, and the inflammations. So initially the pathophysiology was thought it is mostly because of the hyperemia, like increased blood circulation in the brain. So initial management was targeted to lower the CPP and reduce the blood flow by giving hyperventilation and so on. But recent understanding has shown that most of the patients with brain injury will have hypoperfusions and cellular hypoxia. So these are the two important things that we have to consider while we are managing the patients with traumatic brain injury. The most important killer in traumatic brain injury is the raised intracranial pressures. So these raised intracranial pressures occur because of the three things. One is the cellular swelling, that is mostly because of the excitotoxicity. Second is the vasogenic edema, that is because of the disruption of your blood-brain barrier. And third one is the osmolar edema. At the site of the contusions, the blood-brain barrier act like a semi-permeable membranes, and there will be water drag from the vessels to the contus area, and that will cause edema. So this is the complicated story that I have said you, but being an intensivist, we want to understand the things in simple manner. So most important problem is hypoperfusion and the hypoxia. Second is the increased cellular metabolisms after trauma. So there is mismatch between the supply and the demand. So that is actually aggravating the further injuries. And another is brain edema, excitotoxicity with glutamate, inflammation, reactive oxygen species, and mitochondrial dysfunctions. I have highlighted the first four things because we can, as an intensivist, till now, we can manage these four things, and rest of the things is out of our hand. So with this background, I will go to manage a case who was admitted recently in our hospital, and I will request our panelists, don't read my slides. This slides is given based on the current best available evidences, but I will request you, please share your experience and knowledge and what can be done in our setup. Probably everything can't be done in our setup. It is not possible. So this was a 6-year-old girl who was presented with history of fall from the rooftop on a hard cemented surface. Actually, she was playing with colleagues, and she became unconscious. And she had vomiting 2 times and twisting body movements multiple times while carrying to the nearest hospital. She was apparently healthy, there is no apparent past history, and there is no significant allergy history. And child was referred to a tertiary center from the PHC after giving a dose of mitazolam and tetanus toxoid. Obviously, we don't have formal MIST report. MIST stand for mechanism of injury, injury identified, the sign and symptoms, and the treatment given. So that is not given most of the time in our referral center. So the first question will be to Dr. Shamim. So if this history comes to you, how will approach to the patients? Like what you look for in your initial assessment, and what is your basic purpose? How will try to stabilize the patients? So please share your experience.
Yeah, so this kind of patients, this child obviously has a very life-threatening injury, and the best way to approach is to follow a structured approach, which will allow least time wasting and allow you to come to a life-threatening, addressing the life-threatening situations as early as possible. So being a trauma patient, either you follow a ATLS guideline or ILT, International Trauma Life Support, or Advanced Trauma Life Support algorithm, both of which are quite good and suited for trauma patients. If you go for ITLS guideline, International Trauma Life Support, the primary survey it actually is a little bit different from the PALS guideline, and initially it consists of the scene size up. It assumes that you are the primary responder on the scene, so it has added components like thinking of the mechanism of injury and is it safe to approach the patient at that point. The initial assessment is a little bit different because it is not ABC, it's CABC, where the C stands for the control of life-threatening bleeding. Indeed, in trauma patients, exsanguinating bleeding, if the child can bleed out and die, so the first component of addressing this patient is if there is a exsanguinating bleeding, you control that one, or make every effort to identify the source of the bleeding and control that one. This is followed by your ABC that we normally do in PALS, that is A is for airway with the cervical spine control. Always take care of the cervical spine before going on to the next part. Ensure adequate breathing and ventilation, because hypoxia, you come with hypoxia or you develop hypoxia in a TBI patient, you add it to the morbidity. Next is the circulation. Stabilize the circulation. Again, you come with a hypotension in a traumatic brain injury, you have the double chances of dying. Fourth is the assessment of the neurology, where you go for GCS, pupil, and look at the posturing. And 5 is again environmental control. In ITLS, the other added component is that you have a rapid trauma survey. So you do a head-to-toe examination, looking especially if there is an internal bleed or any other life-threatening hemorrhage that is present. So what was the third question, sorry? Yeah, difference from the PALS. So PALS, as I said, in the acute trauma life support, the algorithm is structured in such a way that we reach at life-threatening conditions as early as possible. So that is why there is an added component of going for a CABC rather than ABC, and doing a rapid trauma survey before proceeding on to the next stage.
Very good, thank you. So basically the basic dictum is what kills fast, we have to identify and treat first. So in trauma patients, it is the bleeding. So we have to control that bleeding and we have to try to find out. So this is the primary survey that was done. So Banda ma'am, please have a look. So the patient has abnormal appearance and breathing was normal, color was abnormal, there was no significant external bleeding, and there is there is some abnormal gurgling sound, breathing bit tachypneic and increased work of breathing, saturation is still maintaining. Circulation, there is compensated shock, narrow pulse pressure shock. Disability, GCS is only 3, intermittent posturing, pupil is asymmetrical, and exposure, there is a bruise over the left flanks, temperature is normal. So ma'am, based on this information, what is your initial assessment, physiological categorizations, and what will be your immediate actions?
So here the airway is, one has to stabilize the airway with cervical spine immobilization, that has to be taken care of. And since the child is in tachypneic and is work of breathing, so is in respiratory distress, most probably upper way, because there is some sound. And the blood pressure is low along with poor perfusion, so child is in hypovolemic shock, and also the pupillary is asymmetry, so most probably this child is in raised ICP with herniation. Yes. So immediate priority has to be to give 100% oxygen and along with hyperventilation. So simultaneously this in order to reduce the raised ICP, 3% normal saline has to be given at 10 ml per kg. And when we are doing hyperventilation, we should take care that we are doing it with 100% oxygen for reversal of the pupillary dilatation. And along with this, simultaneously, we have to take care of the perfusion, because this child is already hypovolemic. So take care of the CPP, IV line bolus, and inotrope should be started immediately. And along with it, yeah.
Yes, ma'am. So this patient has acute herniations. So you have to start with back mask ventilations, little bit of hyperventilations with 100% oxygen. You have to give 3% initials. Here we will consider 3% initials because the patient is in shock, and we have to give some sedations. So, Kostov sir, you please tell us about the airway management in a TBI patient. So, oral airway, nasal intubations, oral intubations, when you will intubate, like what are the medicines that you will use, what will be your concern, major concern during airway management?
Okay, in traumatic brain injury, if you see this case, already the GCS is like 5. Along with that, you are getting anisocoria. So that means there is herniation. So you need to maintain the airway. So if your air is maintainable with that back and mask ventilation, you will plan for intubation, because already the GCS is less than 10. And as per the ATLS guideline, you need to go for intubation at that point. So for it, because there is a herniation, what do you need to do? You need to take care of the acute surge in ICP while doing that intubation. So what do you go for? Is basically rapid sequence intubation. So once we are planning for RSI, that means what you need to do is some sedative agents and some muscle relaxant also. So what we mostly use in RSI, depending on the conditions, like most of the time we use like midazolam and fentanyl. Most of the time, along with that, some muscle relaxant like rocuronium or atracurium or vicuronium. And there are indications of using that propofol or something like etomidate. Etomidate is in ATLS guideline, they are more profound of use. But obviously all is having some amount of advantage and disadvantages. So what advantages is depicted already. So if you are using, so main target of that ICV to manage that is that your cerebral perfusion pressure to maintain. But all these drugs which you use as benzodiazepines, there is a decrease in the MAP, that is blood pressure, and that can lead to decrease in the CPP also. And along with that, narcotics like fentanyl we have discussed, so that can decrease that blood pressure, but that can increase that ICP, but overall the CPP is no change. So that is one of the good thing of the fentanyl. But propofol, etomidate, and thiopentol all can decrease that both blood pressure as well as ICP, and that's the way that can decrease the cerebral perfusion pressure. But that is for a transient time, so you need to use, and most of the time in our setup we use that midazolam and fentanyl. But having said that, we need to stabilize the blood pressure, and that's how initially we give a bolus of 10 ml per kg of normal saline, and then subsequently we go for RSI.
Very good. So basically what I have said already, so secondary insult, that is the hypoxia and hypotension, that is the major things that will ultimately give you the ultimate outcome. So during each and every procedure, you should take care of these things. So you will take care of the airway, you will start some oxygens, you will give some fluid bolus, you will probably start with some inotropes, then you will go for RSI. So you have to consider hypoxia and hypotensions. If the patient is hemodynamically unstable, it is better to use opioids or the ketamines, or if the patient is hemodynamically stable, you can use whatever you want. So Dilip sir, so this is yours. So when you suspect the cervical spinal injury, and how you will approach to rule out this cervical spine injury in a traumatic brain injury child, sir? Please, sir, share your experience.
So, in cases of traumatic brain injury, we should always suspect a cervical spine injury. Yes. The suspicion is the main for neurosurgeons, for intensivists who are managing cases of head injury, polytrauma cases. There should be a high degree of suspicion, because lot of traumatic brain injury cases, lot of head injury cases have associated cervical spine injury. Like the mechanism, the mechanism of adult is completely different from the child. A child has a large head, so there is a fulcrum effect. So when like in adult we get cervical spine injury, mid cervical spine or lower down. But in case of pediatric patient, we get upper cervical spine injury that are more common. We get odontoid fractures, we get C1, C2 fractures. So it is very easy to miss upper cervical spine injury.
Yes, sir.
On radiology as well. based on the radiological features of the pediatric population as well. Whether the already all the primary and secondary centers are fused or not, that creates some confusion on the X-ray plate.
Yes,
so it should be properly read. We should always take the help of the radiologist. Whatever we can see on the X-ray plate, whatever it seems, but we should always have a talk with the radiologist to find out whether there is any fracture or whatever we are seeing is normal. We should always consider this. And like I was telling that we should always suspect a cervical spine injury when there is a severe head injury, or when there is the mechanism of injury is very suspicious, like axial loading, like the boy or the girl is falling down from the bicycle, and mostly they come up with that fall over the head, they fell over the head, or there is some distraction injury. So these are some extension injuries. So these are very significant mechanism of injury. So a proper history is also very important. And we should maintain cervical spine collar till we can clear the cervical spine. We can remove the cervical spine collar for a time being and check for the range of motion. If there is any suspicious that there is pain in the cervical spine, tender, or there is restricted range of motion, we should always go for X-ray and CT scanning. In X-ray, we should never miss a open mouth view, because getting an open mouth view in a child is very tedious. Most of the child at that time is restless, is crying. So getting an open mouth view is very difficult. But if we can, with a gag or whatever, if we can get an open mouth view, that will be very helpful.
Thank you, sir.
And also if we can get the CT scan to screen the cervical spine.
Yes, sir. So basically it is the history, it is the examination findings, and one thing that we should understand is most of the injuries, even in MRI, there will be no significant findings. So that is known as sciuria. So spinal cord injury without any radiological abnormalities. So Dr. Samim, this patient also had compensated shock. So can you please tell us what are the causes of shock in traumatic brain injury patients, and what will be the basic principles, like how it is differ from our usual resuscitations in a patient with shock?
Yeah, so control of BP takes precedence actually, and it takes precedence even before going for a neurosurgical intervention. Need to stabilize the BP first. That is the first thing we need to remember. In a trauma patient, by default, if the child is having low blood pressure, the cause is a high hemorrhage. Either it's bleeding externally or it's bleeding internally. And getting a control of the bleed is the first thing that we need to do. External bleed, compress, tourniquet, call in the surgeons, get the surgeons in the loop. If any external bleed is not notable and the child is significantly hypotensive, go for an immediate fast scan along with, at the time when you were doing ABC.
So will you do fast scan for these patients? So there was bruise on the flanks and.
So if there is a discoloration on the abdomen, there is a high chance that the child is bleeding into the abdomen. So and that might need a surgical intervention.
Fantastic.
So we need to document there is bleed and need to identify, and fast scan is we can do it immediately, and when we are doing a CT scan of the brain, we can actually get a CT scan of the abdomen also to see if there is a bleeder. Okay. But in a traumatic brain injury or in a trauma patient as such, apart from the bleed, there are a few other causes that can cause this hypotension. You can have an obstructive shock, you can have a huge pneumothorax, you can have a tamponade, and you can have a hemothorax, which actually cause obstructive shock, and you can still get the blood pressure that is low. So you need to identify as part of EFAST, we can look for a pneumothorax or a hemothorax, and you drain that one. The last thing is you can have a spine injury, and that can actually cause that can also cause hypotension.
Neurogenic shock.
Exactly. So identify and stabilize the blood pressure. That is the first goal. So what was the second question? The management.
Management.
Or stabilization. Yeah. So stabilization, if it's a bleed, you need to replace with blood. Initially, we don't get blood immediately, but we go with fluid. But if it is a massive bleed, you are not able to stabilize the patient only with giving normal saline. So you have to go with blood. And once a child needs more than 30 ml per kg, 40 ml per kg blood, you need to go for massive transfusion protocol. So only replacing with PRBs is not going to help. In that case, you need to replace, apart from PRBs, you need to give the plasma, platelet, fibrinogen, and need to replace the calcium also. We need to make sure we are not going into that lethal triad or lethal diamond. We are going to avoid hypothermia, acidosis, coagulopathy. Brain injury as such is a hypercoagulable state. So brain causes has a lot of thromboplastin. So injured brain causes the INR to go high up. So that needs to be controlled. Otherwise, the child will keep bleeding. So internal bleed, and if you can't control the bleed by only by transfusion, get the surgeon in first, and you need to control the bleeder.
So here, so one important thing is like in traumatic patients, so we sometimes use a term that is the permissive hypotension. So if you have a patient with raised ICP or traumatic brain injury patients, so probably we will avoid that things. So we'll try to maintain at least MAP around 60 to 70s. So otherwise the cerebral perfusions will be compromised. Second thing is we should avoid fluctuations of the volume status and fluctuation of the blood pressure. That is very important. We should avoid the fluctuations. One important thing, and fluid in this case is always crystalloid. It is always crystalloid. If you give albumin, the mortality may increase. So now, Kaustubh sir, what will be like your assessment during the secondary survey, and what will be like your next plan of action with investigation and the things? How will plan for the further care?
So, as per the management of traumatic brain injury, if you are getting shock, possibly one of the crux is that you have to differentiate between that hemorrhagic, whether it's a hemorrhagic cause of shock or there is a non-hemorrhagic, as Dr. Samim has said. Having said that, the ATLS guideline is clear-cut about some criteria to be fulfilled. That is, they are always, obviously it is from the adult perspective, but they are always trying to keep the blood pressure, that is SBP, more than 100 and more than 110 in 15 to 55 years, 59 years of age. So what is our plan is that always target that blood pressure towards that 75 to 90th centile, particularly for that particular age. So that's how the BP should, that's one of the mortality predictor also. And apart from that, we need to just focused on that secondary survey in the form of, after that primary survey, the secondary surveys. So as per, you can go whatever you are feeling more comfortable with. So we usually go by the IPALS secondary surveys, that is that focused examination, and focused examination means head to toe. But having said that, there are certain, previous slide. So in trauma patients, you can do like inspection, palpation, and extremities examination. So inspection is the mnemonic like decap BLS, so it means that you just examine that whole areas of the brain, that is the deformities, contusions, abrasions, and there is a penetration. And then obviously palpation is like TIC, like tenderness or instability and crepitus, and PMS is that basically pulse and motions, motor functions and sensation. So what we need to do is with the secondary survey head to toe, you just identify is there any other areas, like what in this case is that there is some abdominal trauma. Recently we got a case of 4.5 years having fall from the height, and then there's a bleeder actually continued, and that's how the shock was not managed properly with the fluid only, and we need to give a repeated blood transfusion. And we found that apart from the traumatic brain injury, this child is having bleeding from the hepatic artery also, and we need to go for the hepatic coiling, and then after that we can control that blood pressure quite nicely. And the vasopressin and norepinephrine, which was started initially, just within 24 hours is gone down, and within the we can manage with the fluid. So these type of management is quite important for identification with the secondary survey.
Important thing is like you should have a formal neurological assessment. So when the patient is not hypoxic and not hypotensive, you should have an baseline neurological examinations that will tell you the next line of actions as well as prognostication. So this is very important. So what about the indication of CT? So this is probably will be helpful for all of us. The patients will come with a history of a fall, and they will say, sir, ek bacha ka CT kara do, MRI kara do. So how will you approach? Like this is, I think this is very important for all of us.
Yes, I think when you are in the OPD, particularly as a, not only as a pediatric intensivist, one of the important history is that vomiting. So if you see the criteria, like we always take the history of loss of consciousness and then vomiting and then subsequently like headache. But if you see one of the criteria that is most common, ask for the vomiting, whether the vomiting is, because that is the most important criteria out of all this. But apart from that, if you are getting loss of consciousness, even if it is for a blip or even if it is a lucid interval, you have to take care of that with the CT scan of the brain. And apart from that, if it is persistent headache following that fall, then you have to take care of that one also. In this case, if you see that GCS was 5, and along with that there is an acute herniation in the form of anisocoria. So if those are on your clinical finding with the pupillary findings, so immediately go for those CT scan. Apart from that, on palpation, if you're getting something like depressed skull fracture, you should go for that. Apart from, if you are thinking of CSA bryonuria from the nose, or if there are certain signs like what I've been discussed as battle sign, then rattle sign, then skull laceration, you need to go for that one. And if you're getting something like bleeding from the ears or hematoma, you need to go for immediate CT scan.
Thank you.
The brain.
So basically, all moderate to severe traumatic brain injury patients should have formal CT scan. And in case of mild traumatic brain injury patients, you have to consider the mechanism of injury, sign and the symptoms. Then you will decide. Sometimes you may not have like clear-cut the things, so you can observe the patient for 6 hours or 8 hours, and then you can take a call. So based on this guideline, we are managing the patient. So this patient was shifted for CT scan brain as well as cervical spine was done. So cervical spine is reported to be normal. CT scan is showing this type of cerebral edema. So sir, Dilip sir, so like, would you like to give us some information of the CT, the role of CT in traumatic brain injury assessment, and when will you go for the urgent neurosurgical interventions before going to the pediatric ICU patients? So like, what will be your sir?
So when we have discussed when we will get a CT. So already if we have a CT scan or we have done a CT scan, we should look out for whatever primary injury has already happened, and we should aim to prevent the secondary injuries. So our main aim from a neurosurgical point is to prevent the increase of ICP, prevent herniation, and prevent further secondary injuries. So we should look for whether there is any hemorrhage, whether there is any hematoma which is increasing, whether there is any depressed fracture. Those things we should rule out, the surgical cases, and also we should look for the signs of herniation, or if herniation is probable signs of herniation. Because like in a dense, like the CT scan, if there is cerebral edema in a dense brain in a child who don't have that much of space. In adults, in elderly, there is cortical atrophy, there is a lot of space. But in a child with cerebral edema, if the child have one more episode of seizure, that will also increase the cerebral edema and will lead to herniation. So we should have our threshold very low, and we should operate, we should decompress. If we think that this child can have herniation, this child can go into herniation. If there is telltale signs, like if there is a large EDH, large contusion, already there is midline shift, already the basal cistern is not visible, or already the basal cistern is being compressed. So anywhere we feel that herniation is starting, we should go for surgical intervention.
Thank you, sir. Thank you. So the case further progression. So airway breathing was taken care. Patient was intubated. PRVC mode of ventilations. Now saturation is maintaining. ET CO2 is around 42. Circulation has stabilized with noradrenaline of 0.1. GCS is now still 5/15. Sorry, and people is now equal. Now patient is come to the pediatric ICU. So ma'am, can you like tell us what will be your monitoring plan? So if you go with the like evolutions of neurological monitoring, so it was initially the clinical assessment, then comes the CT scan, then subsequently the ICP inserts and EVD, particularly the EVD and ICP monitoring. Over the time, people realize that this ICP and CCP monitoring is not helpful. Then they go for the like brain metabolism analysis, like PbO2, cerebral microdialysis. Even people use the cerebral perfusion with Doppler ultrasound and CT scan, genuine perfusion scan, and everything. So, ma'am, like with this, all these things, all things are not applicable or not possible in our setup. So, if the patients come to our setup like in ICU, then what can we do? Like from practical point of view, what will be the most beneficial? Like how will approach in PICUs?
So in resource-limited countries and resource-limited settings, again clinical examination is the most important. So continue your GCS monitoring and the neurological monitoring every 2 hourly, and also pupillometry can be helpful, automated pupillometry where you can look for the pupillary index. And apart from that, non-invasive monitoring will be more helpful. In invasive monitoring, one can go for ICP monitoring, which can be, it is important to stress that even if the child is not having a abnormal CT scan, raised ICP can be a concern in more than 30% of the cases. So in transcranial Doppler monitoring, what we see is that the pulsatility index, which is actually a coefficient, and it is the difference between the systolic blood flow velocity and the diastolic blood flow velocity by mean velocity, and a pulsatility index of around 1.5, less than 1.5 is normal. Around and a diastolic velocity of more than 20. So 20 to 25 is normal. So if you're having something less than that, then you have to think of improving, making interventions to improve your CPP. Then coming to the next non-invasive monitoring is the optic nerve sheath diameter monitoring, where a transducer can be used.
Linear probe.
Linear probe to be used to see the optic nerve sheath diameter. The usual normal value is around something less than 5. But if it is more than 5.8, has a high sensitivity and specificity for predicting a raise ICP of around more than 20. So coming to the invasive monitors, we have seen that ICP monitoring, there are many RCTs which say that ICP monitoring might not be that beneficial. So whether to go for a CPP guided therapy or ICP guided therapy, so one can go, if you have a ICP monitor in place, then one can look for something called the pressure reactivity index. So if the pressure reactivity index is negative, then the cerebral autoregulation is preserved and one can go for a CPP guided therapy. And if it is positive, that indicates that autoregulation, cerebral autoregulation is lost.
So pressure regulatory, this is basically a correlation between the mean arterial pressure and the ICP. If you increase the mean arterial pressures, if your ICP goes up, that means there is loss of autoregulations. So if the ICP is come down with increase in the MAP, the autoregulation is intact. So in that case, the pressure the reactivity index will be negative. So based on that, we can identify the optimum CPP for a given patient. So nowadays they said, they're like blanket statement, the CPP should be maintained with this. That is, people have question on that. So people are trying to find out the optimum CPP for the patients for a given time. That can change over the time. Like today the optimal CPP may be this, but tomorrow that may be another things. So this is the work is going on. Probably this will come as a standard guidelines in the next future. So Dr. Samim, can you tell us like the overview? Can you give us the overview, basic overview of the raised ICP management? Many things has been discussed like in the previous discussions. So specific to this traumatic brain injury patients, yeah.
So this patient with a GCS of around 3T, I guess. That was intubated, right? Yeah. So with a severe traumatic brain injury and hemodynamically stable. So the treatment will differ a little bit based on the where you are treating the patient. But basic things that should be done in all PICU. One is the child should be kept in a head end, elevated head end with a head in the midline. Should be adequately sedated. Should have oxygen in the normal range, blood pressure in the normal range. Repeated monitoring of blood glucose that has to be in the normal range. Aggressively look to keep the temperature normal. So don't allow any fever. Avoid any noxious stimulus, so good amount of analgesia will be needed. The next thing is this child has to be on some hyperosmolar therapy, either a 3% saline with infusion or a mannitol. If the blood pressure is okay, mannitol still should be fine. But one of them, or either one of them or both has to be started in this patient. And then the child has to be on intense monitoring to look if the ICP is increasing despite all of this, because it's a step-ladder pattern kind of treatment. If despite these measures, if the ICP is increasing, then you have to go to the next ladder. The ventricles in this child was very small, so it's not a candidate for a EVD. So the only next thing that we can do, if after all this, if it is still refractory, only next thing we can do is call in the surgeons and go for a decompression.
Fantastic. So now this is the debate, Kaustubh sir. So this debate is still, I think, going on, whether 3% NaCLs or it is the mannitol. So what is your stand? So this is the latest systematic review meta-analysis. They said 3% analysis is nothing, it is a bogus things, and it is associated with complications. With hypernatremia and hypercholemic acidosis, lots of complications. It doesn't do anything with the ICP and the mortality. Even your 6-month or 12-month Glasgow outcome scale, that is based on the adult study. So what is your stand?
So if you go through that raised ICP management, you need to understand that all these extra thing apart from that hyperosmolar therapy, like head and elevation, all this depends on how is the shock is managed. So once the blood pressure is managed, the shock is corrected, then only do these things like head and elevation. So if this child is in shock, better to keep it in that flat position and manage the shock. Along with that, TBI management should be side by side going on. So if there is an acute herniation in this, just like in this case, so I will definitely go for something like hyperosmolar therapy. So we have, apart from that regular management of the ICP, right, Dr. Samim Hot said, euglycemia maintenance, temperature is one of the important prime factors. So you have to aggressively manage that temperature, as well as you can go for some anti-seizure medications for early PTS. So apart from that, if you are going for hyperosmolar, we have two things in our hand. One is that the hypersaline, hypernatremic, that is 3% saline, and along with that mannitol. So both up is having some pros and cons. So 3% hypertonic saline is actually not causes hypotension, and if your child is in shock, or if after giving 3%, after giving that mannitol, if there is shock, it is better to go for that 3% saline. And the studies, whatever RCTs is now coming up with the 3% hypertonic saline and as well as mannitol, the mortality benefit with these two is not there. So there is no difference. But having said that, overall, with the 3% saline, if you see the hospital stay as well as the rest ICP or CCP targeted therapy is better managed with this recent RCTs that is showing. So I will bet on 3% saline compared to mannitol in these conditions. But having said that, I use both depending on the patient's conditions.
So fantastic. So most of the recent guidelines, they are in favor of 3% initial nowadays. So but mannitol has a place. So that is, even again, it is the institution based and the physician who is treating and his experience, that also matter. So now, ma'am, can you please tell us, is there any role of PBO2 guided ICP therapy? So we conventionally, we are managing with ICP, then CPP guided therapy. Then nowadays we are thinking that no, it is not optimum. So we need something else. So PBO2 guided therapy, is there any
when they saw that there is no mortality benefit with ICP guided or CPP guided therapy, then they came up with something new, which is you can say in the experimental stage, that the PBO2, brain tissue oxygen monitoring. So here the desirable level is around 20 to 50. Again, this is an invasive monitoring. If the level is less than 20 means, that means this child oxygen extraction is more, and most probably the demand is more and the supply is less.
Yes, ma'am.
But
Yes,
one has to remember that even a high PBO2 can be detrimental, because a PBO2 more than that indicates hyperoxemic injury can happen, and when it is on the lower side, then the child can go into ischemic. It indicates a cerebral ischemia and injury. So the recent guideline, the CETL guideline, which has come with a tired therapy based on the PBO2 monitoring. So in the zero tire, you can go ahead without any ICP monitoring or PBO2 monitoring. So whatever we do clinically, head and elevation and midline positioning, and also management of the temperature.
So basically, ma'am, just to sort out, so basically ICP, normalization of ICP and CPP, still PBO2 guided, they found that there is significant hypoxemia, around 70% of the cases. So our aim is to just balance between the demand and the supply. So that's why the people, like the latest guideline, the Seattle guideline, they come up with this recommendations. They use both ICP and the CPP, PBO2. So best if maybe your ICP may be normal, PBO2 may be low, or your ICP may be high, PBO2 may be normal. Based on that, they have given this type of management strategy. Okay, so this is the very important thing. If the first tier not working, second tier, third tier, before going to that, we have to re-examine the patients and may have to consider repeat CT scan to see the mass effect, and we have to consult the neurosurgeon, and extracranial pathology that can increase your ICP, like PEEP and other things, the edemas things that we have to take in the considerations. So sir, can you tell us about the role of decompressive craniotomy? So this is the latest trial. So this trial said there is no outcome benefit with your decompressive craniotomy. So what is your stand? Will you consider decompressive craniotomy for this patient if this patient ICP is not getting under control?
So, like the recent evidence what has come, that decompressive craniotomy only to when there is no surgical injury inside, when there is no hematoma inside, only decompressive craniotomy to prevent raised intracranial tension is not that much helpful. But still, if there is lateralization, like if there is midline shift, if there is chances of uncal herniation, any signs of uncal herniation, any pupillary asymmetry, we can still, as a last resort, try for a decompressive craniectomy.
Thank you, sir. So basically, there was a controversy about the role of decompressive craniectomy. So evidences is very clear. So prophylactic decompressive craniectomy, there is no role. So you have to take care of your air breathing circulations. You have to give the ICP tire therapy. If that is refractory to all the medical treatment, then you can consider, yes, we need further evidence, and the trial is going on. So these are the extracranial complications that we have. We should to manage these things like pulmonary complications, ventilation, early tracheostomy. There is no role. And the fluid, I have already talked. Blood product, Dr. Shamim talked about that, and this renal problems and the nutritions. All these things have to be like taken into the considerations. Otherwise, the outcome will not be like so good. With this, like we are concluding these discussions, so we'll expect some questions and the remarks. And I must thank my all panelists for doing the great job. Thank you.
Thank you for the nice discussion by the moderator and all the panelists.
Just to
want to say something.
Just to add on, I think the biggest study recent published is showing us in cases of traumatic brain injury, 3 things are quite important for prognostic marker. One is blood pressure management. Second is your CO2 titration, like 35 to 40. Don't go for hypocarbia or hypercarbia. And third and most important is that most of the time we forget that one. What is the last line is showing is that early nutrition. Early nutrition means within 72 hours you need to start on the feeding. And that's actually create a huge difference in mortality.
What I want to say from the discussion that the quick assessment and quick referral to the intensivist is one of the important thing, because intensivists take the burn for the management of this case. Generally, we spend for the CT scan all these things. Already Kostov mentioned what are the silent feature when we do the CT scan. If there is a vomiting, if there is a consciousness, if there is a lucid interval, if there is a headache, these are the different points on details they have discussed about the CT scan. And during the when came to them regarding the management, our moderator highlighted main 2 points. One is the hypoxia and hyperperfusion, and for that he has discussed in different things. And during the management of critical care, we all know the mantra is ABC, by here is mantra is CABC. So you have to control the bleeding. Hemorrhage is one of the cause. Even sometimes you have to search, you have to suspicion for the injury and for the hemorrhage itself. These are the few salient points we have learned from them. But one thing I want to mention here in this platform, that when the intensivists work in their unit, they are very much stressful condition. They are thinking of the patient, but sometimes they forget to mention the documentation. The documentation is one of the important points, because now medical legal is so much increasing. Even we can remember the case of Apollo Hospital. That was also a case of head injury. And what happened? So I want to share that even we are spending time, we are thinking of the patient, everything, we are in a very stressful situation. But documentation is one of the important things in this era. With this, I want to, from the audience, everything, they want some question, anything. Our panelist is ready, our moderator is ready. If any question from the audience, I want to hear from the audience anything.
A lot of high-tech is needed, right?
Yes, sir.
Things like NIRs, how far should we go? And do we have enough evidence to recommend any of the newer modes?
So can you
recommend that
yeah.
we should do?
So basically, sir, based on the latest Seattle guideline that published in 2019, so PbO2 comes into the your recommendation in the guideline. So I show you the this slide. So that is basically this is the Seattle guidelines. So that is there. NRS I intentionally skip it, because in a standard textbook I find out that one sentence that said, in a cadaver, 1/3 of the cadaver has NRS value that is equivalent to the normal patients. So that's why I have skipped that NRS things. Okay. Thank you. Thank you. If there is no question, then we'll sum up. Thank you.
I think we with this, thanks to all the audience, organizer, and the panelists and moderator, I conclude the session here. Thank you everybody.
Thank you, sir. I'd request all of you to please step outside for the felicitation. We are now moving on to our next talk, which will be delivered by Dr. Priyavartani V. Ma'am. It's a talk on neuroprognostication following cardiac arrest. This session will be chaired by Dr. Shapna Chakraborty Ma'am. I'd like to request ma'am to kindly take her place on the dais. Dr. Shapna Chakraborty ma'am is former professor in HOD of Department of Pediatric Medicine at College of Medicine and JNM Hospital, Kalyani. Ma'am, I'd like to request you to kindly introduce our speaker, please, ma'am.
Hello. Hello. A very good morning to everyone. I must thank the organizers for inviting me such a session and to speak. She will speak on Dr. Priya. She will speak on a subject which is not a common subject in pediatrics, and very few of us has usually face this problem. And I mean, this has got experience that the cardiac arrest, it is so that as it is common in adult, it is not common in children, but still the children who survive after cardiac arrest for missed in a coma state for 72 hours, only it is applicable for those group of children. And I would request Dr. Priya to speak on this subject. And should I introduce her? I cannot see this from the. You can see that. She can see that. Okay. Go that side.
Ma'am, Dr. Priyavartani ma'am is a consultant PICU and post-op cardiac ICU at Apollo Children's Hospital. She is an accredited teacher with the College of Pediatric Critical Care and is published widely.
She will speak on neuroprognostication after cardiac arrest in children.
A very good afternoon, one and all. So my topic today is neuroprognostication after cardiac arrest. So I would like to thank, before I start, the organizers for giving me this wonderful opportunity. So how many of us have seen a child who has had cardiac arrest? Everybody here? Everybody here? Okay, how many of us have seen a child who remains comatose after cardiac arrest? Everybody here? Okay. And what will be your thought which is going through your mind when you think the child is comatose? What is that which comes across to your mind? What am I going to tell the family? Will this child survive? Will this child have a normal neurology? These are the, the glaring questions that come to you. The rest of it is all manageable. See, if you look at intensive care or managing children, heart, we have medications to support, we have ventilation to support, we have dialysis, but the only organ which is kind of you don't have anything to support or replace is brain. And so we are in always a dilemma as to how we are going to prognosticate these children if they sustain a cardiac arrest. So in post-cardiac arrest patients, the bad outcomes primarily is because of hypoxic ischemic brain injury, and if the children remain comatose after a period of after cardiac arrest, the prognosis remains uncertain for quite some time. Okay, and predicting neurological outcomes is essential for facilitating management decisions and to counsel the families, as I already mentioned. So what is the dilemma here? If somebody has is unlikely to have a good outcome, you don't want to prolong their treatment unnecessarily. At the same time, if somebody has a potential for neurological recovery, you don't want to inappropriately withdraw life-sustaining measures. So you can be in either end of dilemma. And so that's why we are discussing about this whole topic. So, and what we realize over time, and literature also says the same, that no single test can reliably predict prognosis in any patient who has had cardiac arrest. There are a lot of confounding factors which can influence each individual's prognosis, and in addition, therapeutic hypothermia will complicate prognostic evaluations. So these are the common challenges, and that's why it is very difficult. If it is something straight, this is not going to be a discussion here. So when we talk about outcomes, the most important thing we discuss about is poor neurological outcomes. When you say poor neurological outcome, how do you define it? For you, we need to have a standard definition for that. So how we assess that is by using pediatric cerebral performance category or pediatric overall performance category scales. In that, I'll just describe just about the most common one, which is the pediatric cerebral performance category. There are 6 grades in it. Grade 1 is a normal child, grade 2 is a mild disabled child, grade 3 is a moderate disabled child, 4 is severe, 5 is coma, and 6 is brain death. If I say poor neurological outcome in any patient, it means at least 4 and above. Okay, because I cannot say moderate disability has a poor neurological outcome. So whenever we talk about neuroprognostication, we need to have clear goals. Who will not have a good outcome is our main question. It is like, in court of law we say, right, no a good person should get executed or should be punished. It's the same way. Okay, so every single child should be given a chance to live. So here we are looking at outcomes which will definitely say it is very, very poor. We shouldn't look at, minor things. So far we saw why we are talking about this topic, what are the challenges involved, and how are we measuring the outcomes. We will move on to the methods which are available, how all we can do. We already said there's no one test which is available. So there are a series of tests. The first is clinical neurological evaluation. Number 2 is neurophysiological test. Number 3 is neuroimaging. And the last is blood biomarkers. We'll see one after the other. So when you look at clinical examination, we need to factor in child's developmental age because that can be very variable, and the assessment of neurology depends on the age of the child also. Also, in most of these patients, we will be ventilated, they'll be sedated, and we'll be neuroprotecting them. So a lot of pharmacological agents are there, and that will prevent us from doing a proper clinical examination. So at the time when we decide to do the neurological examination, sedation and neuromuscular blockade should be completely off. Apart from that, there could be some pathophysiological states such as hypotension and metabolic abnormalities which can cause the same effects. Like suppose somebody is hypoglycemic, for example. They can have profound encephalopathy. We shouldn't think that is related to the cardiac arrest. It's related to the metabolic abnormality. So before we say that a child is comatose, we need to exclude the effects of pharmacological agents and other things such as metabolic abnormalities and hypotension. So once we do that, then we will look at what all are abnormal in the clinical examination. There could be many things, but here we are talking about what are those things which will definitely say this child's neurology is going to be eventually very bad. And so there is no point in continuing therapy. That's what we are looking at. So it could be absence of spontaneous respiration at 24 hours, a GCS of less than 5 at 24 hours, absence of pupillary reactivity at 24 hours. Apart from this, if there are no purposeful movements at 24 hours, that also has been studied. These are a list of studies that have looked at clinical neurological examination as a predictor of poor neurological outcome. So though these data is very small data that we have, so we cannot make big decisions based on this. So we look at some adult data. So adult data says if somebody is not treated with targeted temperature management, okay, the earliest time to prognosticate unfavorable neurological outcome is 72 hours after the arrest. Meaning, if somebody has an arrest today and the child remains comatose for the next 3 days, I would do the neurological examination only after 72 hours. Today somebody arrests, tomorrow I cannot look at the patient and say, no, this child is gone. No, we cannot do that. So we need to do at least after 72 hours. But if somebody has been treated with targeted temperature management, meaning somebody has been treated with hypothermia, you need to warm them and get to the normal temperature, and 72 hours after the completion of achievement of normothermia that you need to assess, not after 72 hours after the arrest. So today somebody arrests and then they are treated with hypothermia. So then you decide to warm them. If you have achieved normothermia, and then from there 72 hours is what we are looking at. So to summarize, the clinical neurological exam as a prognostic factor, we should use caution in the interpretation very early. Like I said, we should not use it very, very early. And the reliability improves with serial examinations with the passage of time after cardiac arrest. Do it repeatedly. Do it, after a third day, after a fourth day, keep doing that, and you may get ideas about the neuroprognosis. And you should not use this clinical examination alone in, to prognosticate these children. Meaning, I'll just do neuroexamination. I saw some absent pupillary reflexes. I saw absent respiration. I cannot say the prognosis is going to be poor. I need to supplement it with other things which I'm going to describe. So we cannot use clinical examination in isolation to prognosticate a patient. So the next thing is neurophysiological tests. So by that I mean EEG and evoked potentials. EEG, the problem is you need technical expertise, you need knowledge on patient's clinical status, because most of the times EEGs are interpreted by neurologists. We need to give that information to them, the current status, what drugs I have used, whether I'm using hypothermia, because all this can affect the EEG study. So preferably we should use continuous EEG, and the EEG background can be normal, slow organized, discontinuous or burst suppression, or attenuated and featureless. In general, the more severely abnormal EEG background patterns are present, the worse is the prognosis. Which means if somebody has a burst suppression or an attenuated featureless EEG, then the likelihood of neurological recovery is very, very low. So again, there is pediatric data. There are multiple studies which have shown discontinuous or isoelectric EEGs, status epilepticus, myoclonic status, voltage attenuation. So there are a lot of EEG background features which says that these are very bad features. They are likely to have a neurological, poor neurological outcome. Here again, we are not saying just with EEG this is going to be bad. We are going to put this in the context of the clinical picture, neuroimaging features, if possible biomarkers, and then we are going to come to a conclusion. So, to summarize in the EEG, none of the EEG features have perfect predictive value for unfavorable outcomes. So, we need to consider EEG findings within the overall clinical context. And the past 2015 guidelines says that EEG performed within the first 7 days after pediatric cardiac arrest may be considered in prognosticating neurological outcome at the time of hospital discharge, but should not be used as the sole criterion. So far we have seen how is clinical examination useful, what are the features, and we know that in isolation we are not going to use it. Again, we saw EEG features, again in isolation you are not going to use it, and you could do EEG within the first 7 days. There's no particular timeline they have said where you should not be using. The third thing is evoked potentials. Okay, so these are very appealing because they can be performed at the bedside. It is not affected by sedation or hypothermia, and you can be done repeatedly. So there are different types of evoked potentials. The most commonly used is somatosensory evoked potentials, and by that it basically tests the integrity of the peripheral nerve, usually the median nerve, spinal cord, brainstem, and cerebral cortex. Basically, you are trying to stimulate here, and you are looking at whether the whole thing is, integrity is intact. So the cerebral, here we are interested mainly in the cerebral cortical activity because we are neuroprognosticating. So that is, identified by the N20 wave. So if bilaterally N20 waveform is absent on day 3 after cardiac arrest, it usually predicts unfavorable outcomes in adult cardiac arrest survivors. So, but before you say absent N20 reflex bilaterally, we need to rule out that there is the pathway from median nerve, for example, till the cortex is intact. So you need to look at other markers as well. So the message is that you can use SSEP, and bilaterally absent N20 reflects that the prognosis is likely to be poor. So other evoked potentials include brainstem auditory evoked potentials and visually evoked potentials. Auditory evoked potentials use auditory stimulus, visually evoked potentials use visual stimulus, but these are not really very good measures of looking at cortical function. So it is, and studies also show inconsistent data, so this is not being used. So to summarize regarding the evoked potentials, there is insufficient evidence to support the routine use of evoked potentials for neuroprognostication after pediatric cardiac arrest. So far we saw clinical examination is reasonably good, EEG is reasonably good, and together is probably good, but evoked potentials is not so much. We may use it, we may not use it. The last is neuroimaging. So neuroimaging in post-cardiac arrest patients we will do for two reasons. One is to ascertain the cause of arrest, which we are not interested in now. We are talking about prognostication. Okay? And diagnostic neuroimaging usually we do for a child who has not returned to baseline neurology, or if the neurological examination is confounded by sedation or neuromuscular blockade, why the child had a cardiac arrest to begin with. We may do it for that reason, or when there are focal neurological findings. But these things are diagnostic, and this is usually done at the time when the child is sick, and this is not meant for neuroprognostication. Don't use this for neuroprognostication. So let's move on to neuroprognostication. Imaging. So we have two, normally we do use two type of things. One is CT, other is MRI. First we'll talk about CT. A non-contrast CT is not sensitive, especially in less than 12 hours after return of spontaneous circulation, but can identify more severe cerebral edema, and the published evidence is inadequate to determine the most suitable timing and whether brain CT in the first 24 hours is useful for prognostication. What I mean to say is you can do CT more for diagnostic purposes rather than for prognosticating purposes. That's the essential message of that. So let's move on to MRI. MRI definitely has superior accuracy than CT in identifying hypoxic ischemic injury. So what are sequences we need to find out? T1, T2 and diffusion weighted imaging. Diffusion weighted imaging sequences pick up cytotoxic or vasogenic edema, and when you see abnormalities in these sequences, that may help us identify poor prognostic factors. Okay. And what are the poor prognostic MRI factors that people have studied? So you can have focal or generalized hyperintensity, abnormal basal ganglia, this is very important, abnormal cortex. And if in general these changes are generalized, that's more severe compared to when it is a small or focal area. So these three things what I told has a very good positive predict value. Apart from that, even head CT can be used in less than 24 hours if there is diffuse loss of gray-white differentiation, basilar cistern effacement, sulcal effacement, again there can be prognostic significance. So to summarize, brain CT is a useful diagnostic test after ROSC to identify the causes, but not for prognostication. Whereas MRI, if you do conventional imaging and diffusion weighted imaging in the first 3 to 7 days after ROSC, it is very useful and it supplements the clinical assessment, including serial neurological examinations, EEG, and sometimes SSAPs. So essentially, so far we have said clinical examination is useful, EEGs are useful, MRI is useful, but none of them in isolation can be used to prognosticate a child, especially in saying that the child is going to have a very bad neurological outcome. The last bit of my talk is biomarkers. Biomarkers are sampled from the blood early after cardiac arrest. So whenever you have a hypoxic ischemic hit, what happens is that the nerves basically gets injured, and there are chemicals from the neurons are released into the circulation. You can ask, how is it released into the circulation? Because there is damage to the blood-brain barrier due to the hypoxic ischemic process. So it gets through the blood-brain barrier into the blood, so you can measure that. So there are many markers. We really don't need to remember the names, but we need to know that it is available. So there's something called S100B, neuron-specific unulase, and glial fibrillary acid protein. Okay, these are some of the biomarkers which can be studied. Apart from that, we have lactate, which we are all familiar with, but lactate elevation may mean systemic hypoperfusion or neuronal injury, so it's very difficult to use that for prognosticating purposes. So to summarize biomarkers, there's insufficient evidence to support the use of biomarkers alone to predict outcome after pediatric cardiac arrest, and studies in children are yet to be validated. So biomarkers may be used, but kind of you need to know, use it with caution. So the one important aspect of neuroprognostication is impact of hypothermia. If somebody uses hypothermia, then you need to be very careful in neuroprognosticating, because hypothermia as such is going to alter the cerebral metabolism and neuronal activity. Also, it will prolong the clearance of sedative and analgesic medications. So you cannot put a patient on hypothermia management and then assess neurology or EEG and say that this child is gone or this child is going to have a poor neurological outcome. So you need to bring them back to normalcy. But after bringing back to normalcy, in adults they say it is 72 hours after coming to normothermia, but in children we do not have a particular timeline to say. So we need to be careful. Maybe best to do it 72 hours after achieving normothermia. So far I have spoken about why we are talking even about this topic, what are the challenges we have faced, on what are the different ways of doing things, but I wanted to really look at how each one is doing across the world. Okay, so there's a survey in European PICUs. So even there is no consensus as to how they do neuroprognostication. Most people have used clinical neurological examination. The next most used is MRI brain, and then the next one is continuous EEG. So at least we can take this home that we need to do neurological examination, MRI and EEG to prognosticate. So as usual, because we have very sparse data, we need to look at adult data, and that is much more clearer than pediatric data. So we can use this to kind of have a rough framework, but of course this is adult data, we need to remember, but this has really lot more clarity. So somebody has a return of spontaneous circulation, meaning you have, a patient has arrested, you have achieve spontaneous circulation. Then after that you are going to look at the neurology. If somebody is going to follow the commands at any time or obeying command, okay, awaken them from coma, it is a good prognosis, it's clear, it's straight. Suppose if that doesn't happen, look at whether the patient has got all neurological criteria for death, that is brain death. Okay, if that is present, again death by neurological criteria. So two extremes we have excluded. One is a good, good superb outcome, other is an extremely this side outcome, meaning a brain death criteria is fulfilling. So once that, most other patients will fall into the intermediate category. How are we going to look at them? Again, look at predictors of good outcome. See, the idea behind this whole thing is, we should not brand anybody is going to have a poor prognosis when they have the potential to survive. That is the whole point. So here, first again, you are looking at, is there anything to say that the patient has got good outcome? That's what you are looking at. So if there's motor response withdrawal or localization, if somebody localizes to a painful stimuli, that's a remarkably good thing. Or if MRI with absent or only small DWI, that is diffusion weighted lesions in the MRI between 2 and 7 days from ROSC. Or just remember, everything is or. Even if it is one criteria which is present, it means it's likely to have a good outcome. Then the third thing is EEG. We saw clinical examination, then MRI. The third thing is EEG. EEG shows continuous background less than 12 hours from ROSC, or reactive background less than 24 hours from ROSC. Or if you do SSEP, that is evoked potential, N20 amplitude is more than 4 microvolt, more than 42 hours. So if you have so we have 4 criteria, one clinical, one MRI, one EEG, and one SSEP. If any of these one thing is present, it is indeterminate, but this patient is likely to still have a good outcome. So we will continue therapy fully. But if none of these predictors of good outcome are present, then you look at, is there a reliable predictor of poor outcome? So that in adults have only 2, absent pupillary light responses 72 hours from ROC, and bilateral absence of N20 in SSEP. If it is that, if it is, if both these predictors are present, then the outcome is likely to be poor, but here also there is some uncertainty. So just because these 2 are there, just don't go and tell the, family that no, it is gone. Put other things into perspective. Somebody has had only a 5-minute arrest, maybe we need to give some more time. Somebody has had a 1-hour arrest and you revived after 1 hour, maybe not. So you need to look at that. And if these reliable predictors of poor outcome are also not there, then look at moderately reliable predictors of poor outcome, which includes CT findings of diffuse gray-white differentiation and MRI features of diffuse restricted diffusion and EEG features of burst suppression. So if this is present, again, poor outcome is likely, but again, uncertainty is a lot. We cannot really decide and brand them as it's a gone patient. And if it is no, it is an indeterminate outcome again. So we understand that extremes are easy to prognosticate. The intermediate gray area is still remaining gray, and we need to kind of do more studies and more publications to find out the answers. So to summarize, no single variable has been found to significantly and sufficiently predict neuroprognosticate in children with cardiac arrest. Practitioners should consider multiple factors when predicting outcomes who have achieved ROC. This is one pediatric algorithm which is present in one of the journals in clinical and experimental pediatrics. This has incorporated the pediatric data and adult data. Here again, they're looking at neurological exam, EEG, and brain imaging findings, these 3. And if there are these usual poor prognosticators. Poor outcome is very likely. If it is not there, wait for another 24 hours and do the same thing. Again, if it is present, poor outcome is very likely. If still you are not very clear beyond these three things, you do SSEP, your biomarkers. Then if those are also abnormal, poor outcome is likely. If these things are not there, indeterminate, and you need to observe and evaluate. This is actually my summary slide. And I want to finish with this saying, this is one very beautiful editorial on the same topic. If anybody is interested, can have a look. But the first line of this editorial says, this is 2024, very latest one. And trying to predict the future is like trying to drive down a country road at night with no lights while looking out the back window. So it's as simple as that or as complex as that. And thank you for the patient listening. Thank you very much.
Thank you, Dr. Priyavartini. You have so nicely covered this very important but very difficult subject, and particularly the last 2-3 slides, which are in a so much informative in a short time. So thank you very much again for this. And if there is any question from the audience, I would request.
Thank you. Thank you so much. Thank you.
One factor, especially in peds, is the neuroplasticity.
Absolutely, sir.
And what is the age of the kid, and how much neuroplastic potential the kids still have.
Correct.
That will also be another
Absolutely.
factor, and
Yes, sir.
possibly further complicate the.
Absolutely, sir, absolutely. That's why, in fact, I was very tempted to put up all the adult articles because it's beautiful. It's like one mathematical algorithm they have. But then adults don't have this neuronal plasticity, whereas children have. I have personally had a child who had 1 hour of CPR. After 2 years, came walking and smiled and said hello to me. So what practically we do is we look at these things. But, unless there are clear signs of brain death, at least I personally don't withdraw. And it actually came from, this thought came from one of my senior colleagues. When I sat with him for a counseling, he said, let's not play God. Every time I tell this to myself, let me not play God. Things will declare itself. If things have to go the wrong way, it will declare itself. So if it's brain dead, clear outcomes. Otherwise, you wait and watch. And of course, this discussion has to be openly communicated to the family. This is going to be a long drawn process, may have good outcomes, may not have good outcomes. That needs to be clearly communicated.
We have more reasons to be hopeful.
Absolutely. That's why, even adolescents with severe brain injury after decompression, they just come back pretty much normally. So, it's remarkable that way, and I think we are very fortunate that way that we handle children and we see very good outcomes compared to adults. So that's why, I think that is one of the reasons we don't have very good pediatric data. I think that's one of the reasons. Thank you so much for bringing that up, sir. Thank you. Thank you, ma'am.
As always, a pleasure to listen to you, ma'am. I'd request all of you to kindly step outside for the felicitation, ma'am. We now have a session of 3 small talks, and this session will be chaired by Dr. Ranjana Chatterjee, ma'am, who's ex-professor and head of pediatrics at RG Medical College, Kolkata. Ma'am, I'd request you to kindly take your place on the dais. I'd also like to welcome on the dais Dr. Shati Chakraborty, ma'am, who's ex-professor in HOD at IPGMR. Ma'am, could you please take in place on the dais? Our first talk in this session will be by Dr. Monideepa Datta. Dr. Monideepa Datta is a consultant pediatric intensivist at Manipal Hospital, Mukundapur. She is faculty of the National Board of Education and also an author of a chapter in textbook of pediatric intensive care. This talk is sponsored by Medtronics.
হ্যালো, শোনা যাচ্ছে? Actually, in this session, we are going to have 3 short talks. So 3 speakers will be with us. And we plan to finish the talks first before going for the interactive session. Each of them will be having 10 minutes time. So after finishing within 30 minutes of this part, we will go for the next part. So you have heard the short CV of Monideepa. So I will request Monideepa to start her topic.
Good afternoon, everybody. And it's a pleasure to present amongst all the faculties, the respected faculties. So I am, without wasting much time, I will start. I will talk about the advancements in SpO2 and capnography monitoring. So we every day use the pulse oximeter. This is the for monitoring of SpO2. It is a non-invasive real-time, and it's a continuous monitoring of the oxygen saturations, which is very much reflective of the oxygen status of the patients. And so it is nowadays accepted as a 5th vital sign, and we can monitor it very efficiently and tell very efficiently about the oxygen status. So from the basic of our physiology knowledge, we know that oxygen delivery and oxygen demand should match. Otherwise, there will, if there is a supply is less than the demand, so there will be poor oxygenation. And there is a reduced hemoglobin, which is get oxygenated, and then the percentage of the concentrated oxygen, that is the oxygenated hemoglobin, tells about the SpO2. So principle of pulse oximeter, this pulse oximetry, nowadays all the pulse oximetry is based on the principle of spectrophotometry, which is governed by the Beard-Lambert law. So this is the light absorbance. There's a light emitting diodes which pick up the light absorbance at 2 spectrum, that is the 660 and the 940 nanometers. And this because they chosen these 2 wavelengths because the oxyhemoglobin and deoxyhemoglobin has got very separate absorption in this 2 spectrum. So, and accordingly they have given a ratio of absorbance in the red spectrum and the infrared spectrum, and there's a calibration done with this ratio, and we got the SpO2 value. So there is a comparison of this R and IR ratio which is given, and it is about comes about if it is unit value, that is the when it is ratio is 1, the saturation comes around 85%. So there is, sometimes we get various alarms. There is a very limitations of using this pulse oximetry, and these limitations mainly due to motion. There is motion artifact, there is low perfusion. If the perfusion is very poor, because it depends on the blood flow, there's arterial blood flow, so if the perfusion is very low, that value can be misleading. And also the optical interference around the surrounding light, if that is interfering with the light, because it detects the emitted light. So if the surrounding light is very much, like in if the child is placed under the phototherapy or in a very bright light situations, then it can give false results. And also the pressure, we apply some pressures where sometimes we didn't give the value and we apply the pulse oximeter very tightly. In that case, we may get a wrong value, because that cannot detect the arterial pulsation. So this is the motion artifact. If there is a motion artifact, the graph we get usually like this. Instead of a normal looking plethysmograph, we get this like a chaotic graph. So, and in low perfusion, the graph will be of low amplitude. We can make out every day we see in our pulse ox monitor that the graph is very much low amplitude in a shock state. And this is ambient light, as I have already told. This can interfere with the photodetector detecting the light which is passing through our blood. So all this can be very way now with the newer machines we can all these problems can be solved with to some extent. So, and this is the pressure that the vein pulsation can be if there is a change of color, sometimes we also see that there is change of color due to so tightly we apply the pulse oximeter, especially the wrapping pulse oximeter used for the neonates or the small child. We can see there is hardly any pulsation, any perfusion beyond that application. So there is, we have, since it's a sponsored talk, I have to talk about something about the pulse oximeter, which is available with us. That is the Nelcor's pulse oximeter, which can circumvent all these problems, try to this. So this is the pattern recognition analysis. It is the normal pulse. As we can see, this is a plethysmograph. So if there is motion artifact, this is the motion artifact graphs look like. So to counteract this motion artifact, they have the technology that is the cardiac gated averaging. This is a newer pulse oximeter use this cardiac gated averaging, which is the normal pulse. If this cardiac pulsation is getting taking up in the also in the motion artifact, they are nullifying the motion artifact graph. So if we take an average, how the pulse oximeter works, if we take an average of like 5 readings, every 0.2 seconds they are taking readings, and this according to the calibration parameters, there's about the 5 readings, they are dividing by 5 and we get the reading of more 94%. This is the older version. But when we use the cardiac gated averaging, what it is doing, it is taking the immediate after the immediate previous reading. That is, it is not the whole 5 reading, just one reading, and after that reading, 2 readings, like suppose in 98 and 94, we are taking this, then average is done with this 98 and 94, and which comes around 96, and again the third reading we are taking 93 to 96, and this goes on. This is not the whole 5 reading we are taking average of the whole 5 reading, just the 2 readings we get an average, and with this average we are taking the number of the third reading, and this previous average we are getting another reading, and with this average new value we are taking another value, that is the 4th value, and this way we are calculating the cumulative value. It is not all of our 5 readings in 1 minute. It is in 1 minute we are taking multiple average depending on the previous one and the immediate post which is coming. So it is more accurate. Instead of 94 as in the previous one, you get what if you average this, we are getting 92. So for more accurate reading, this cardiac gated averaging which they use is for more accuracy and to nullify the effect of motion artifact. If there is motion artifact, that effect will not be taken up. So they will take up the exact value. When we get that exact value, and we average with the immediate after what you get. So this is for low saturations, the FDA approved the accuracy because the problem we get with all the pulse oximeter, they act very nicely around 75 to 80% to 95%. But usually what we get is the hypoxic child, when the saturation is usually less than 80% or 75%. In that time, there's accuracy which matters, because every time we cannot do a arterial blood gas to know the oxygen status. So we need something very accurate which can non-invasively monitor our patient's oxygen status. So for low oxygen saturations, this cardiac gated averaging acts very nicely, as they have shown in various studies. So also the speed and the consistency. This is the paper. They have the different. They have quoted different with the different machines, and they have that this accuracy is very much high with this Nellcore and compared to the other which is available with us. So about the speed, every seconds matter. We know how fast we can detect the saturation of the patients. How this is very much important. So this is about if we first attach the sensor to the patient and then to oximeter, we can this time is, as you can see, this is just 11 seconds. So instead of waiting for a half minute or some more minutes, we can know about how what is the saturation. We can act very fast according if we can take up this very rapidly. So we believe that cardiac signal is the key to maintain other signal interference, and so we can use this technology more and more. And this is the various sensors available with them. There's a reusable sensor wraps is also there. And this is the 4-8 sensor. This is for the patients because sometimes we have there may be gangrene in the hand or any burn, or the perfusion also, the peripheral perfusion can be very low. We usually attach to ear lobule when we do not get in the hand. So in that case, because the perfusion to the head and face remains up till very late period, so we can use the 4-8 strap, which can detect, rather than applying it over the fingers or the toes, we can apply it the force in 4-8 for accurate measurement of the pulse oximeter in case of low perfusion or when it is not feasible to attach in the hands and foot. So also they have the non-adhesive sensors, which in case of neonates, because the neonate skin is very much allergic to the adhesive we use and very much sensitive. So in case of neonates, they do not, some non-adhesive sensors is available, which is reusable also. So we can use this with more accuracy. So this is the, and another, so about this is the cardiac gated averaging, the newer technology they are using, which is very much useful to detect the pulse oximetry very fast, that is within 11 seconds as they quoted, which we need actually. When we are managing a hypoxic patient, we need a faster and a very accurate reading. So with this, we can get this. Now about them, something microstream capnography, that is also a recent advancement in the detect the EtCO2. So what is the capnography? It is used by the anesthesiologist to detect the EtCO2, which we can, again, we don't have to invisibly prick every time for an arterial blood gas to detect the CO2 status. And it is also important, so whether how much CO2 is eliminating, know about our ventilations when we are ventilating a patient. Even after the cardiopulmonary resuscitation, if shows the rise in the EtCO2, that is the first marker that your patient is resuscitated adequately. So it is a numerical value. We all know it is a numerical value of the EtCO2, and there is also a graphic waveform of the concentration of EtCO2 over time. The real respiratory rate detected from the actual airflow. So this is the capnometer, is the numerical measurement of carbon dioxide, and the capnogram is the waveform which we show in our monitor, which displays the carbon dioxide over time. And as these two are very much important, as I have mentioned, this is the reflects the oxygenation status, and capnograph reflects the carbon dioxide status. So this is the waveform which we usually get. This is the normal waveform with the patients normally breathing and eliminating carbon dioxide very nicely. In case of hyperventilations, that is very, the respiratory rate is very high, but the EtCO2 is lower because patient is eliminating the carbon dioxide more than usual, which is actual rate. And this is the hypoventilation. When the respiratory rate is very low, the EtCO2 will build up. The carbon dioxide will build up, and we can get a higher value of EtCO2. So it is the microstream technology with what they use. Actually, this is this can be, the EtCO2 can be picked up by a mainstream technology. We can attach in the mainstream or a side stream. From the airway, we can use in a side way and or in the mainstream. This is the side stream airway and technology, because this is not interfering with the flow, and also the moisture which is coming to when we are we are also exhaling some moisture. This moisture can interfere with the reading of the EtCO2. So they are eliminating that also. And this is a laser-based CO2 specific technology, and is very specific for the carbon dioxide also. Only because there are lots of air coming in the air. Also, there are lots of air, and this is the very beautiful about this microstream technology. It can be used in intubated and a non-intubated patients also. Usually, where you use in the EtCO2 in a intubated patients, whatever is available in our with us is usually the older version is the intubated patients. But in a non-intubated patients, when the patient is in nasal prong or in a oxygen mask, especially with oxygen, we can also detect what is the CO2 status. We can monitor whether carbon dioxide is building up or not. Then we can decide about the plan of the management. So it is not just intubated patients we can use. So for this, we can. It is very advantageous if we pick up the CO2 only, because they the non-intubated patients. Intubated patients mostly we get the carbon dioxide, not the other air, components of the air very much. But in the non-intubated patients, that can be other components of the air. There's other than carbon dioxide, that must be all the other components of the gas must be there, which can hinder the actual CO2 value. So it is very specific to have the CO2 actual level. So another advantage with this is the very low flow rate, because in case of neonates, the flow rate may be very low. So it can detect is the 50 ml per minute only the gas flow. If the single breath, this can detect the CO2 level. You need not to breathe a very high volume, breathe out a very high volume of gas. Just a minimum shy of gas can give rise to a EtCO2 value. And it is also laminar flow. There is less turbulence to the flow and accurate monitoring. So but it is arranged, can be used as in neonates. From neonates, it is the specific advantage for the neonates, because they have very small tidal volume. So these are the various filter lines for microstream. This is a single one-piece conduit. It is very user-friendly, as I have already mentioned, both for intubated and non-intubated patients. And these are also can the alternating mouth and nose breathing, they both can be used. As you can see in the lower right picture, because the children can breathe out from the mouth also, not just nose, they can breathe out from the nose. So from this, when you attach this, when one probe is going to the nose and other one is the mouth. So in the lower right, this probe can detect the whole of the CO2, not just the nasal one. So intubated, there's a long-term and short-term use, and neonates, they can be used for very long period. And this is the line where there is a water filter. And this water filter, it can absorb the water from the expired air, so that will not hinder your CO2 value. So it is very lightweight. It is two-port design, reduces occlusion from the moisture and secretion, allows flexible positioning in breathing circuit.
Monideepa, you have finished your time twice.
Okay.
So hurry up.
Okay, sir. So these are the different filters available with this. So thank you.
Sorry.
So the next speaker, the next session, or the part of this session is of fungal infection in PICU, and the speaker is Dr. Krishna Mohan Gulla, and he is a consultant PICU, AIMS, and the rest will be shown in the CV. So, And as we all know, who are dealing or who are continuously working in PICU, how important is this fungal infection is, its problems and its treatment, they all face this. So, Dr. Gulla, please.
Thank you, ma'am. So I will be So, it is a very common topic that I don't want to go very in detail because you're all expert in this. So, outline of my talk would be what is the definition of invasive fungal infections and risk factors we have, and what are the diagnostics that we are supposed to do, and how do we manage in brief, and actually what we actually end up in doing when a patient comes to you with fungal infections. We all know that the proven infection is it is a presence of fungal ailment, either as mold or yeast in deep tissues, in a FNAC or biopsy, that is confirmed on the culture. That is called as proven IFI. And if you have at least one host factor like immunosuppressive host factor is there, and radiological criteria is present, and one biomarker criteria is present without the microbial evidence, it is called as probable IFI. And if you have host factor plus radiological criteria only, which other times we use this term possible IFI without any biomarker or microbiological confirmation. We all know that Candida is one of the most common organisms that is we see in ICUs. The majority of the portal of entry is to the gut, followed by your skin. And nowadays, for the last 20 years, it used to be albicans. Now the non-albicans species have been increasingly found in the ICUs, Glabriata, Paracelsus, and Tropicalis. And again, the data is very mixture depending on the ICU work. And the rampant use of fluconazole and caspofungin is resulting in a lot of resistant pattern in the Candida. These are the common risk factors that we see for Candida. We know that is prematurity, burst of antibiotics, TPN, invasive ventilation for a long time, dialysis, malignancy, neutropenia, long-term steroid use, and organ transplantations. For Aspergillus, again, the immunosuppressed patients are there. Along with that, we need to look at the dampening of the walls in the ICU and the constriction near or inside the hospital, which is very pretty common in the clinical scenario. And for mucor, apart from these factors, diabetes is one of the risk factors for invasive mucor infections. We face a lot of challenges in diagnosis of infections in children because the signs, symptoms are radially very non-specific. You cannot pinpoint that this is because of the fungal infection. And the sampling is very challenging in pediatric population, like need to take a biopsy or BAL who is critically ill and who is thrombocytopenic and hypoxic. And we need to take a lot of large volume of sample, like blood also, it may not be practically possible. And it is the Aspergillus, like fungi, rarely culture from the blood, and the BAL culture positivity are up to 30 to 50% only. And again, the tissue culture positivity, even if you take the tissue culture, the positivity is very less. And again, the slow turnover time, it take up to 4 weeks for the culture to come. These are the challenges we face in pediatric population. Sometimes even if the patient is having severe disseminated Candida, we may sometimes get very low yield because of low Candida cell count. Or sometimes like malaria also, there is temporary presence of yeast in the blood. And there will be sometimes the intercellular absorption of the Candida into the macrophages or leukocytes. And often we take, for namesake, we take the blood volume around 0.5 ml, 1 ml to color the blood culture bottle. So these are the factors which we result in the low yield of the Candida. And look at the fungal biomarker, which we commonly, this is one of the diagnosis modality we use to diagnose fungal infection, that is galactomannan, beta-D-glucan, mannan antigen antibodies. And nowadays, recently, majority of the hospitals, they have the lateral flow assay for Aspergillus. That is a point of care test that can be used, that we can do in the ICU itself. But if you look at the galactomannan, it performs better. The literacy predominantly is from the hematologic malignancies compared to the other transplantations. And if you not only single value, the serial values will be helpful for diagnosis as well as for the prognostication whether the patient is responding to the treatment or not. And if you have two consecutive values of 0.5, it has dimensionless galactamine is dimensionless value. And if you, any value of more than 0.7 in the BAL or serum, that can be considered as the positive, provided the patient is feeding into your clinically suspected infection, fungal infection. But the problem with galactamine is that if you take the sample after antifungals, the yield, the results will be less, and you may get false positive values with antibiotics like peptides, augmentin, cephalosporin, sulbactam, because the basis is because these antibiotics derive from the penicillins. And you have cross-reactivity with other infections, and if you have severe mucositis that we see commonly in the neutropenic patients, there is a translocation of this food material into the bloodstream and cause false positive galactamine values. And ice pub water contaminated with penicillium, sometimes IVAs also will give the false positive galactamine values. If you look at the galactamine in the BAL, which is commonly sent in from ICUs, there is no specific cutoff, but if grossly, if you take more than 1, because majority of times our lungs are colonized with the aspergillus. So that is the reason they have taken larger cutoff for infections. If you take more than 1, it is sensitive compared to the culture. The sensitivity is around 78%, and specificity around 93%. Other marker which are commonly used in clinical practice is beta-D glucan. It is a pan-fungal marker except for mucormycosis and cryptococcus. It is less than 6 is negative, more than 80 is positive. But mind you that this is the cutoff values for the candida, not for the aspergillus. That we need to take into consideration. And there are a lot of RCTs conducted in the pediatric adult population. For empirical antibiotic therapy, antifungal therapy, therapy for candida in adult ICUs, they found that whether if you give the beta-D glucan guided therapy, it resulted in the less duration of antifungals, but not with increased mortality or length of stay or invasive infections. This is a recent study published in 2022. It is Candicept trial. So they included 342 patients, adults with sepsis and those who are increased at risk of invasive infections. And they had 2 groups for the fungal therapy, that is galactamine and beta-D glucan guided versus standard treatment. They looked at the primary outcome was 28-day mortality, which is not significant between these 2 groups. And again, the secondary outcomes like length of stay and winter-free days are similar in both the groups. Again, it is false positive in the patient is having PCP infections or undergoing dialysis because of the membrane and IVAZ, albumin, the gauze packages, antibiotic like augmentin and bacteria like Pseudomonas will give the false positive beta-D glucan values. This is one point of care test recently introduced. It detects the manoprotein in the cell wall of the fungus. It has, compared to the galactamine, it has sensitivity of around 68 to 76%. And compared to the galactamine in the BAL, it has specificity of 93%. So it can be used because it is easily available at the bedside. But it is not, again, evaluated in the pediatric population. Again, these other two tests, that is Mannan antigen and Mannan antibodies, there are few centers they use for detection of the candida infections. Again, majority of decisions are based on the clinical host factors and the radiology and the biomarkers. So if these is a classical textbook teaching that if the patient is having nodules, cavities, halo sign, Erickson sign, wedge-shaped infarcts, then you suspect fungal infection, but it's not actually the true. But the population in which they are studied in the immunocompromised patients, especially in the hematologic malignancies. But what we see in the pediatric critically ill, non-neutropenic critically ill patients, that it may not be the true. Again, if you have fungal infection, fungal abscess causing caused by this fungal infection, that you need to look at in the radiology. Again, you need to look at the candida score, that when a patient is in ICU for a long time, if he has these factors like TPN, surgery at the ICU admission, severe sepsis and TPN, they have the score. If the score is more than 2.5 or so, then you say that the patient might be having increased risk of having invasive fungal infection in the next coming days. Again, the prophylaxis, many times we use the prophylactic agents for antifungal in ICUs. I'm not going to go in detail in this. Again, how do you prevent the candida infection? That is by probiotic therapy. Then I will be telling about the few studies from PGI. And daily chlorhexidine bathing and antibiotic impregnated catheters, they don't directly reduce the prevent the fungal infections, by indirectly reducing the bacterial infections, resulting in the reduced use of antibiotics, and then resulting in secondary reduction of the candida infections. This one study from the PGI, they looked at observation study before and after study. They endured those patients who have a broad spectrum antibiotics for more than 48 hours. They have given probiotics, and they compared the historical group 9 months back, and they found that those patients who received probiotics, there was candidemia of 1.2%, and the controls, the incidence of candidemia was 3.7%. And again, the candidemia is less in the probiotic group and more in the control group. And in the to prove that they did an RCT, their primary outcome was rectal colonization. So those patients in the probiotic group, by day 14, they significantly less colonization compared to the placebo group. But however, the candidemias didn't differ between these two groups. The treatment, we know that the first choice for candida is echinocandins in neutropenic and non-neutropenic patients. If there is contraindication for that, then you can use for the fluconazole or amphotericin B. And again, echinocandins are not recommended for eye and CNS UTI infections, and voriconazole is not for UTI because it is not excreted in the urine. And duration of therapy is 14 days for candidemia after the first natal blood culture. For endocarditis and CNS, at least 6 weeks. For pyelonephritis, 2 weeks, and for eye infection, at least for 4 to 6 weeks. And for aspergillus, the first treatment is voriconazole. Alternate, if you have contraindications for voriconazole, you can use amphotericin B. And you can add echinocandins as salvage therapy. Again, the duration is, minimum of 6 to 8 weeks, 12 weeks of duration you are supposed to give. And for mucormycosis, the main treatment is surgery to remove that part that is infected with the fungus, and followed by the chemotherapy, that is amphotericin B. And if you have contraindication for that, you can use posaconazole. Again, similarly, what do you do for the antibacterial stewardship? You should have the antifungal stewardship in your ICU because of the high rate of invasive fungal infections in ICUs. And again, you need to have early diagnosis and rule out tests to reduce the duration of treatment, therapy, and resistance. And again, you should have multimodal approach, like you should have rapid diagnostic test, therapeutic drug monitoring if it is possible, and then you should have an ID specialist so that he can guide you in treatment. So actually what we end up in doing is, we suspect IFA in high-risk patients. They're not responding to the conventional broad-spectrum antibiotics. We send urine KOH, beta-glucan, blood and bowel cultures, and galactomannan and lateral flow assays. And they start treatment with fluconazole or caspofungin, not responding, we upgrade to voriconazole amphotericin. This is what everybody does practically in their ICUs. So you need to identify the high-risk patients, the consider fungal workup when the patient not responding to the conventional antibiotics, send cultures in histopathology if possible, and biomarkers aid in the diagnosis as well as the prognostication, and you should make a decision based on the clinical features of biomarker radiology. This is what we actually end up in doing. Thank you very much.
Thank you, Dr. Krishna, for your very important but crisp lecture on fungal infection in the PICU. And the questions, if there is any from the audience, will be invited at the end of the session.
Lastly, we are inviting our third speaker, Dr. Shotobrato. Yes. You start your topic and stick to your time, please.
So today my topic is role of hypertonic saline nebulization in PICU. So 3% nebulization, 3% saline in a hall where we are talking about neurocritical care. It's all about, we usually think about infusion, but it is not about infusion, it is about nebulization. And hypertonic saline, if you use it at nebulization, it will come under the group of mucolytes. How it acts? It draws fluid from the mucous layer and dilutes the mucus and increases the clearance and usually hydrates the mucosa. Now, the roles are mostly studied in bronchiolitis, cystic fibrosis, and non-CF bronchiolitis. The role of hypertonic nebulization mostly we use in our ICU is always bronchiolitis. And bronchiolitis is disease of a small airway, and that gets inflamed and lots of secretions, and these secretions causes mucus plugging in the smaller airways and causes obstruction, and always there is also edema. And if we use hypertonic saline in these cases, what will happen? They will draw the fluid from the mucous layer. It will decrease the mucosal edema. It will hydrate the airway. It will dilute the mucus, and it will improve the mucus clearance. So theoretically, it is looking that it will work. Now, what about the clinical evidence? If we go through the Cochrane database, it will show that first, safety. Is it safe for the child? Safety was studied in 27 studies, and 14 showed that there is no significant side effect. And 13 trials showed some side effects like agitation, bronchospasm, bradycardia, desaturation, vomiting, diarrhea, etc. But most of these side effects are very minimal and self-resolving. So really there is no significant issue with safety with this drug. Now, is it effective? Nebulization hypertonic saline may modestly reduce the length of the stay among the infants hospitalized with acute bronchiolitis and may slightly improve the clinical severity score. So it works. And sometimes if we use it in emergency department, it can reduce admission also. Now, what strength we should use? Is it 3%, 5%, 6%, or 7%? There are lots of studies with higher strengths. And if you go through some of these trials, the trial done by the Jacob, they have done with 7% saline, but they failed to show any advantage of that compared with 0.9%. And second study, they have done compared 3% with 6%, and they also failed to show any significant difference. Another study was done with 3%, 7%, and 0.9%, and this study also failed to show any superiority with hypertonic saline with hyper concentrations. So the question of superiority of higher concentration of hypertonic saline remain unanswered, and it will require further large-scale study comparing with larger amount of children and with proper protocols. So what is the current recommended dose? The most common studied regimens are 3% saline, volume of 4 ml per dose, 4 to 6 hour basis. Now, it is always has to be used with some other supportive treatments like oxygen therapy. Most of the studies use short-acting beta agonist, but it has, as per the evidence, it will improve the clinical symptoms transiently, but it doesn't have any role on the disease course, length of the stay. But racemic epinephrine mixture has been proven to shorten the length of hospital stay. Corticosteroid has not any proven role, antibiotic doesn't have any proven role. Now, second disease, cystic fibrosis. What is the disease? It is a defect in the CFTR gene, and that leads to the excess absorption of fluid from the airway surface layer. And what does that lead to? That leads to the decrease in the length of the ASL, and there is airway blockage, thick secretion, difficulty in clearing secretions. And we know that hypertonic saline will draw fluid from the mucus and increase the length of the ASL and improve the hydration of the airway and improve the clearance of the mucus. But what about the evidence? Now, as per the Cochrane database review, it is uncertain whether the regular use of nebulized hypertonic saline in a stable lung disease leads to an improvement in FEV1 predicted at 4 weeks. So it is not very clear that if we use it regularly in a child, it will cause some improvement. But it has shown that at the time of exacerbation, if it is used along with the physiotherapy, it may have positive effects. So, but this evidence is not that good. It is a very low or low grade evidence. Now, which concentration we should use, 3% or 7%? There is, the recommendation is one study compared 7% saline with lower concentration, that is 3% saline, but it cannot be ascertained that higher concentration improved lung function. So this trial also failed to prove that higher concentration of hypertonic saline is better. So it needs further study. So, and about the safety, the trial didn't report any serious side effect with 3% NaCl nebulization in cystic fibrosis. So what is the recommended dose? 4 to 5 ml twice daily improves the FEV1, approximately 40 minutes nebulization per day. Now, nebulization of hypertonic saline in non-cystic fibrosis bronchiectasis. Most of the data in this group has been extrapolated from the cystic fibrosis group. And same way, the hypertonic saline in this group of disease also reduces the sputum viscosity, increases the lung function, and decreases the frequency of exacerbations. Due to this, there are some recommendations of use of this hypertonic saline in non-cystic fibrosis bronchiectasis. If it incorporated along with physiotherapy, it has proven that dynamic lung volume and morbidity in children has been improved in non-cystic fibrosis bronchiectasis. Now, another issue. Prophylactic use of nebulized hypertonic saline in mechanically ventilated children. So, when we are doing a ventilation in our ICUs, the child is always at risk of getting thick mucus and mucus plug in the airway. Why? Because there is less coughing, the power of the respiratory power is decreased, and the child is dehydrated due to some protocol. We keep the child dry, and last of all, the medical air may not be adequately warm or hydrated, moist. So this all leads to insufficiency of the secretions in the airway and may lead to different manifestations and complicate the ventilation duration. So theoretically, it looks that if we use 3% NaCl in this child regularly as a prophylaxis, it may work. Now, what about the evidence? RCT was conducted below 18 years old children who were intubated less than 12 hours and expected to be ventilated more than 48 hours. 3 ml 3% NaCl was nebulized 4 times, and it was compared with 0.9% saline. And what was the result? The administration of prophylactic nebulization hypertonic saline to mechanically ventilated children did not improve clinically relevant outcome, including duration of mechanical ventilation. But it was an underpowered study. So we need adequate power clinical study to prove the role. Now, if there is, as per our experience and current ICU protocols, there are some recommendation of use of hypertonic saline in intubated child in a specific situations, like lobar collapse, atelectasis, unilateral or bilateral, abnormal radiological changes in X-ray suspected to be caused by mucus plug, or if we are seeing that secretion is very thick and it is very difficult to remove, we can use this 3% NaCl nebulization. So as for now, to conclude, I would say that 3% NaCl, higher concentration of hypertonic saline, more than 3%, is not recommended. And 3% NaCl nebulization has a very good recommendation in bronchiolitis, and it can be used in cystic fibrosis and non-cystic fibrosis bronchiectasis. And there are some specific indication for 3% NaCl nebulization in intubated children. Thank you.
Thank you, Shotobroto. We have finished our short talk session. Now we have hardly 2-3 minutes left for the interactive session. So I will request all the speakers to be here just for having this, taking the questions from the audience if there is any. So anyone who is interested to have some, yes. Just come and sit there. Yeah, all of you come to the dais and sit there. Huh? 3 seats are here, Baba. 1, 2, and 3. Yes.
My question is related with fungal infection in PICU. If the in a patient who is in PICU and staying for longer period, usually what is seen that more than 2 weeks staying, so give prophylactic antifungal like that. And suppose the patient is diagnosed as probable case, so no culture positive report. So how long antifungal treatment to be continued in this scenario?
Yes, sir. Again, what you said is the classical problem we face. So if you look at that studies that I quoted from adult population, so they, if you have the facility of doing a beta-D-glucan, then if the levels are reduced, stop, and you don't have, culture will take some time. And the median duration of giving antifungal in that particular population that is guided by the beta-D-glucan was around 5 days. So they say that, again, if you are guiding, one is two principles. One is the clinical decision, what you do. ये मेरा मर्जी है, मुझे लग रहा है कि मैं दे दूँगा 10 to 14 days. That's what everybody does in the ICUs. So what they wanted to look at when you're starting with empirical antibiotic therapy in the high-risk patients. So if they looked at the beta-D-glucan, if it is negative for day 0 and day 4, then they stopped it. And they didn't find that these patients will be getting the invasive fungal infections in future. So if you have the facility of beta-D-glucan, that you can do, sir. Again, I have no answer regarding that, again, because an estate clinician like you will take a decision whether to stop or not.
But there is a definite indication for prophylaxis in case of PICU, antifungal prophylaxis.
Yes, ma'am.
In NICU it is there.
Yes, ma'am. So the prophylactic and antibiotics will give when there are, so antifungal, sorry. So prophylaxis means when there are no clinical symptoms, no radiology, no biomarkers, nothing. Like transplant patients. There you say that these patients are going to have, then you will give prophylaxis.
So what are those conditions?
So, when you have like transplantation patients, those are the classical example of these things.
I think devices for long time, immunocompromised.
Again, for long-term devices, there is no concept of giving prophylaxis, ma'am. No, sir. In pediatric also we never, yes, in pediatric also we didn't see those type of severe mucor in pediatric population at least.
I'm trying to understand about the 3% initial. So the story probably started from 2007 onwards in bronchiolitis. So there are multiple RCTs, systematic review, and people feel from their gut that there will be some benefit. But from the RCTs or the systematic review, there is no robust evidence to say that 3% initial is essential and you have to use. Now, I think that is true because the main mechanism, if it is because of the hygroscopic effect, just draw the fluid from the vessels to the airway, if that is the main mechanisms, that is probably not going to act because your mucosa, like the tracheal this lining, that is not impermeable or semi-permeable to 3% initials. Second is the mucus that is too thick, that can't be like dissolved with this water. So again, I can quote one book that is written like this about these things, water installation during tracheal suctioning. They said it is just like pouring water on a grease. So it is never going to liquefy the grease, something like that. So if you have to liquefy this mucus, then you have to use some kind of recombinant DNAs and something like that. So like, please clarify, like what is the evidence?
There are some RCTs that have shown that 0.9% saline compared with 3% NaCl, and they have not shown any benefit. But recently, all the reviews, current reviews of Cochrane has shown that 3% NaCl nebulization can reduce the duration of hospital stay, and they have shown that if it is used in emergency, that can reduce the admission. Current review 2023 Cochrane. And so I have not remembered, I have to see that thing. But there are some studies that have not shown any benefits. But and second, they have some studies have also studied that these 3% NaCl as a mucolytic therapy, they, as DNase act, they also act as a mucolyte. They have a DNase property. 3% NaCl had a DNase property, and they can also act like that way. And it usually draws the fluid not from the vessels, from the mucous layer, and it usually dilutes the mucus, sitting over the mucous membrane.
We are
so
afraid
just one question to
running short of time.
So, okay. So if you are using 3% or 7%, if it is a counter irritant, so do you use bronchodilator prior to that? And most of the time, 3% or 7% we are using for cystic fibrosis patient. What is your take and what is your unit policy?
So 3% and 7% till now has not been proven superior to 3%, but it may produce some irritations. And if you are using 7%, then we should use, I think we should use some bronchodilator along with 7%. But in 3%, also there are studies that have shown to use salbutamol along with the 3%. But it is not, we are regularly using salbutamol along with the 3%.
So this is the end of this session. Thank you all the speakers for your nice presentations, and thank you our co-person also.
Thank you all. Kindly step outside for the felicitation and memento. Our next talk will be on brain death and organ donation, and this session will be chaired by Dr. Arun Manglik sir. Dr. Arun Manglik sir is president of the West Bengal Academy of Pediatrics. I'd also like to call Dr. Shishu Kamath sir on the dais, please.
So welcome, Dr. Kamath. And,
Thank you, sir.
An important topic, no, organ transplantation and brain death. I think that was his topic. So when would we consider a child or a patient to be brain dead, and when would we consider that to be a fit patient for an organ transplant? Of course, with the consent of the family and others.
Yeah.
So it's an important one. Please start.
Thank you, sir. First of all, I would like to thank the organizer for giving me this opportunity to come to your city of joy. I have to confess, this is my first visit to Kolkata, and I am swooped by the city's old world charm. Having said so, the topic that I'm going to talk is going to be quite morbid. It's not going to be so happy. Brain death and organ donation. So I directly start with a case that was there with us 2 years back. This is a 16-year-old boy with a history of high-grade fever for 2 days, 1 episode of seizure, admitted in another hospital. Dengue positives, platelets of 78,000, no hemoconcentration, brought to ER. He had already had an episode of seizure in that hospital, brought to the our ER with episode of seizures, pupil unequal and labored breathing. Intubated in ER with mannitol and other precautions, CT done, and rolled into OR directly because of hypodensities in the cerebellum with possible upward herniation. Instead of downward herniation, this was an upward herniation and gross acute hydrocephalus. Immediate posterior fossa decompression was done, EVD inserted, and the cerebellum biopsy was sent for referral laboratory at NIMHANS in Bangalore. The child was shifted to ICU.
with both the pupils unequal, no spontaneous breathing. The cerebral biopsy was suggestive of dengue infections. On day 5, he started responding to painful stimulus. Pupils were equal and reacting, and a week later, ICP was low, and EVD was removed, and a programmable VP shunt was placed at fixing at 8 millimeters of mercury the pressures. He underwent PEG and tracheostomy, approximately treated for fever. His pupils slowly started reacting, and repeat MRI started showing hyperintense lesions in bilateral lentiform nucleus and caudate nucleus. He again started having seizures requiring thiopentone infusions, and ICP monitor was reinserted with ICPs of around 25 to 30, going as high as 50s as well. Multiple boluses of phenobarbital, other anticonvulsants were given, but seizures continued. We in fact even gave steroids and did plasmapheresis, IVIG, but nothing worked. And finally, he developed diabetes insipidus, hemodynamic instability with multiple vasoactive agents. And CT angiography showed the internal carotid artery with no blood flow above the neck. What you see is the internal carotid artery there. So this child was then declared dead because parents didn't want to do anything further. And he was diagnosed to have severe brainstem dysfunction, which is the diagnosis what we write on the death certificate. So brain death determination is something which is a concept that is actually having lot of doubts. Majority of us are in a state of dilemma whenever these has to come, because it's once in a month or once in a year that you have to actually do the brain death testings. It's not a routine phenomena in the PICU. The Organ Transplant Act, which was passed by the Indian Parliament in 1994, we follow the UK concept of brain stem dysfunction or brain stem death compared to the American, which is brain death. And the confusion arises because the Indian Penal Code says that word death denotes death of a human being, whereas we take only the brain has died, whereas the other organs are still functioning. So this creates a confusion in the bystanders as to why, what actually is happening with the kid or this thing. And what is the scenario of organ donation in India? Coming from a state of Tamil Nadu, we were the first state which made death certification mandatory in 2008, and the government instituted green corridors to transport donated organs, and non-transplant hospitals became were allowed to do brain death testing and improved the donor pool. From 2008 till 2022, total of 783 organ transplants have been done in Tamil Nadu. Today we rank the second in the country. We were first at one point of time. Now Delhi has overtaken. Foundations like Mohan Foundation have taken a key role in organ transplantation. The organ transplantation in India is predominantly an adult field, where you can see after 2020, after the COVID phenomena, the organ donation has significantly increased to around 16,000 now. The last data from the transplant registry in India showing around approximately 16,041 organ transplants being done. Delhi leads the list this year with 3,000, approximately 3,000, followed by Tamil Nadu and Maharashtra, and Kerala, Telangana, and West Bengal follow them. When we talk of brainstem function, we know that midbrain, spawn, and medulla are the vital organs situated there, and these organs control your heartbeat, breathing, and circulation. So any damage to this organ, your reticular activating system is damaged, and the person goes into unconsciousness and coma. Any irreversible damage to this, then it's very unlikely that the patient will come out of this. So this is very important that you diagnose brainstem death and distinguish it very clearly from persistent vegetative state, wherein the brainstem is only injured. So it is in a state of injury, it is not dead. But in brainstem death, it's complete dysfunction. We call it dysfunction, but it's complete stoppage of functions of the brainstem functions. So the major causes of brainstem death in adult definitely is direct trauma to the head, as in road accident. There's subarachnoid hemorrhage and ischemic stroke. and intracerebral hemorrhage and HIEs are the cause. Whereas in pediatric, the direct trauma to the head could be road accident again, which is the predominant cause of brainstem death. At least in our unit, we have a good trauma unit where we get a lot of children with head injuries. Fall from height is something which has to be prevented. Many of the time, societies and buildings do not have their, sorry, somebody's moving, do not have their verandas been grilled. Children have fallen and died from the heights. And that is one thing which is very, very important. Other causes being infections, raised ICP, subarachnoid hemorrhage do contribute a little addition to the pediatric causes of death. When we say brainstem death, it's medically and legally defined as a total irreversible. That is important. The term irreversible is very, very important, and irreversible cessation of all brainstem death. And diagnosis of brainstem death is after the discontinuation of artificial ventilation, when you ask for the parents for organ donation. So remember, it's only for organ donation you can do brainstem testing. Otherwise, you are not allowed to do, as per the law, the brainstem testing. This is according to the Transplant of Human Organ Act in 1994. So who should diagnose it? All of you are aware, it should be a team of 4 medical experts, the medical administrator, an authorized specialist, neurologist or neurosurgeon, and medical officer treating the patient. Any of these 4, including, should sign on the document along with the person doing the brain death testing. Now for brain death testing, when we do, brain death or brainstem, there will be slight change in the terminologies when I was writing, because ideally it should be brainstem for India, and in America it should be brain death alone. We establish the reason for coma. We have to exclude all our known and unknown confounders. We have to ascertain the futility of the intervention, prepare the patient for testing, and acknowledge that the clinical examination alone is the gold standard. You don't need any other ancillary testing. Based on your clinical acumen only, you will have to certify the patient has brainstem death has occurred. And the 3 important questions that you have to ask yourself when you do brainstem testing is, have I tried everything to change the clinical picture? Can I proceed with brainstem testing? And can I be fooled? There is always a chance that you can be fooled, that the child might be a case of, say, the nurse has given a wrong dose of vecuronium and the child is still in that stage, or say a snake venom poisoning or a GBS. These are the conditions that you have to rule out. So before you go for the testing, make sure any of these confounding factors are ruled out. So these 3 questions are definitely vital before you actually rule out. When we look at the diagnosis of brainstem testing, I will not go into detail because every hospital usually keeps a prototype of brainstem testing. You will have all the brainstem reflexes to be tested, right from pupillary right reflex, Doll's eye movement, corneal reflex, no motor response to stimulation, no gag, no cough, and vestibulo-ocular reflex. All of this has to be tested. Missing out a single test will not allow you to go ahead and declare the patient dead. But most of it, the first thing all of you need to remember is the irreversible brain damage. That has to be very clear in your brain, that this cannot be reversed by any treatment that you are going to give. And you should rule out all the reversible causes of coma. So the patient has to be given adequate time so the drugs are metabolized in the body. There is always a question whether if he is on phenobarbital or anticonvulsants, whether we can do brainstem tests. So usually we give a period of at least 6 to 8 hours, and after that we do testings, because by then the drugs will be below the therapeutic level and they will not be working. So you need to rule that out. And one important test that the brainstem testing always mandates is the apnea testing. So now the prerequisite for apnea testing, you have to make sure that the child is having a normal temperature, blood pH is normal, the blood pressure is normal, he's eucapnic before you start the test, and there is no hypoxia. And apnea test should not be performed when the subject is under the influence of paralyzing agent. These 6 prerequisites are very, very essential, because you cannot paralyze and say that the rise in CO2 did not cause the patient to breathe. The procedure, all of you must be aware, you have to pre-oxygenate at least for 10 minutes so that the PO2 is more than 200, disconnect the patient from ventilator, place an oxygen catheter. Usually what we do is instead of an oxygen catheter into the either the tracheostomy or the ET tube, we just connect to a Bain circuit, which also provides 100%. Bain's is the anesthetic circuit which we connect, and we wait for the carbon dioxide to rise for whatever minutes, 8 to 10 minutes. You look closely and look for any respiratory movement. So Bain circuit works in two ways. One, it gives you 100% oxygen, so you're not saying that he's hypoxic. Two, any movement of the patient, usually sometimes it's very difficult to make out when the patient is breathing or not. The balloon on the Bain circuit, the bag on the Bain circuit will make a movement if the patient makes takes a breath. So once that is done, you wait for 8 to 10 minutes, and in that 8 to 10 minutes, what happens is the CO2 rises. This CO2 will stimulate your brainstem and should produce some respiratory drive in the patient. If this does not occur, then at the end of 10 minutes, you discontinue the apnea testing, take a blood gas. Increase in the blood gas by 20 from the baseline, or PCO2 above 60 with no respiratory drive. It is apnea test positive and supports the diagnosis of brain death. Now, if the test is inconclusive, what we do, and the child is hemodynamically stable, what we do is we may repeat the test for a longer period of time. But if the child develops arterial hypotension, hypoxemia, or any severe acidosis, then these have to be corrected first. You have to stop the test immediately. So usually when you do this brainstem testing, either you succeeded doing properly or the child develops hypotension, acidosis, or hypoxemia. And major complications, the other complications are actually rare, but they are reported, like pneumothorax, cardiac arrhythmia, and myocardial infarction. These are the few simple things which you require for brainstem testing: a flashlight, saline, cotton tip, proper ET tube with an oxygen catheter in situ, the ice water with 50 cc syringe so that you can inject in the, for children we take a smaller amount of volume of saline for the vestibulocochlear reflex, a marker and the tongue depressor for a gag and cough reflex, and a reflex hammer. So all these things have to be kept ready when you start the brainstem testing. Once you have done the clinical examination, you need to document every test that has been done. Usually we have a prototype of the brainstem testing in the hospitals. They give us, and we inform the medical superintendent. He or she brings up the required document to us. Confirmatory tests are actually not required. The law doesn't say you need to do confirmatory tests, but in some countries they do it. EEG is supposedly the highest confirmatory test where many of the countries do it because it's easy and can be done bedside. But the gold standard is cerebral angio. Computed tomography angio is what we did in this child, where you saw the carotid artery was cut off. CT perfusion and magnetic resonance angiography also can be done. Transcranial Doppler and radionuclide imaging and multimodal evoked potentials are available now for doing the confirmatory tests, but none of them stand in court of law. If you tell that the confirmatory test proved positive, but the brainstem clinical one proved negative, then you cannot say that he's brain dead. Okay, so you need to have all the clinical parameters positive. Second testing only if the parents are willing for organ donation, and the second test is done after a gap of 6 hours for significant clinical implications. Same set of doctors who did the first test have to do the second test. Doctors involved in harvesting and transplantation cannot take part in this test, and every step that you did in the first testing has to be repeated, including the apnea test. And the time of declaration is usually when the time of second apnea testing you complete. That is the time that you take up for declaration. Ancillary tests, if used, have to be documented. Remember, all the things that you do have to be documented, because this is a medico-legal document that you are doing, and never ever rush in a brain death examination. When we talk of brain death, something that we should not forget is that the family support that we have to provide. Now remember, as physicians, we are obligated to give this support and guidance, because this is the end of life of someone's life actually. And that life is a life of the family. So you need to have the families in the examination room. I always allow them there. I very clearly tell the parent that the child has died. The death word is one important thing that you need to convey to the parents, because the moment you say there is 0.1% hope that the child might be, or you say 99.9% the child is alive, the parents will still hook on to that 0.1% and say, do something for my child to save him. So please, it's a wrong thing to say, but the death word has to come in your counseling, saying the child has died, because only then it sinks into the parents. They come to the understanding that the child, otherwise they'll say, please continue, please continue. Most of the parents usually do understand, but there will be some parents in that. So usually I call all the relatives, make them sit with me and other caretakers, especially the nurse and my other registrars, and we counsel the parents this thing. Once the communication has to be very, very clear about what terminologies you are using. Appropriate emotional support has to be given to the parents, and there will be never ever, since we are the treating doctors, we will not breach the talk about organ donation. We usually employ our transplant coordinator to talk to the parents regarding organ donation. As a treating physicians, we will not talk about it. So this decision is very, very important, and the transplant coordinator is the one who usually talks about the organ donation. Remember one thing, if after the second testing parents refuse to give the consent for organ donation, then you have no other choice but to go ahead and continue ventilation. At that point of time, I counsel parents that there is no hope and there is no chance that the continuation of support will give any further life to the child. So what we do is we take its signature from the parents not to escalate, because according to law we cannot disconnect from the ventilator. It's illegal according to the law if the parents refuse to give organs to the, because brain stem testing is only for organ donation, it's not for withdrawal of support. That thing has to be very clear. If they refuse, please say we will not escalate the support. Even if we continue support, it's going to be not of very much useful. So we take it in writing from that escalation of support. Sometimes parents even refuse to give that also because they are very emotionally. So we then get the relatives, talk to them and make sure that it gets documented in the case sheets. So it has to be very clear about not escalating therapy. And transplant scenario, I already mentioned, all the data that comes is an adult data and it's not a pediatric data. The reason for that being there are very less potential donors for pediatrics because we don't get that many brain dead children in the ICUs, and that's why the transplant program for pediatrics is very, very less. Infant transplant, in fact, is very, very minimal. You will not get so many infant transplant at all in India, and that is the greatest limiting factor for organ donation. So post brain death, the brain undergoes two phases, the body undergoes two phases of shock. One is a hyperdynamic phase, which is called a catecholamine storm, where the child develops shock and hypotension. And then there is a complete cardiovascular collapse phase, wherein the child becomes hypovolemic because of diabetes insipidus developed in the child. Endocrinology, there will be reduced level of T3, T4, and decreased production of ADH hormones. Glucose will be high, insulin production will be low. Similarly, lung, there are chances that they will be developing pneumonia, pulmonary edema, increased capillary leak, coagulopathy and hypothermia. So it is very, very essential that you preserve these, if the parents agree for organ donation, then that child has to be preserved for organ donation. It takes at least 24 hours before you take up the child for retrieval of the organ. So during that phase, PICU forms an important work that you preserve the body and make sure that the organs are in good conditions. There are no much contraindications to organ donor. Some absolute contraindications like HIV and malignancy that can be transmitted are there, but others are all relative contraindication. The cardiovascular priorities in these children, especially they will lose lot of water having gone into DI. So hemodynamic stabilization is important. You correct hypovolemia, support the perfusion pressure, just 1 minute and I'll be done. CVP of around 8 to 10 should be targeted. volume replacement with essential DI and vasopressin and vasoactives is important, and packed red cells transfusion. Ventilate the lung with minimal fluid balance and make sure that you use ventilator protective strategies. Use bronchoscopy and suctioning if required for mucus plugging. Hormonal therapy is something which all of us do institute. We give T3 infusion, vasopressin infusion or desmopressin. Methylprednisolone is also instituted, and along with that insulin to target the glucose as well and keep it at the rate of 120 to 180 milligram per deciliter. Last but not least, once you stabilize, the surgeons come in, they take the child to the OR, hemodynamically stable child is taken up and the organs are retrieved. This was a case last year we had where a 12-year-old boy sitting in the evening in the veranda, Tambram family. Father is a priest in local temple, mother is a housemaker. Both are 10th standard educated. The boy fell on the back, hit the occiput on the ground, literally got brain dead to the ER. Poor prognosis. Within 48 hours, we declared him brain dead. Treating team we were hesitant to ask for any organ donation. In fact, our transplant coordinator was also hesitant. But the parents agreed for it and they donated eye, liver, lung, heart, kidneys, both the kidneys, intestine, pancreas, and even skin. So it is very, very important that we as physicians promote and educate our colleagues and everybody for heart, not even colleagues, the layman, about importance of organ donation. Brain death is the first stepping stone for that. And once you diagnose a brain dead child, it becomes much simpler for the treating team to make sure that the organs are preserved and then organ donation can occur in a very big way. Thank you very much.
Thank you, Dr. Kamath.
Last but not least, we welcome all of you to Chennai in December 2024. I'm the Joint Secretary for this conference. This is the 26th National Conference hosted by the Intensive Care Chapter of India, along with the Intensive Care Chapter of Tamil Nadu and Puducherry. Please do come. We'll be happy to have you in Chennai.
Thanks again,
Thank you.
and thank you for making the rather drab topic really, really interesting. Before I make a few comments, is there any questions on the floor? None as of it. I just highlight one important thing which you highlighted in your talk very much, is the using of the word death. Sometimes we become, we don't want to use the term death. We say the child is passed away, child is no longer with us. Using that very word implies very clearly that the child has died, and that is very important that we use that word during the counseling. Otherwise, there will always be an element of doubt because the parents will always want that the child is probably have a 0.001% of survival. Let's try, let's fight, let's go on. So that thing is very important. And highlighting that the child, no further therapy is going to be useful. And if they don't agree for organ transplantation with their organ transplant team, then obviously one must highlight that this is further therapy or further continuation of therapy may not be of any use. And legally, we are not able to step down. We are just going to not escalate.
Yes.
Okay? So these few words, I just have one important question. Once you declare that this child is fit for transplant, this patient is going to give organ transplant, what is the time lag for various organs? Do we have any data on that? How many hours once we remove the organ from the body, from the patient, and it goes to the recipient?
From the declaration of death, within 24 hours is what my team, usually my organ retrieval team, they say within 24 hours they have to do. Because
once the organ is removed from the donor to the recipient.
It's done immediately, I thought.
Sometimes there may be a transport time lag,
Yeah.
The donor may be in Chennai, but the recipient may be in Pondicherry.
Yeah, I think the 6 to 8 hours is what they do.
Because there is a time lag. It's like for, as far as I know, for liver is up to 24 hours.
Yes.
But the other organs is usually 6 hours.
Yes.
Thanks very much.
Thank you,
and
sir.
I'll just make a small announcement. We all welcome you all to the pediatric pulmonology on the 8th of September at Oberoi Grand. The registration fee as of now is $750, which is available at Belad. Thank you very much.
We demand special discount from Shishu for Pedicriticon.
Just first tell me how much time do I have, because we are already late. So if I will cover as much, whatever time you allow. Check it another hall. If it is in time, then I will cover it very fast, okay? Yeah? 10 minutes, okay. Fine, just introduce.
Sir obviously needs no introduction. So he'll be speaking on role of fibrinogen in the management of bleeding in PICU. Dr. Mihir Sarkar is professor and the head of the PICU at Medical College, Kolkata.
Thank you, Pooja. So I have a disclaimer. This is a sponsored talk by Intas. So the fibrinogen concentration product as the new entry into the management of the bleeding disorders in the PICU. We see because we'll just go through these headings like fibrinogen, what is role in hemostasis, types of fibrinogen disorders that we commonly see, and the role of fibrinogen in the management of various disorders, and this fibrinogen 1, this is composition and the approval status and the dose, the fibrogen, that is the product of the fibrinogen concentrate. So if you look at the hemostasis and the coagulation is that liquid that makes the blood from the liquid to solid state to decrease the bleeding. And the hemostasis is both the balance between the clotting and making the blood the liquid form. So in a disease state like the sepsis, like trauma, like in a high transfusion, we were giving the patient the massive transfusion, these hemostasis get disorders, and there is an imbalance between this clotting, fibrinolytic and the clotting pathways. So what is fibrinogen? It is a large molecule produced by the liver having the 3 polypeptide chains, what you can see in the alpha, beta and the gamma chain, and it is synthesized in the liver. First the fibrinogen is converted to fibrin by thrombin, and then there is a monomer, they got to the polymers and forms the solid clot strength, increase the solid strength. If you look at the hemostasis, what are the parts? There is a primary vasoconstriction, then primary hemostasis, then the secondary hemostasis. Yes, you can see that the first there is a contraction of the vascular smooth muscle, so there is a narrowing, followed by this exposed endothelium that then von Willebrand factor, they attracts this platelet, and there is a platelet adhesion, aggregation, and the initial plaque formation. What happens after that? There's solid brick wall is formed, that is the platelet in between the cementing, the fibrinogen acts like a cementing, it forms a solid clot. So the clot formation, then the clot is strengthened. So what are the coagulation cascade? You all know there are 2, intrinsic and the extrinsic pathway. I'm not going to the details. What you can see here is the fibrinogen to fibrin is the common pathway, final common pathway of these 2 cascades. And sometimes we have to think about this fibrinolysis. After clot is formed, there should be a balance between the clot and this lysis of the fibrinogen. And this fibrin is now, by the plasmin, is degraded to fibrinogen degradation product and the D-dimers. So then disease state, that balance may be lost, and there may be fibrinogen disorder, that low fibrinogen or dysfibrinogenemia may have both, may have bleeding manifestation, may have thrombosis. So this balance is very important. So this is the normal value, 2 to 4 gram per liter, and half-life is 3 to 4 days. What are the fibrinogen disorder that we see? Maybe the acquired or maybe the inherited, and maybe the quantitative defect or the qualitative defect. So that is very important. So fibrinogen level may be normal, but there may be dysfibrinogenemia. So what are the secondary causes that we found in our ICUs, like the liver disease, DIC, or the massive transfusion or the hemodilution? And what are the congenital disorders, like the afibrinogenemia, which is very rare, then the hypofibrinogenemia and dysfibrinogenemia. So in dysfibrinogenemia is one important, that the fibrinogen level may be the lower normal, but it is dysfunctional. So it is very difficult sometimes to get. Sometimes we get the patients who have the all the functions are normal, PT-INR and the APTT normal, fibrinogen is normal, platelet is normal, but patient is bleeding. But because the thrombin time, we have only the thrombin time in our hand, but that may not be always be a good predictor. So that we may not be detect the why the patient is bleeding. That may be due to the dysfibrinogenemia. So these are the causes I already enumerated, so I'm not going to again details. So it may be congenital or acquired. Is hanged. Okay, how we can diagnose? The history is very important, the unexplored bleeding. There may be also thrombosis that I have said already, and during the pregnant women, there may be increased mortality due to the bleeding. So the thrombin time and the plasma fibrinogen level are the tests that will indicate the patient have any fibrinogen disorder or not. But now the tissue thromboelastography is the test of choice in the patient in ICU with the severe bleeding or patient after cardiac surgery, liver transplantation or massive transfusion, because the PT-INR or the APTT are unreliable in this stage. What we find is that there is a dynamicity of the clot, because the clot that I have already shows that the clot formation, then the clot strengthening, and then clot lysis. These are the whole process. So where is the exact defect that can be identified by the thromboelastography. So it is coming more in ICU, because not only that this conventional test may not give you the result where is the defect. Okay, so here you can see there have I'm keeping some time on that because it is very important. It's coming up in the next. So the ART time is indicating the initial clot formation, and the K and alpha angle is the clot strengthening. So role of fibrinogen is there. So if the K time is prolonged and the alpha angle is increased, that means that is a fibrinogen disorder. So even the low fibrinogen or dysfibrinogenemia, both can do this. So the fibrinogen is level normal, but these times are increased. That indicates the patient have dysfibrinogenemia. Then the platelet interaction, this M time, the maximum amplitude MA, is the interaction between the platelet and fibrinogen. So the platelet dysfunction can be there. And this part, this A lysis LY30 is the lysis time after 30 minutes. That indicates the total fibrinolytic pathway. So from this, you can know from this dynamic process where is the exact pathology, and you can titrate your therapy. You cannot give the blindly the FFP or the cryoprecipitate for this patient. You can pinpoint where is the defect. So how we can going to replace? If you look at the in fibrinogen, look at the these things that if the patient has major bleeding like the cerebral bleeding or the thrombosis, then target should be 150 gram per DL or 1.5 gram per liter. But the minor bleeding is up to 50 mg per DL. And for major surgeries, we have to give the prophylactic, and you have to target 150, and minor surgeries up to 100. So these are the things you have to keep in mind when what is the target whenever giving the fibrinogen. So comparison between the FFP, cryo, and this fibrinogen factor component, you can see that the source is purified. Is there any pointers? Yeah, so you can see it that the source is the purified pooled human donor. So so there's a less chance of the contamination with the infections are less. Viral inactivation is done here, and the fibrinogen concentration, it is a more higher. So the dose with a smaller volume, you can increase your target level much faster. So the thawing time is very less. It is just you have to prepare. It will take 10 minutes. In case of the FFP or cryo, it will take more time. Blood group matching is not required. Complications is very low. As you know, this is not a pure blood product. Then it is and it is purified. Shelf life is also long. So you can keep the storage up to 2 years. So these are the very important advantages of this fibrinogen factor concentrate. So this is one of the study done in congenital fibrinogenemia and dysfibrinogenemia. These have shown that it has improved course in that in surgical prophylaxis, both pre-operative and post-operative, and safety profile is also good. So this is the important tool. So this is the product available, fibrinogen 1. That is the fibrogen 1. And what is the composition? It is a freeze-dried form. You have to dilute it with water for injection, and the one vial usually contains 700 to 1300 gram of fibrinogen, and you have to now calculate. So what are the approved indication? Congenital and acquired hypo or dysfibrinogenemia. Our concern is like the patients with the severe liver parenchymal disease, even with the severe dengue, there are hypofibrinogenemia and dysfibrinogenemia, increased intravascular consumption like DIC, and the increased loss. So how we calculate the dose? If you see that target level minus measured level, so your target level in severe bleeding is 150, minor bleeding is 100, and prophylaxis is before surgery is 150. And what is the major level of fibrinogen? By 0.17. So for a 50 kg patient, the target level epistaxis is the minor bleeding, so you can target up to 100. So the dose will calculate up to come to 50 mg per kg. Now we have to guess how much volume to give. So this is the calculation, and that's how we have to go. So thank you. I will end here with this talk. So price is bit costly. So around, I think, 10,000 to 12,000 per vial of 1 gram of this fibrinogen. So there is particular indication. So if there is a, because you can manage it with the cryoprecipitate, but with the, it is the volume is very, requirement is less. Even with the cryoprecipitate, sometimes it is the dysfibrinogenemia sometimes already not got discorrected. So the continuous bleeding, even with this test, then in that cases you can think about it. And also in the patient with congenital hypofibrinogenemia, if there is need sometimes prophylaxis, you can consider that.
Thank you, sir. I'd request all the delegates present to please move to Hall A, where we'll have our inauguration now.
Good afternoon, everybody. Welcome back after lunch. So now we will start our next session, that is immunomodulation in PICU. Our chairperson is Dr. Rakesh Kumar Mondol. Sir, please come up on the stage. The moderator is Dr. Prabhas Prasun Giri. Sir, please. And the panelists are Dr. Kumar Divakar, Dr. Archon Shil, Dr. Reshmi Mishra, Dr. Shayantan Mondol. Please come to the stage.
Good afternoon, everybody. Thanks to Dr. Mihir and his team for inviting me and here for an important session. And as you all know, that PICU treatment, PICU management, it is not only the gadgets, not only the inotropes, antibiotics. It is beyond that. A lot of things have come up in last 2 decades. Cytokine, anti-cytokine, biotherapeutics, biologics, etc. And I believe it has definitely a good role, very important role in PICU management also. Not only rheumatology patients or oncology patients who are in the ICU receiving this, beyond that also, many patients, I think they require for their state-of-the-art management. Here our moderator is Professor, Dr. Prabhas Prasun Giri, Associate Professor and Faculty in ICH. He did a lot of good work in ICU and even rheumatology earlier. So I request Professor Prasun Giri to introduce the panelists and go forward.
Thank you, Rakesh sir, for the nice introduction. স্লাইডগুলো কোথায় আছে এখানে? It's not coming over here. Thank you all. So in the next 40 minutes, we'll discuss about the immunomodulation in PICU. With me, we have some eminent panelists. We have 3 intensivists on the board, Dr. Resmi Mishra from KIMS Bhubaneswar, Dr. Kumar Dibagar from Tata Main Hospital, Dr. Shayantan Mandal from Arjikar Medical College. We have one pediatric rheumatologist and immunologist who used to be a pediatric intensivist one part of time, Dr. Archon Sil. So let us start with the journey of immunomodulation in PICU. So what do you mean by immunomodulation in PICU? So the meaning of immunomodulation means you have to modify the immunity of a patient in the PICU. So in the 2 ways you can do it. Either you have to enhance the immunity of the patient, or you can depress the immunity of the patient. So when to enhance the immunity of the patient? Suppose clear-cut case, a patient of diagnosed immunodeficiency like a Bruton's agammaglobulinemia, admitted in your ICU with an infection. You have to give intravenous immunoglobulin to increase the immunity. These are not very much common. So what you used to do? Usually, they suppress the immunity. So there are a few occasions that we have to face in the ICU, in the PICU, when the immunity or the immune system of the body has behaved some unnatural way. So at this moment of time, we need to suppress the immunity. So in the whole talk, we'll discuss about when to identify the immunity is dancing and how to suppress the immunity. So the main 4 questions we'll try to find out through this lecture. How to diagnose, how to treat, when to treat, how long to treat. So what to diagnose is basically the cytokine storm. So cytokine storm in the PICU is the only condition where we want to depress the immunity. We want to do the immunomodulations. So how to diagnose the cytokine storm, how to treat, when to treat, and how long to treat. So my first question to Dr. Mishra. So what is cytokine storm, and is there any one single definition of the syndrome or not?
Hello, good afternoon all. Basically, cytokine storm is otherwise known as hypercytokinemia. When there is excess and uncontrolled release of this cytokine occurs, that is, we say it is cytokine storm. Basically, in a normal person also, whenever there is some amount of infection or inflammation occurs, cytokines, which is a pro-inflammatory agent, that is released. But when it is released in an uncontrolled and excess manner, that may lead to multi-organ failure. That's why it is very much important and should be treated and detected early.
Do you have any definition of cytokine storm?
Till now, there is no such definitive definition they have come up with.
Okay. So the landmark study that came in the New England Journal of Medicine in 2020. So this cytokine storm terminology has been in use since the COVID pandemic. So during COVID-19 pandemic, the intensivists identified that the whole manifestation of the COVID-19 in adult population is not due to only the overwhelming viremia. There are some immune-mediated response. Then the terminology of cytokine storm is being so popular. So my next question to Dr. Archon. So how to classify or divide or distinguish different types of cytokine storm?
Well, cytokines are like mobiles nowadays. The immune cells talk to each other by cytokines. So cytokine storms, there are some features, both clinical and laboratory. So cytokine storm, you can measure some indirect markers like ferritin, which will be elevated in cytokine storm. Cytokine levels you can directly measure. And there will be the effect of cytokines as well as dysregulated immunity to different organ systems of our body, leading to multi-organ dysfunction syndrome. And the main cells that they trigger is the innate immune cells, mainly monocyte macrophage system. So macrophage activation syndrome, the name has come from monocytic activation, macrophage activation. So cytokine syndrome, they have divided as per severity and as per causes. So cytokine syndrome, if we, they have given a stamp like HLH, hemophagocytic lymphohistiocytosis. It can be primary, which is mainly predominant in infants, and especially in children less than 2 years of age, where different genes have been identified to be responsible for primary HLH. And secondary HLH can be due to varied causes. Infections are one of the important pillars of secondary HLH etiology. It can be bacterial infections, it can be viral infections, it can be fungal infections. Mainly some viruses like adenoviruses, as the moderator has already mentioned. EBV, it's a very notorious virus which can cause HLH. CMV, HIV, these are the viruses which can cause. And malignancy is an important pillar of causing HLH, but today our focus of discussion will be mainly on secondary HLH or MAS, that is, MAS is the term which is used to denote HLH, which is mainly associated with rheumatological conditions. But in some articles, MAS has been used to define secondary HLH or reactive HLH also.
Exactly. So if you see the cytokine storm, it's not a disease, it's a syndrome, it's an umbrella term, and it all this terminology is there. Now there's a concept with this ARDS is also a cytokine storm, but a localized cytokine storm. So for very easy differentiations, there is no classification that how many types of cytokine storm is there. But for easy discussion and differentiations, I think that we need to classify in these 4 categories. Number 1 is the hyperferritinemic sepsis with mods of any etiology, viral, bacterial, parasitic, but not fulfilling HLH 2004 criteria and don't have any underlying rheumatological disease. It's one type of cytokine storm. Number 2 is a specific etiology, COVID-19 associated cytokine release syndrome or MISC. That is nowadays very rare. We have seen lots of these cases couple of years back. Number 3 is basically a pure HLH, hemophagocytic lymphohistiocytosis. Those who are fulfilling the criteria of HLH 2004 criteria. As Dr. Orton already told, there are 2 types, familiar and secondary. Number 4 is the macrophage activation syndrome. It's a type of HLH, but arising from underlying rheumatological conditions. Let's go to the cases. Case 1, this 10-year-old girl presented to us with a history of fever for 5 days, headache and body ache, pain in the abdomen for 1 day, non-bilious, non-projectile vomiting for 1 day for 6 to 8 episodes. On admission, around 2 p.m., the child was alert, conscious, cooperative, had 1 episode of vomiting after admissions, was hepatomegaly, asking water continuously. Child was given 100% maintenance fluid and given symptomatic management. Blood investigations were sent. At 4 p.m., we got the preliminary blood investigations. The girl had been admitted in the dengue season. So few reports came that raised the suspicion that possibly the girl is suffering from a dengue. The PCV was high, platelet was low, there was transaminitis, INR was bitly deranged, and CRP was not that much high. So on suspicion of dengue, the IVF has been changed to normal saline, 3 ml per kg per hour with BP monitoring. At 8 a.m., the report from outside that already deposited outside lab came as dengue NS1 was positive. Child was not passing urine after admission, so bladder was not palpable. The bolus has been given in the ward, passed blood mixed urine, shifted to the PICU. On PICU, we found the girl to be a bit compensated shock. The peripheries were cold, child was a bit irritable. So we investigated, repeated on the night at all in the PICU. It's seen that there is no such remarkable decrease of the PCBs. The platelets has been decreased further, and we have sent a ferritin, and it came out to be 41,815. LDH was 3861, and fibrinogen was 115. So at 11 p.m., vital was stable, there was no organ dysfunction, saturation was normal, heart rate was 132, pulse volume was average, BP was normal, is getting IVF of 4 ml per kg per hour, urine output is 0.7 ml per kg per hour for the last 6 hours. So at this moment of time, on the day of admissions, at 2 p.m., at 11 p.m., we got a child who is in a compensated shock, dengue, self-ventilated in room air, normal sensorium, borderline urine output, possibly normal urine output, because in dengue we target 0.5 ml. Thrombocytopenia with falling platelets, transaminitis, high LDH, extremely high ferritin, hypofibrinogenemia, coagulopathy by raised INR but no spontaneous bleeding. So my question to Dr. Sayantan, Do you feel this patient is having cytokine storm? If the answer is yes, then do you want to use any immunomodulation now?
Good afternoon, all. So the case, as we saw, is already in a dengue shock syndrome. The child is already in the critical phase of the illness, and as expected, the child is having a low BP, and the reports that we see is that the LDH is high, the ferritin is a very high level, and there is hypofibrinogenemia. So if we go by these terms and these investigations, so yes, I will say that the patient is actually in cytokine storm, which is well expected in the critical phase of the illness in dengue. But immunomodulation now at present, I will think to wait for some time at least, because this is only one value that we have seen, come across only a one value. I would like to wait for the trends that should be going on before starting any immunomodulation therapy. As we know, we all work in resource limited setups. So right now, jumping into immunomodulation, I like to wait for some time.
Okay, so if you do a random ferritin study, values in your any critical sick patient in the ICU, you feel that almost all the patients have raised ferritin, 2,000, 4,000, 800, 8,000, 20,000. So we don't treat the numbers, we treat the patients. So as there was no clinical worsening for the 8 hours, no organ dysfunctions, no immunotherapy had been given. So we continued the fluid management as per the guidelines for dengue and continued the same over the overnight with a target urine output of 0.5 ml per kg per hour overnight. The next day morning, heart rate came down, blood pressure is well, but it's a bit narrow pulse pressure, saturation was 86% in room air. So she needed 4 liters of oxygen support, urine output is 0.7 ml per kg per hour overnight. IVC was not collapsible, there's right pleural effusion and ascites. Blood gas, done this time, revealed a metabolic acidosis. So the blood pressure is normal, urine output is normal. IVF is 6 ml per kg per hour, pulse volume is average. The chest X-ray done on admissions, and you can see the chest X-ray has deteriorated and developed some fluid accumulation in the pleural cavity as well as the lung. So we repeated the test on the next day morning, almost 18 hours after admission. You see that PCB is almost same. There's a further fall of platelet, but there was no spontaneous bleeding, so we have not transfused anything. There's decrease in the SGPT and SGOT, and ferritin had been decreased, LDH decreased. PT-INR is almost same, but APTT has been decreased, and fibrinogen level is almost same. So in a nutshell, there is not at much clinical deteriorations. Clinical scenarios are almost same, but there are few labs that not been changed and few lab values that has been improved. So we thought that possibly this patient is still fluid deficit. We have started giving 5% albumin. After 1 hour, she was tachypneic, 4 liters of A2, pulse volume average periphery was cold, but blood pressure was normal by NIBP. Starting a bit irritable but conscious, urine output after albumin is increased to 1 ml per kg per hour. There's no bleeding. No bleeding was there. Ferritin decreasing 35,000, fibrinogen almost same. So my question to Dr. Diwakar, that do you want to use any immunotherapy now?
So at this point of time, there will hardly change in clinical condition. Oxygen has been started, it was not on oxygen, but it's only on by mask. So respiratory is not an issue, and the extra chest can be explained with the dengue. So this child is definitely in cytokine storm, cytokine release syndrome, but organ dysfunction can be explained by the underlying illness. So I'm not too sure if hyperinflammation is causing those organ dysfunction. So we can wait. The ferritin levels, which has decreased from 40,000 to 35,000, I wouldn't much be happy with that, because it's like the stock market. Say overnight 500 stock has gone to 40,000, and next day it has come to 35,000. So 35,000, 40,000, not much difference. But I will still be having a closer look for starting a modulation. If not now, but we need to monitor for the immunomodulation.
Okay, so if you ignore the value of ferritin in this patient, so all these symptoms that the kid had been quietly explained by the critical phase of dengue. So as the ferritin was in decreasing trend and transaminase is in decreasing trend, no spontaneous bleeding, no immunotherapy had added. But it had in our mind that possibly cytokine storm is going on and the girl may need immunotherapy at any moment of time. So continued the same fluid therapy with a urine output of 0.5 ml per kg per hour. At 6 p.m., means almost after 26 hours of admissions, 28 hours of admissions, the girl was still tachypneic, 4 liters of O2, compensated shock, periphery is cold, pulse volume average. Now the irritability has been increased. He's conscious, but irritability increased over the time. He was not interacting properly. Urine output is good, there's no bleeding, and started having complaining of pain abdomen. So we got the report in the evening and seen that there is a significant fall of PCV, but there is an increase in the platelet. We have not transfused any platelet. But at that moment of time, we have put the NG tube, and NG tube revealed the blood. Frank blood was there, and there was a minimal bleeding from the prick sites that you can already see. There are a few bleeds from the prick site. So we transferred the PRVC, cryoprecipitate, and FFP. So this child deteriorated over the time. For the last 6 hours, there are a few new changes appeared. There is constant irritability, there is a pain abdomen, there is a GI bleeding, and sensorium has deteriorated. So Dr. Mishra, so do you want to use any immunotherapy now?
Definitely, I like to go for some immunotherapy. Like you can go for steroids, dexamethasone, or we can go for the other thing also, because there is definitely deterioration in the sensorium. Child has started bleeding, and this is now the time to start some immunotherapy.
Okay, so for almost being stable for the last 16 to 18 hours, for the last 6 hours, there is a significant deteriorations in the form of sensorium and coagulopathy. So we thought that possibly the cytokine storm is now taking over this critical phase of dengue, and this is the main concern at this moment of time. So I started the IV dexamethasone as a dose of 10 milligram per meter square per day in 2 divided dose, as we given in cases of HLH. At 11 p.m., the tachypnea has been increased, put on HHFNC, compensated shock, pulse feeble, but metabolic acidosis has been increased. There's a worsening sensorium, bleeding, more tachypnea, intubated, ventilated. Midnight, we got the ammonia report. It came out to be 500. So this is the report at 11 p.m. So the platelet is normal, but the child have been bleeding and ultimately intubated and ventilated. Over the next 2 to 3 hours, there was rapid deteriorations. At morning at 4 a.m., you can see the real picture. This is a real story, real case. We can see the monitors on ventilator. The ET is very low. That means we are not over-ventilating. That means there was a metabolic acidosis. We can see the NIVP. The pulses were so feeble that we are not able to secure an heart line. Or the heart rate and saturation was normal. We have optimized all the fluid therapy. The inotrop has been started. This is the time she started developing decompensated shock and started having oliguria. In the morning, we got the reports. The platelets are almost same, but there's a significant drop of the hemoglobin. Significant drop of the hemoglobin. And if you see, we have done this report almost after 24 hours. Those who are coming down, again increasing. The ferritin was decreasing trend. After 18 hours, the ferritin jumped to 78,000. So there's a further deteriorations in the clinical status, further deterioration of all the lab values. So at 10 a.m., he was very high ventilatory setting, went into irreversible shock, child went downhill over the couple of hours, no urine output for the 4 hours, abdomen was tensed, fluid inotrop has been optimized, all sorts of blood products they have given, but as more blood pressure, blood product we are giving, there is no urine output. What next, Dr. Archon? Very difficult scenario.
Yeah, so the child has entered the VCS cycle.
Yes.
And so other supportive, CRRT has to be started. So AKI has developed supportive treatment in the form of blood products transfused. And in cases of secondary HLH, the important thing is that the interleukin that plays pivotal role is interleukin-1. It has been seen in multiple trials and studies. So although anakinra availability and cost, these two are issues in countries like us, but still where we are in doubt that underlying infection is going on, underlying sepsis is there, so two most safe options are IVIG and the number 2 is anakinra. So here the child was treated, first dose of anakinra was given.
So we find out that possibly the child in the VCR cycle and overwhelming cytokine storm. So we have initiated CRRT, we have given the first dose of anakinra, but just succumb within 3 hours. So what went wrong? Anyone?
Difficult to say what went wrong, because this is a discussion, so definitely we must be thinking about whether we could have gone for immunomodulation earlier or not. So retrospective vision is always 6 by 6. So now it's very easy to say patient has succumbed, we didn't give the immunomodulation, patient had died. The simple inference we can draw that we didn't give the immunomodulation, the patient has died. Nobody knows whether a patient who is still alive, whether we were given or not. But few things are clear. Patient was in cytokine storm. There was organ dysfunction, there was a confusion, there was a doubt that this organ dysfunction is because of the dengue illness or because of the hyperinflammation the patient had. So hindsight, it looks like that we could have done earlier, but I'm not sure if I get the patient again, so whether I would start at that point of time or not.
Exactly.
Again, there was suddenly there is jump from 35,000 to 78,000. So I knew that 35,000, I was not too happy with the decreasing trend. It didn't make any sense because patient was deteriorating and ferritin is going down. So I still consider 35,000 as a 40,000.
Exactly.
What could have done, we could have repeated earlier to see, but again we are changing the ferritin. Even I would have, if you have to give the immunomodulation, even 35,000 with severe organ dysfunction is a good enough. The trend is not good enough.
Exactly. Initially, we thought that we will not treat the numbers, and the next day we treated the number. And then there is a big gap. We have not seen the numbers. So retrospectively, we analyzed this case that what went wrong. So possibly we should have started immunotherapy a bit earlier in this patient. When we started dexamethasone, possibly we had to hit hard and fast at that moment of time. But Dr. Divakar told that it could have happened that we have started immunotherapy earlier at that time. Still, we could not save this child. So if you are getting a patient with a dengue with cytokine storm, if you are not very much convinced that you need to start the immunomodulator, please monitor very carefully with the vitals, any new deteriorations, and check the labs, specifically fibrinogen and ferritin every 6 to 8 hourly. ESR is a surrogate marker for fibrinogen basically. As
So
we have the
already-
fibrinogen.
One thing regarding ESR, after giving IVIG, you can't monitor by
Can't
ESR
monitor.
because ESR will be falsely high due to fibrinogen in IVIG. So ESR, otherwise ESR you can monitor, but it is a nonsense.
So actually there is no doubt about patient is in a cytokine storm, right? So there are certain lab clues, you look for the inflammation, the next question, but there is no doubt it has. So suppose we could have done the CRP also. CRP would have been high. Suppose SCR is not too high, CRP is too high. So how do you explain the ferritin? So I have one ferritin and clinical picture is matching. So taking too much of data is difficult to interpret also. So lab clues, we are looking for the inflammations. As Madam said, CRP, ESR will be raised. Then the cell lines.
We can take the questions after the panel.
We are not on the HLH.
We can take the questions after the panel.
Then you can cell line depression, you can say. You can have the leukopenia, you can have the anemia, you can have the thrombocytopenia. Patient is already thrombocytopenic.
So cytokine storm can happen in sepsis, severe sepsis infection, immunoregulations. Antibiotic is definitely the cornerstone of management. Despite the optimal supportive therapy, mortality has not come down significantly. The immune dysregulation leads to cytokine storm, and pattern of organ dysfunction varies depending on causative organism. So the deadly thing is that in dengue, it's very difficult to define whether everything is happening due to overwhelming dengue viremia, or it is the main player is the immune dysregulations. So the thought was there that if we identified that, okay, this, by the numbers, that the patient is a cytokine storm, to when to start the immunomodulation? Should we start the immunomodulation to prevent the critical illness? The patient is otherwise stable, hemodynamic is stable with a fibrinogen of 100 with a ferritin of 10,000, fulfilling the criteria. Should we start at that moment? Or we should start the progression of the critical phase? This patient a bit deteriorated, uncompensated shock, but no organ dysfunction. We should start at this phase. Or when there is an established organ dysfunction, with timing, when to start the immunomodulator? The answer, nobody knows in the earth. We can do debate thousands of hours, but possibly this answer will not come. I treated this patient on immunomodulator, these things, and definitely I had a sleepless night for the next 10 days. So I started thinking, why should I not start it anakinra one night before? Because in ICH, we have a stock of anakinra. We can get it at any moment of time. We had a stock of anakinra. We supply anakinra to all of the West Bengal. So we had a stock of anakinra. If you need anakinra, please message me, I can supply you the anakinra. Okay?
Surely.
Even we can export it to Odisha as well.
Maybe Jharkhand also.
Jharkhand also.
I will just share my experience on this slide. Just sorry to interrupt you. So in our hospital, the adult physicians, so they are using Dexa to prevent the critical phase. So immunomodulation to prevent the critical phase. And when I compare, so it's difficult to compare apple orange. So I compare our mortality is not different from what they are doing it. So, and they are doing DEXA only, not anakinra, because, so I'm not too sure whether we should try to prevent the critical phase.
Dr. Sayantan, my question is that it is dengue patient in a critical phase, leaky phase. So when to identify that dengue viremia critical phase is not playing everything? There is cytokine storm. What are the clues?
Definitely when the patient enters the critical phase of illness, we are all at very alert that what next, what can come. But I think certain things, if we keep in mind, that number one thing should be the encephalopathy or the irritability, the CNS manifestations, anything that is going on or not, that should ring bells that the child is now going into a cytokine storm. Secondly, I think we are actually, all of us are from very back, long time, our mind has been totally boggled with HLH, secondary HLH or primary HLH, and we have that set criteria that HLH guidelines have set to us. But not sticking to this guideline only, but we should always think about, number one, is the end organ dysfunction is happening or not. So by the end organ dysfunction, we mean that any DIC that is setting in, probably any vascular endothelial damage that leads to production of some products that trigger the coagulation pathway, production of the fibrin and subsequently fibrinolysis that leads to the generation of fibrin degradation products, and other things that we all know are the HLH that we are discussing, the very high ferritin levels, not only the only one, but the rising trend of the ferritin levels. These things I should be kept in mind for the identification of the cytokine storm.
So what I think that you should remember this slide, the diagnostic tetrad, that DIC, new onset DIC, or the DIC that is not being resolved with the traditional therapies or the guidelines therapy of dengue or any disease.
It could not be only by the platelet counts, rather by the DIC, so other parameters.
And there is a persistent or deteriorating or new onset hepatobiliary dysfunctions, persistent high LDH, and definitely hyperferritinemia. So if you think about the DIC, it's few things that in DIC there are few things are happening. So how to identify DIC? This is very much important. All the dengue patient with bleeding is not on DIC. So to identify DIC, so there must be some intravascular activation of coagulations, formation of fibrin, fibrinolysis, consumption of clotting factor, hemolysis, and end organ damage. So these are the things that are happening in DIC. That's why these lab values you have to do in a periodical manner. So what are the lab values suggestive of platelet consumptions? It is the thrombocytopenia. It is the thrombocytopenia. Depletion of coagulation factors, increased PT-INR and FPTT. Trends, INR was 1.86 in the morning, in the evening it's 2.16, even if no bleeding. Increased fibrin formations like decreased fibrinogen and increased thrombin time. A definite increased fibrinolysis, elevated D-dimers and elevated FDPs. One thing to remember about the fibrinogen is a marker of acute phase reactant. It's a marker of inflammations. So if you do fibrinogen in any patient with acute infections, those who are not in DIC, it should be around 400, 500, 600. But if the patient in DIC, it's coming down from 500 to 250 or 300. So sometimes this patient having actually hyperfibrinogenemia, but as the fibrinogen is an acute phase reactant, it is giving a falsely normal level. So you might be satisfied, okay, my fibrinogen is not coming down, so it's not in DIC, it's not in HL, it's not in cytokine storm. So don't rely too much on normal fibrinogen level. Actually, the normal fibrinogen level that you are seeing is actually coming down from the raised level to a normal level. So don't be very much satisfied with the normal fibrinogen level. And definitely the liver dysfunctions, the new onset liver dysfunctions, new onset jaundice, this is very much important of organ dysfunctions. Now coming to the ferritin, I think Dr. Orchon is the right person to talk about the ferritin. So in HLH criteria, they have set a number that is more than 500. So 501 or 50,001. What should I take? And whether we should treat the numbers only. Because there are few people, they only, okay, the ferritin is 1,000, give. Someone, okay, ferritin is 10,000, ferritin is stable, don't treat. So do we need to very much worry about the single parameters?
No, ferritin is a non-specific acute phase reactant that we all know. Ferritin is a marker of inflammation, so in any inflammatory conditions, ferritin will rise. So we'll have to decide on the value of ferritin based on the clinical and laboratory profile of the patients. So as we have already mentioned, hyperinflammatory syndrome, whatever you call, cytokine storm, HLH. So liver dysfunction and coagulopathy, these two are the important thing. So you'll have to look for this, and ferritin is produced mainly by monocyte macrophage cells, but in dengue, in the setting of dengue, there is bleeding, there is hemolysis. So ferritin will go high due to that RBC destruction also. Ferritin will go high due to liver damage also, because reticuloendothelial cells which are in liver, in spleen, they will also cause rise of ferritin. And in dengue, there is microbiological translocation, so which enhances the lipopolysaccharide production, which promotes ferritin production. So it is a ferritin you will have to judge based on the coagulopathy, hepatic dysfunction, and other parameters. And in HLH features, or increased ferritin with coagulopathy with other features, in infant or less than 2 years of age, you will have to always consider the possibility of primary HLH. Even if HLH is present associated with some infections, then also you should consider, because primary HLH can always be triggered by some secondary infection. So you should always think of genetics or perforin assay or granule release assay, which are not done in our setup, in most of the setups.
So as you see in this slide, that elevated ferritin is very much non-specific. You can see in the acute phase as well as the critical phase. So one thing is that's now coming, lots of multi-organ dysfunction. So we are treating this hyperferritinemic syndrome with MODS. So there are lots of multi-organ dysfunctions phenotype. So what are these phenotypes and what are the clinical implications? Why do we want to identify these phenotypes?
Basically, there are three types of phenotypes of MOF. One is your thrombocytopenia associated, where the platelet count, usually the number of platelet count, if it is less than 1 lakh, or there is a decrease in the platelet count to 50% when you have a baseline platelet count, we say it is TMMOF. And another one is your IPMOF. IPMM, basically it is immunoparalysis, which usually develops after 3 to 4 days after the MOF develops. Another is your sequential MOF, where there is development of the hepatic involvement also occurs here, where there is the bilirubin count may be more than 1 and requirement of oxygen that also increases. These are the things we can...
So the main purpose of dissecting these things and giving new name and making our things more complicated. But one thing that I can tell you from my clinical practice, that if you are getting a multi-organ dysfunction syndrome that are under the umbrella of TAMOF physiology, and you are getting a multi-organ dysfunctions with thrombocytopenia, with new onset acute kidney injury, and you are getting hemolytic uremic syndrome like pictures, the hemoglobin is coming down, peripheral blood smear, few cystocytes are there. So possibly you are getting a TAMOF physiology with hypercytokinemia. So if you identify this physiology, they will not be benefited by only your steroids, anakinra, or these things. They will need simultaneous RRT with plasmapheresis. So the importance of this, identify this physiology, this on the background of cytokine storm, if you have a persistent thrombocytopenia, hemolytic anemia, acute kidney injury, severely elevated LDH, then usually you get a TAMOF physiology, you need to give plasmapheresis. Now, the million-dollar questions and the debate, and this debate we can do a whole day conference with this debate also. So the management. So as I told, that identifications, that the diagnostic tetrad, DIC, hepatobiliary dysfunctions, high LDH, ferritin, these things. So management, the questions are what to give, how to give, and how long to give. So there are lots of options available. There are steroids, there are IVIG, there are chemotherapeutic agents like etoposide, cyclosporine, there are biologics, there are plasmapheresis, and there are extracorporeal therapies. So this is our initial test studies, that infection-associated HLH, a case series using steroid-only protocol for management. We have published this almost 13 years back. We have collected data from 2008 to 2010, At that moment of time, everyone treating this HLH as a full chemotherapy, etoposide, cyclosporine, but at that moment of time, we did not have that courage to give etoposide and cyclosporine. We started giving steroid and all the patients improved. So we started thinking, okay, this is the whole thing, the bhagwas written in the textbook, HLH is a fatal disease, they will die, they need etoposide, cyclosporine, hematology. We're just giving 2 or 3 dexa and they are improving. Fantastic. Then you got the same cases in dengue. Each and every dengue patient with a ferritin of 568, 668, 968, 1000, okay, fulfilling the HLH criteria, give steroid, all of them are improving. We have published in IAP as well with some tag of some stalwarts of this hypercytokinemia macrophage activation, we have published in. So we are very much satisfied, okay, this HLH can happen here and there. Each and every alternate patient is HLH. You just give 1 or 2 doses of steroid, they will improve. But this is not the same. So you need steroid. So what steroid you should give? Dexamethasone or methylprednisolone. But study says that if you are giving very high dose pulse methylprednisolone, in these cases the mortality usually increases. Because in our scenario, in our part of this country, most of them, if they are coming with a dengue shock, there are some underlying sepsis is there. So don't go for the high dose of pulse methylprednisolone until and unless you had a confirmed underlying rheumatological disorder that went into the MASH. Otherwise, use a low dose methylprednisolone or you can give a dexamethasone. So there was a study was showing that if you are giving the high chemotherapeutic agent like etoposide and cyclosporine to treat this patient, the mortality usually increases. And in our center, totally till now, we have given etoposide in 16 patients and all of them expired. 100% mortality etoposide to these cases. None of them survived. So all the studies are showing that until and unless it's a familiar HLH, if you give etoposide and cyclosporine, the mortality increases. So, Dr. Divakar, so I got this thing from a textbook written by the Dr. Carcillo, who is the pioneer of this term, hyperperitonic sepsis of MODS. Do we agree on this flowchart that we should follow it or not?
So basically, he is talking about the your tetrad. So hepatobiliary dysfunction and DIC, with high ferritin, you go ahead with the immunomodulation. The choice could be different. So you can give IVIG plus anakinra. I will share with my experience in dengue. So we have treated more than 600 patients. Out of 100 came to our PICUs. They had the moderate to severe dengue. We identified 8 patients within a cytokine storm. You use the MIS-C definition to identify those. So 25% of 2 cases were blood culture positive. So they were high in temperature, they were not improving, but they found to be. So we were very scared of using Dexa at that time. So we give the IVIG only. I'm not sure whether I did right or wrong. But here you can see that if you have diagnosed the sepsis-induced cytokine storm with multi-organ dysfunction, you can go ahead and give the IVIG.
So the whole world and the intensivist now shifting from steroids to something else. Initial favorization was IVIG, but practically we are not getting very much good results with IVIG. Now the things coming in, that is anakinra. So my question to Dr. Archon, that lots of biologics are there. In COVID, there's a hue and cry about tocilizumab, IL-6, tocilizumab. There are another, the JAK inhibitor, bursitinib, anakinra. So in these situations, dengue or non-dengue cytokine storm, what biologics would you prefer to give? If availability is there and cost is no barrier.
So if availability is there, I will definitely prefer anakinra, as I have already mentioned that the interleukin-1 is the key player in secondary HLH or reactive HLH or MAS. So anakinra, there are studies, they have shown that anakinra, if started early, had good results as compared to late initiation of anakinra. So that's why this regime came, anakinra with Dexa with IVIG. Exactly.
So if there is a no cost concern, you should start anakinra, Dexa, IVIG altogether. If cost concern, cut short your IVIG, invest on anakinra. Remember, it is not a subcutaneous dose. In rheumatological cases, we give subcutaneous. Here, we have to give IV. It's an IV dose, twice daily or thrice daily. Yeah. IV dose.
And the concept in IV dose is that you will have to reach the level fast.
Exactly.
So half-life is in subcut dose is somewhere varies between 3 to 7 hours, whereas in IV dose it will be around 1 to 1.5 hours. And if there is, in severe HLH setting, if there is thrombocytopenia, severe thrombocytopenia, to be specific platelet count less than 20,000, then in subcut injection there is chance of bleeding. And if there is neurological manifestations, So in all these cases, IV injections are preferred. And tocilizumab, I will simplify the thing. Modernly, there is, in recent times, there is a lot of hue and cry regarding CAR T cell therapy. So if the HLH is associated with CAR T cell therapy, hopefully we will not face that situation, then tocilizumab is preferred. Then interleukin 6 is the chimeric antigen receptor T cells. Now CAR T cell therapy is a very hot topic in oncology, pediatric oncology setup. So they are using CAR T cell therapy in ALL, multiple myeloma, and a lot of other malignancies. So in that case, and in drug-induced, if this HLH is drug-induced, then tocilizumab can be a good option. In rheumatological conditions, in SLE, Ritux can be a good option. So apart from these things, mostly anakinra, and in primary HLH, the HLH, age-old HLH 2004 guideline, where Dexa, etoposide, cyclosporine, but etoposide, as already mentioned, is a very difficult drug. It can lead to nightmare. It will lead to pancytopenia, sepsis. It can be very difficult. So we should be very cautious before using etoposide. And JAK inhibitors now are coming in a big way because the interleukins, they act, the interleukin receptors, downstream there is JAK-STAT. And there are two molecules, that is AAK1 and GAK, so cyclin G associated kinase and AP2 associated protein, which are pivotal in regulation of clathrin mediated endocytosis. So that's why baricitinib, there are a lot of trials regarding the use of baricitinib as a potential anti-inflammatory as well as antiviral agent. And there is another JAK inhibitor which is not widely available, that is ruxolitinib, that is also used in HLH.
So these two are usually coming. So extracorporeal therapy, I am going very rapidly. So there is another concept, that extracorporeal therapy. The only thing that is available is cytosol. That few of our colleagues are very much fond of it, that okay, give extracorporeal therapy.
And to confess that I have not used it.
Yeah.
I hope many of us also have not.
So there are few theoretical benefits are there. For practical applications, our experience is very less in pediatric populations. Few of the studies shows, okay, it's very good in cytokine removal, it's very good in organ dysfunction reversal, but ultimately mortality has not been improved. Few of them are showing, okay, very good in cytokine removal, but no improvement in the organ dysfunction course, no improvement in mortality. If lots of resources are there, then you can use. It will not cause any harm, but benefit is doubtful. I'm not able to go to any further cases, so we're ending the session over here. Thank you.
Just for the food for thought, I think for the discussion and for the panelists also. So the two cases I described, so they were in cytokine storm, they were culture positive, they were intubated, so moderate to severe organ dysfunction. What is the right time? I know this is debatable. What is the right time to start the anakinra? Do you wait for the culture to be getting?
The thing is that it has been told that anakinra do not suppress the immunity. It is immune safe. It's not like that. We have seen that if you give anakinra, there is lots of increase in the fungal sepsis. All the patients who received anakinra had developed fungal sepsis. So this is very much aware. Definitely, it is less immunosuppressive than methylprednisolone. But if you have a circulating bacteremia is there, better to treat that, preserve anakinra. I don't have the courage to give anakinra to a patient who have a blasphemy going on, flooded with a Klebsiella or MDR Klebsiella.
No consensus on when to start. Some say start early, some say treat underlying condition first and then start. So there is no consensus on when to start. So
when patient dies, we always say that.
Yeah, in retrospect, it is easy to comment that.
So just one slide that if you have a hyperpatremic sepsis with MODS that is characterized by the hepatobiliary dysfunction, DIC high ferritin, preferable is IVIG plus minus anakinra plus minus IV steroids. Then if it is a refractory is a tamophysiology, then go for a CRRT with plasma exchange. Refractory disease without tamophysiology with IL-6 more than 1000, then gone for pyrosol. So after this session, we are still confused how to diagnose, how to treat, when to treat, how long to treat. If anyone is there, can relieve my confusion, please DM me.
I think easiest to diagnose. Diagnosing is not a great deal.
Any question from the audience? They will comment from the audience, any comment or any clarification. What I believe is right that it's a very important topic. It's unfolding every day, and it's not in 1 hour you can justify. That's why we are doing 2 hours, 2 days of conference on pediatrics.
So then give me chance to speak on 4 hours on this. I can eat 4 hours.
Okay, I just one question. This slide by Joe Carciloitel, which you showed, and as usual, it showed a ferritin cutoff of 500. We have discussed it million times before. So, like hepatobiliary dysfunction plus DIC in a scenario of sepsis, we are getting okay. But in this context, like the maximum confusion we face is regarding the ferritin value. We have seen it multiple times. Like such a patient is there and the ferritin is 700. So in that situation, to start IVIG 2 gram per kg with anakinra, most of us will not do.
No, will not do.
Most of us
Definitely will not do.
But that is the thing, like this here, we decide based on what ferritin cutoff. Perhaps we are individually comfortable with different ferritin cutoffs, which we will select, which will be the threshold to treat. Obviously, patient is gradually worsening, we are seeing, okay, but sometimes the ferritin comes like 1000. So then it becomes very difficult to decide.
It's better to check the ferritin trends, basically.
We were checking the trends.
Suppose if, the ferritin, if my patient is not improving, patient is deteriorating and the ferritin increasing from 500 to 1000, then I think I will not treat as a number. I will treat the ferritin increase twice. And the patient is deteriorating. I like to treat. But at the same time, patient is not deteriorating and ferritin increase from 40,000 to 40,500, possibly I will not treat.
Yes, but that's the thing. So if the ferritin was 700 and the ferritin the next day rises to 1400, with the patient being in almost status quo situation, meeting those criteria, like having a hepatobiliary dysfunction, some DIC going on. So, would you treat with IVIG 2 gram per kg plus anakinra?
I'd just like to address this thing. We often get these sort of ferritin levels.
We are running short of time. We need to end. Okay.
Scenario. I personally, for me, I'd like to see other markers also, not only based on ferritin, for judging our diagnosis and intervening the treatment.
For ferritin level, there is a score. H score you can follow. H score is there, which can assess the H score. There is.
We are running short of time. We are running short of time.
We have successfully treated one case of dengue HLH with anakinra, and that is reported in pediatric IAP also. And what I feel is that we don't treat the numbers. What has been said as trend of ferritin or trend of something like the thrombocytopenia or SGPT scoring, like ratio of the ferritin and SGPT kind of thing. But what is more important, I feel, over time and over experience is that the clinical deterioration of the patient. If you can correlate these two, possibly that's the how, in this patient also, you are not delayed, you are delayed by only 19 hours to start this immunomodulation. Within that time, patient actually succumb. So if your clinical parameters are deteriorating, along with that, if it is your parameter, that lab parameters also corroborated, then possibly you would treat it. Even if your lab parameters is not corroborated, but your clinical parameters are deteriorating, in this child, the child was a little bit incapable of breathing and gradually things got lost in the form of that GI bleed and all this. So possibly we'll treat anakinra with anakinra early or IBIG early.
Thank you, otherwise organizer will be throw you out.
Basically, we are not treating 500.
I think there's still some scope for discussion, but unfortunately we're short of time. We'll now move on to our next session, which is a debate. And the topic of our debate tonight is role of steroid in acute hepatic failure. Our chairperson for this session is Dr. Debashish Bandopadhyay, sir. I'd request you to kindly please take your place on the dais, sir. He is Additional Chief Health Director, Department of Pediatrics, and a senior consultant and a PG teacher with NB New Delhi.
So good afternoon, everybody. It is a pleasure to be here, and I thank the organizers for arranging this session, role of steroid in acute hepatic failure. So we have the first speaker, Dr. Shivoprato Patnaik. He will be speaking in favor, and against the motion will be, the speaker is Dr. Bijay Meher. So I ask both the speakers to kindly come up to the stage.
Dr. Shivabrata Patnaik is Professor, Department of Pediatrics with KIMS Bhubaneswar.
Good afternoon all. Role of steroid in acute hepatic failure. So when the topic was given, actually even I didn't like the topic because none of us practice giving steroid in acute liver failure. So I thought that my topic is really a very bad topic, and then I asked few of my friends who are practicing hepatology and pediatric hepatologist also. They told that articles are very less and mostly you will not be getting any evidence, so better you present for against steroid. So I told that they have already given me a topic on steroid, so what I will have to say. And but now see, last 45 minutes of discussion was in favor of steroid. Okay, so I am now feeling more courageous to answer everybody, because 45 minutes of discussion, people are telling about role of steroid in dengue, role of anakinra in dengue, everything. So I feel maybe steroid is having some role in viral hepatitis or maybe acute hepatic failure also. So starting, what is the definition of acute hepatic failure? I'm not going to detail of that. In 2006, actually, it was planned. And the definition, everybody knows that if the INR is more than 2 and it is not improving coagulopathy due to liver disease, INR more than 1.5, that is not corrected by injectable vitamin K in presence of hepatic encephalopathy, and without hepatic encephalopathy, even if it is more than 2, then also we say it is hepatic failure. And in addition, there should be elevated liver enzymes in the absence of any underlying chronic liver disease. This was the definition. 2 years back, one paper was published in Frontiers of Pediatrics, that was from Chennai. Dr. Bala Ramachandran was one of the participants of the study, and they have found that around 32% of cases of acute hepatic failure is because of infections. And second cause is indeterminate, we'll discuss about that and others. Then third is drugs, including paracetamol, that was around 21%. Similarly, and what interesting was that, as we discussed here, in the acute hepatic failure, they found dengue as the commonest cause of hepatic failure in South India. While 4 or 5 years back, that was published in Institute of ILB, so Liver and Biliary Sciences in Delhi, that they have found that 50% of cases are because of viral hepatitis, and in them, they have found hepatitis A as the commonest cause and indeterminate as the second cause. So you will be finding that indeterminate is a major chunk of acute hepatic failure in children, but however, this indeterminate we'll discuss later on. Before that, you see developed versus developing countries. In developed countries, indeterminate is the #1 cause of acute hepatic failure. While in our countries, like India and other developing countries, the infection is the leading cause of acute hepatic failure. So one of the common causes of acute hepatic failure is definitely viral hepatitis, including A, and A is the commonest one. And if you see about indeterminate, which is more common in Western countries, also it's a part of a big chunk of our disease also. These are the diseases where we are not able to establish any cause. Most probably we will be finding some other hepatic, viral hepatitis also in these cases, which are not non-A, non-B type. Maybe some genetic diseases are also there. Some metabolic diseases are there, which are not, the cause is not established in those diseases. So coming to the pathogenesis of acute hepatic failure, you see, it may be mostly, sometimes directly injury to the liver, or mostly it is immune mediated. It's not directly cytopath, the virus or any other thing which is causing direct injury to the liver, but mostly it is because of immune mediated. So massive hepatic necrosis and release of cytokines occur. The cytokine storm and surge can lead to multi-organ dysfunction. Not only it causes involvement of the liver, it can lead to involvement of the other organs like brain, cerebral edema, even ARDS can also occur. Even myocardial dysfunction can occur in case of acute hepatic failure. So this finally, because of decrease in the ATP, there will be cerebral swelling and cerebral edema can occur. This has been published in 2024, this year only, from SGPGI, where they have hypothesized that SARS is because of both DAMP and PAMP, that is, this is damage associated molecular pattern that because of the maybe virus or other organisms, and then after that, PAMP is because of the pathogen directly because of the virus, and damage associated molecular pattern is because of the virus-induced injury to the cells and cell walls, which can cause again further release of the cytokines leading to further molecular dysfunction involving all the organs of the body. So definitely there is a role of cytokines and immune mediation in case of acute liver failure. Same thing in hepatitis A also, it is not only because of the directly injury to the liver by the virus, but also immune mediated. Both B cell and T cells are responsible for this immune mediated injury to the liver. So in autoimmune hepatitis, as we find, this is one of the important causes where both here also T cells and B cells are responsible, and also the immunoglobulins are responsible for producing injury to the liver. So you can find in hepatitis and also autoimmune liver disease, you find role of the immunology, and mostly in autoimmune hepatitis, there is a definite role of steroid. Everybody knows about that, so there is no point in discussing much about that. But other cases, we should discuss a little bit about that. This was a paper published in Lancet in 2008, where they have found that this, the relationship between effector cell and the regulatory cell, if the effector cell numbers increase gradually, the hepatic injury is more. So some drug can be used to decrease the effector cell numbers. So like steroids, which can help in case of this immune mediation and improve the hepatic failure. So is acute liver failure immune mediated? That is an important question. It was published in 2017. So what they have found that around, this is a big group of pediatric acute liver failure study group. They have examined around 1,000 patients, and what they have found that around 28% of them had some form of autoantibodies. And out of that, around 64 patients had autoimmune hepatitis. So if you find, apart from autoimmune hepatitis, 64 cases, there are 202 number of cases who had also high amount of autoantibodies. So some form of immunological mechanism is definitely going on in the patients, which is responsible for producing immune-mediated injury to the patients. And they have not only that, they have tried steroid in these patients. What they have found that actually in the study, they found that when they gave steroid to these group of patients, they found that these steroids are not able to improve the patients. However, what they have found, they have taken the 21 days outcome, and if you think that maybe the role of the steroid has not come in that 21 days, had they taken the study period for a longer time, maybe 2 months, 3 months, maybe they have found some positive results. So we cannot conclude that this steroid is not effective in case of this type of acute liver failures not related to autoimmune hepatitis. So maybe further studies will be required to tell that this has some role. So how steroid helps? As everybody knows, corticosteroids can quickly repress an excessive immune response and inflammatory reaction. Moreover, corticosteroid has directly hepatoprotective role. So they prevent cytolysis of the swollen hepatocytes and also the protection of hepatocytes from apoptosis induced by toxicity. So accordingly, fulminant hepatic failure is anticipated in response to steroid based on their hepatoprotective action. So corticosteroid has definitely some action in case of fulminant hepatic failure. So coming to another big group of acute liver failure, as I told, this is a drug-induced liver failures. What you find is that corticosteroid has been proposed to be helpful in case of drug-induced liver failure also. So one study has been conducted in 131 patients, where they have given steroid to 26 patients, while corticosteroid not given to around 105 number of patients. And they have found that, again here, 50% of those who received steroid have improved from 26 patients, while 62% patients from those who have not received steroid have improved. So this is also an inconclusive study. You can say that definitely steroid has some role, but it may not be statistically significant, and also there are some biases towards the group which has not received steroid here from the study. So they conclude that though steroid has some role, we may not be able to conclude from this study. So finally, this is a systematic review of role of corticosteroid in drug-induced liver failure. This was published in 2022, where they have taken around 24 papers. In that, 8 papers were on drug-induced liver injury. What they have found from 8 studies, 6 studies had positive effect. They have shown positive effect of steroid in drug-induced liver failure. While in case of drug-induced autoimmune hepatitis, 5 out of the 5 papers had positive result for steroids. But in case of drug-induced acute liver failure, two of the studies have shown that steroid has no role in case of acute liver failure. Similarly, in case of malignancies, steroids have been given in some acute liver failure induced in anti-malignant drugs. So there they have found that 9 studies have been done on those liver failures related to anti-malignant drugs, some immune modulators, and they did not find any positive result in those cases. But overall, if you see here, in case of drug-induced liver failure, drug-induced autoimmune hepatitis, they have definitely found role of steroids. in case of acute liver failure. So many studies are telling about this. So in this study, what we found is corticosteroids are often used in treatment of drug-induced liver injury. However, their efficacy and safety are still disputable. Based on the available knowledge, patients with severe drug-induced liver injury or drug-induced autoimmune hepatitis might benefit from steroid therapy. So, but these studies are very less in number. We cannot just say that steroids are effective or steroids are not effective. We need larger, bigger studies, prospective RCTs to prove that steroid has definite role in case of acute liver failure. So many studies have been done in acute liver failure. Actually, I never thought that I will be getting so much of studies. However, these are all adult studies, and I am quoting about the only positive studies, negative studies I have not quoted here. If you say the study about role of the steroid on acute liver failure have started since long, like 1951, which was published in NEJM, where they have started with 5 viral hepatitis cases where they found that maybe steroid is having some effect. And gradually, if you see from 1953 onwards, the role of steroid has gradually, means people have started not to use steroid. But again, though, it has come up, and from 2006 and 2013, 2 studies. So you can find that they have found some positive effect of on role of the corticosteroid in case of acute liver failure. So steroid is definitely, it's not that completely no for the steroid. You can still say that definitely it may be having some amount of role, which may require some further studies. So this is an interesting study which was published in Egypt 6 years back. In 2018 this was published. What they have done is they have taken 33 cases of fulminant hepatitis A, and out of that 18 patients received steroids while 15 patients did not receive steroid. Of these 18 patients who received steroid, 15 patients improved and 3 died, while in those patients who did not receive steroid, 4 survived while 11 died. So you can see here clearly in this study at least they have found that statistically significant improvement of the patients who received corticosteroids. So steroid therapy in children with fulminant hepatic failure because of hepatitis A had good results in this study at least. But we cannot conclude from a single study that definitely steroid has some role, but definitely it's a single study. But definitely it is saying that it is pushing us that we should work more on finding more results and to do more studies on those aspects. So future studies will definitely helpful with larger population involving multiple centers may be recommended for giving a particular best result for this. So to conclude my presentations, acute liver failure is definitely immune mediated. Steroids may play an important role in managing acute liver failure. It is still not a recommendation to use steroid. Many studies with smaller sample size have found positive results. Larger prospective RCTs will be required. So what I will be saying is that if in our country, like we say 50% of cases are infectious etiology, where some are drug-induced liver disease, some are autoimmune hepatitis, some are indeterminate forms. So definitely in those cases, role of steroid is still there. So we cannot just say that steroid is not indicated. But however, I feel Vijay has come with some good evidence in favor of steroid. Let us see what he says.
Dr. Patnaik, well said. Thank you.
So a very good afternoon to all of you, and I'm very thankful to the Society of Pediatric Intensive Care for giving me this opportunity. And Dr. Shivabrata my friend, has already described the role of steroid in acute liver failure, and he is also against use of acute liver failure. So he has made my job more complicated, that whether I should go tell in favor of this or against this. But what is important is that we need to understand the science behind. And whenever you see any patient, any disease which have a very bad prognosis, steroid always comes as a rescue. So whether to use it or not to use it depends upon many things, what is the basis, what are the evidences are present, and what are the recommendations. So basing on that, we are going to discuss. So from the beginning, the effect of steroid in the treatment of acute liver failure is controversial, but still we are having a debate because we want to understand the basic of acute liver failure. We want to analyze the pathophysiology, unfold what is there in the recent evidences on the pros and cons of, of use of steroid, and opens up windows for further future research. So but at the end, it will again going to be the effect of steroid in the treatment of acute liver failure is controversial. Okay. So my objective of my presentation will be based on three arms. What is the basics of acute liver failure? What are the evidences for and against use of steroid? and what are the recommendations and the guidelines in acute liver failure in favor or against using steroid. So, is there any rationality of use of steroid in acute liver failure? Yes, and there is a role of inflammation. Is there any role of inflammation? Hepatic encephalopathy, and if the steroid is going to help in the reduction of intracranial pressure, which is due to hepatic encephalopathy, autoimmune hepatitis, as we know that autoimmune hepatitis is an immune-mediated disease. What is the role of steroid? And HLH, which is a liver failure is a complications and associated with HLH that we are going to study. Mortality is very high in acute liver failure. Transplantation is not available in all the centers. That is why we are talking about the steroid. And if you see the etiology, infection, drugs and toxins and metabolic causes are the most common causes, whereas even though infections and drugs are there, immune-mediated phenomena are seen in not only in autoimmune disease, but also in some viral hepatitis and some drug-induced liver diseases like hydralazine and halothane. You get some immune-mediated mechanisms which helps in the destruction of the hepatocytes. So this is the etiology of acute liver failure in the Indian study. The indeterminate variety are almost 23%, and the autoimmune hepatitis is nil. In this last study, what has been described by Amartya et al. And most commons are the infective causes, drug-induced causes, and the metabolic causes. So what is the basic thing in the hepatic encephalopathy in the pathophysiology is that severe degeneration or necrosis of extensive number of hepatocytes in a very short span of time. That is very important. In a very short span of time, most of the hepatocytes get degenerated and necrosis. The degeneration is a reversible phenomenon, but it becomes necrosis, it becomes a irreversible phenomenon. Okay? And the plasma concentration of ammonia and symptoms of hepatic encephalopathy are not always consistent with each other. So there is something in between is there. And what is that? And it has already been proved that systemic inflammatory response syndrome are the most important thing which are in the pathophysiology of acute liver failure, which comes into play. And whenever there is inflammation is there, that in the presence of inflammation, then the necrosis and the hepatic encephalopathy and organ dysfunctions are very important, or that is very manifest symptoms. So there is a role of systemic inflammatory response syndrome, and that is mostly lead to the organ dysfunction. All the organ dysfunctions are immune mediated, and that is triggered by the inflammatory response syndrome. So this is already proved that high ammonia induces hepatic encephalopathy only if systemic inflammatory response is present, which has been proven by the animal and human studies. And there is definitely a role of inflammation is there in all the acute liver failure. Inflammatory mediators, cytotoxic substances, activated lymphocytes induces severe degeneration and necrosis, leading to extensive number of death of the extensive number of hepatocytes. But what are the anti-inflammatory pathogens and what are the targeted therapy? So these are the therapeutic strategies which has been studied, that is NAC, N-acetylcysteine, hypothermia, minocycline, NSAID, TNF, and alpha antagonist. But steroid has never been thought of as a anti-inflammatory pathogens in the management of hepatic encephalopathy. So whether steroid is good or evil. So the good thing is that steroid inhibits excessive immune response and excessive inflammatory reaction. It has some hepatoprotective role, which Dr. Shivabrata has also described. It prevents cytolysis of ballooned hepatocytes. It protects the hepatocytes against apoptosis. But the question is that when extensive confluent cellular necrosis has developed, will it going to improve the prognosis in acute liver failure? That is one question. And second, can steroid have a sufficient effect on regenerative ability when the hepatocytes are dying or degenerating or getting necrosis in a very short span of time? And that is going to decide whether steroid is going to help in acute liver failure or not. And third thing, sepsis is also an important precipitating factor for decompensating liver failure. So whether the steroid is going to be harmful when used in acute liver failure, that is the question what we need to answer. So coming to the evidences, this is not the in 1970s. This was published in 1991. the acute hepatic failure study group, and they have used double-blind randomized controlled trial of use of hydrocortisone in the acute liver failure, and they recommended that corticosteroid use in acute liver failure with hepatic encephalopathy to be discontinued. But in Japan from 1998 to 2010, due to the shortage of the donor liver, steroid has been introduced in almost 70.6% of the cases of acute liver failure. But after that, what has been shown that outcome in corticosteroid group is not different, and infectious complications are likely to occur if you use steroid in case of acute liver failure. There are certain case reports which are shows very good result with that use of steroid in acute liver failure, and some are used in HLH, some are used in chronic hepatitis B infections, and that is not a sufficient evidence that we can use steroid. Then efficacy of high dose corticosteroid in the early stage of viral acute liver failure. So in viral hepatitis, there is a role of inflammations. Role of inflammation is there, and this is one study which studied that use of steroid in the acute viral failure. So 31 consecutive Japanese patients were treated in the early stage. They were given with high dose methylpenicillin for 2 weeks, and what was observed that the SGOT and SGPT, which are markers of liver injury, were lower in the steroid group. That means it had some effect on the injury to the hepatocytes, but there was no difference in the rates of survival and rate of liver regeneration. That means this study tells that steroid might have some role in preventing the injury, but it is not sufficient enough to prevent the patient from developing the surviving, or the mortality will be reduced. So coming to this study, this is one study which is telling much in favor of corticosteroid, that corticosteroid improved spontaneous survival without liver transplantation. This is a Japanese study which was published in 2016 by Zhao Bio et al. And they shown that steroid is statistically significant way improved survival, and also this improved survival in acute liver failure which was induced by the viral hepatitis. And they also told that the highest response with a lower MALD score, lower coma grade, and with an extremely high ALT level when the starting of treatment time is less than 2 weeks. If you start early with these conditions, then the outcome is better. So if you go to the study, it was a retrospective study from 2001 to 2012. 238 patients were enrolled. From that, 73 had acute liver failure, and out of that group, only 3 patients had received liver transplantation. And the timing, route, and dose of steroid was entirely at the discretion of physicians. Some have received 5 milligram of dexamethasone, some have received 20 milligram of dexamethasone, and the range is some have received 1 day, some have received 3 weeks, something like that. So again, this study was mostly done in adult. The mean age was 30.8 years age group, and 7.3% were due to viral hepatitis. And if you see in the steroid group, the total bilirubin was lower. And the enzymes levels were higher in the steroid groups. And if you see the spontaneous survival, if you analyze the spontaneous survival, up to the 3 weeks, up to the 4 week of admission, in the steroid group and there is no steroid group, there is no difference between the two groups. Whereas afterwards, in the no steroid group, some of the patients have succumbed, and the cause is whether it is due to acute liver failure or due to something else, that is yet to be known. And then the specific management of acute liver failure, if you see, there are in the specific management, you can use steroid in autoimmune hepatitis and HLH. These are the two group of conditions where you can use steroid. So that means it appears that if a case of autoimmune hepatitis is there with liver failure, we can use steroid. But again, it is a greater error to avoid treatment in patients who might respond but otherwise die, or to introduce therapy to patients who will improve and may worsen with the use of steroid. So it is a $1 million question. So now we'll see whether steroid is going to be helpful in acute liver failure in case of autoimmune hepatitis. So definitely we know that in autoimmune hepatitis there is an immune basis and the steroid is likely to be helpful. But what is the role of steroid in the treatment of severe acute fulminant autoimmune hepatitis, that has not yet been established. If you look at this study, in autoimmune acute liver failure, no therapy except liver transplantation is effective in the late stage of impaired liver regeneration regardless of the etiology. That means the steroid or any immunomodulatory drug, whatever is being used in the autoimmune hepatitis, it's for in the beginning, when the patient has already landed up in severe and fulminant acute liver failure, the steroid is not going to help the patient in reversing the pathogenesis and giving benefit. That means steroid therapy is of little benefit in severe fulminant acute autoimmune hepatitis. Rather, it may favor septic complications like gram-negative sepsis, even aspergillosis like fungal infections may be triggered by use of high dose of steroid, even in autoimmune hepatitis.
Dr. Meher, you have only 1 minute left.
Okay. So few guidelines and recommendations. So if you look at the guidelines and recommendation, all the management guidelines unanimously emphasize that all cases of pediatric acute liver failure should ideally be managed in a liver transplantation center. So what is the main role? We should support the liver and the other organs. Spontaneous recovery or liver transplantation is the two outcome. Targeted therapy is available for a select group of etiologies. So is there any non-transplant options? So if you look at the non-transplant options, the immunomodulatory therapies are like cytokine removal, like use of oxidase, use of cytosurf. In macrophage activation syndrome, there is a rule of immunotherapy is there, which has a proven treatment of these conditions, which may occur in certain conditions. However, early initiation of high volume CRRT, it's a very useful modality, and high volume plasma exchange is a very useful modality as a supportive modality, or a bridge therapy, which is a non-transplant option in case of acute liver failure. And this Aspagan criteria, they have not described steroid in the management of acute liver failure. Rather, the PCRT expert committee recommendation, the iconic paper recommended doing a renal replacement CRRT in critically sick children with acute liver failure. There is a role of CRRT in the management of acute liver failure.
You can now conclude. Please.
Okay, thank you, sir. So concluding, immune-mediated liver injury documented in acute liver failure. Definitely, systemic inflammatory response syndrome is the key to MODS. And so many drugs are there, but steroid is unlikely going to improve the prognosis. Extensive cellular necrosis and less time is the main problem for non-response of steroid. It may be harmful in sepsis. Hepatic failure study group recommended to discontinue steroid in very early. There is little benefit even in fulminant autoimmune hepatitis. In early stage of a viral acute liver failure, it suppresses destruction of hepatocytes, but there is no difference in survival. And there is no recommendation by any group. However, if you want a non-transplant option, high volume plasmapheresis and CRRT are some immunomodulatory options in liver failure, acute liver failure. So the final disposition is that same effect of steroid in the treatment of acute liver failure is controversial. However, it can be used in certain cases of early viral hepatitis in very early stage. In autoimmune hepatitis, you can treat it in the early, but the role of the effect of steroid in the late stage when there is fulminant hepatitis is controversial, or it should not be used.
Thank you, Dr. Patnaik and Dr. Meher.
Thank
I congratulate both of them, and it needs an applause. They have done such an intensive research on this very vital topic. 30 years back, our teachers used to say, no steroids in hepatic failure. But the pathogenesis has made a transformation in the understanding of this problem. So, in the near future, I don't know whether in malaria also steroids will be indicated. So, thank you so much.
Thank you, sir.
Thank you, sir. You can please move outside for the felicitation. We now move on to the last session. We now move on to our last session, which is a panel discussion on kidney replacement therapy, a right choice for your patient. This panel will be chaired by Professor Supratim Datta, sir. I request sir to kindly take his place on the dais. Professor Supratim Datta is a professor at KPC Medical College, and he was ex-professor in HOD Pediatrics at IPGMR.
Thank you very much. As we are running late, so I'd request Dr. Kaushik Moulik to moderate this session, which is a very important topic, renal replacement therapy in pediatric intensive care. And needless to mention that 25 to 30% of ICU patients, they do develop AKI. So that is why this is a very crucial topic. So Dr. Moulik, please start and introduce the panelists. We have eminent panelists, 5.
So good afternoon to one and all, and big thanks to Society of Pediatric Intensive Care Kolkata for giving me this wonderful opportunity. So we are running very much short of time, so I think we'll directly move ahead and invite my panelists. So we are going to discuss on kidney replacement therapy, right choice for your patient. So my panelists are Dr. Debrina Dasgupta, who is a pediatric nephrologist, currently affiliated to Institute of Child Health Kolkata. Dr. Shumantra Kumar Raut, pediatric nephrologist. Arekta chair. Dr. Dibyendu Roy Chaudhary sir, pediatrician and pediatric nephrologist at Calcutta Medical College Hospital, Kolkata. Dr. Shatrupa Mukherjee, pediatric intensivist, currently working at CMRI. And Dr. Shubhranshu Shekhar Dhal, pediatric intensivist. Okay, so without further ado, we'll start. So this will be a scenario-based session where basically we are going to run through different scenarios and find out like which form of KRT or RRT is going to be the best suited for an individual scenario. It's what we see daily in our ICU. So first scenario is a 2-year-old child with a weight of 10 kg. It's a case of severe pneumonia, mechanically ventilated in septic shock and requiring 2 inotropes. So we are now, the blood pressure is holding at around 5th centile. Day 2 of PICU stay, the urine output of around 0.5 ml per kg per hour. And we have calculated the fluid overload percentage, which we do regularly, and we have found out to be 15%. Urea of 88 and create of 1.2, ABG showing a pH of 7.18, bicarb of 11 and lactate of 2.8, and that is after an IV sodium bicarbonate corrections, and potassium of 6.1, that is after medical management. So now my question to Dr. Dibyendu is, does this child require a KRT now? And if so, why?
So in this case, what are we seeing? That the baby is in sepsis, having pneumonia, on mechanical ventilation, develop septic shock and requiring 2 inotropes for that. With time, the baby has developed oliguria, urine output is less 0.5 ml per kg per hour. Fluid overload is 15%, that is significant. And there is urea and creatinine also high according to his age. There is metabolic acidosis and hyperkalemia, which is refractory to the treatment. So whether this child requiring KRT now, so what are the common indications of KRT? First we have to discuss. So these are the common indications like metabolic acidosis, which are refractory to treatment with sodium bicarb, whether there is significant fluid overload present, significant oliguria and anuria, refractory hyperkalemia, hypernatremia and hypophosphatemia, which is also refractory to the treatment, medical treatment, and when there is uremic encephalopathy and uremic pericarditis. So these are the common indications of renal replacement therapy. If we go to this, in this case we are seeing that that baby is having refractory metabolic acidosis, significant fluid overload, that is 15%, and there is also hyperkalemia, which is also refractory to treatment. So these three is fitting for indication for renal replacement therapy. So for this baby, we must have to go for renal replacement therapy.
Okay, thank you so much. So this is a very simple scenario. It is just meant to discuss that whether you are going to do KRT in this scenario or not. That is because while we are discussing about KRT, what is the right choice for your patient? The first step is whether I am going to do a KRT or not, yes or no. And if these indications are being satisfied, we must remember that we have to proceed with a kidney replacement therapy for our patient. Okay, so now moving ahead. So we have scenario 2. So scenario 2 is now B 8-month-old male infant, case of disseminated staphylococcal infection, and MRSA has been identified, getting intravenous vancomycin at 15 mg per kg per dose Q6 hourly. And from day 7 of intravenous antibiotics, the kid started developing oliguria and then became anuric after 24 hours, urea of 182 milligram per DL, creatinine of 2.3 milligram per DL, and ABG showing a pH of 7.25, bicarbonate of 18, and it had fallen further, both the pH and the bicarb, and an intravenous sodium bicarbonate had been given, and also potassium of 5.9, that is after the definitive medical management. So my question to Dr. Shaturupa. So does this baby require a KRT now? If so, then which modality and why?
Yes, as we can see, the baby is anuric, and also the creatinine is high, the pH is worsening, there is acidosis, so which is not amenable with medical management. So definitely the child needs some form of KRT. Now to choose the modality, so this is a 8-month-old baby.
Correct.
So the options are like PD, SLED, or hemodialysis or CRRT. So what is feasible in our setup? The most, the cheapest, the effective and the safe modality to do in this baby is definitely a peritoneal dialysis. Putting an invasive vascular catheter is quite a challenging job here, so we can't go ahead with other modalities. But PD is a best option in our resource limited setup.
Yes, so thank you. So whenever we face this situation, we always have to make a choice. So among the modalities of kidney replacement therapy which we have, so we have peritoneal dialysis, we have our intermittent hemodialysis, we have our CKRT, that is continuous kidney replacement therapy, and we have the sustained low efficiency daily dialysis, that is the SLED. So we have to choose between these 4 whenever we are doing a KRT. So when we are selecting, the age of the patient has a significant role, the age and the weight. So if it's a small infant, like an 8-month-old or a 6-month-old infant, so apart from PD, in all the other modalities, we require to put a large-sized wide-bore catheter into one of the central veins. And that may become technically challenging, especially in small children. Okay, so in this scenario, so in a resource limited setting or an expertise limited setting, so the ideal choice would be a peritoneal dialysis. But yes, again, so this child, if I tell you is a hemodynamically stable child, you might think that whether you are going to go ahead in this child with a CKRT or an intermittent hemo. So obviously doing an intermittent hemo would be almost impossible in this child, very small child, and the amount of blood flows and the amount of fluid shifts would be very poorly tolerated by the child. Okay, so again CKRT, yes, so you might consider it, but yes, so that would lead to a regulated and slow removal of your solutes and also your fluid, but again you have to place the vascular catheter, it would be a continuous process, and you would also need to use anticoagulation. So all these risk factors are there. So considering all this, in this particular scenario or in such kind of scenario, perhaps the best modality of KRT would be a peritoneal dialysis. So now coming to scenario 3. So our scenario 3 is see a 5-year-old girl child with a weight of 13 kg. She developed acute onset of ptosis and weakness with drooling and dysarthria while playing outside. She also gradually developed red colored urine, oliguria, and respiratory distress. And on examination, fang marks were noted over the foot. So it's a snake bite and become anuric, edematous, blood pressure more than 95th centile, urea of 222, creatinine of 3.2, and VBG showing a metabolic acidosis with a pH of 7.13, bicarb of 10 after bicarbonate correction, and a potassium of 6.3 despite medical management. So my question to Dr. Shubhranshu, so again, so we have understood that obviously, so does this child require a KRT? So yes, so and if so, which modality and why?
So as you can see, in our case, this snakebite case having refractory metabolic acidosis, anuric, fluid overload, along with that having refractory hyperkalemia. So all these are specifying that we should go for renal replacement therapy in acute kidney injury. So regarding the modality, whenever we choose modality, I want to simplify. So what are our targets? We are targeting fluid removal and we are targeting the molecules. So here I want to highlight that the target molecules here are small sized molecules like below 500 Dalton. So when the small sized molecules are sodium, potassium, urea, creatinine, these are kind of molecules, and fluid. So whenever we want to remove such kind of things, we should go for the intermittent hemodialysis. While choosing intermittent hemodialysis, we need to keep in our mind that there is a rapid shift of urea removal. Whenever we do the intermittent hemodialysis, there might be a rapid shift. So that rapid shift can cause cerebral edema, that can cause dialysis disequilibrium syndrome. And the rapid shift of electrolytes between intracellular and extracellular compartment can also cause significant catastrophic events. Other than that, if we remove maximum amount of fluid, the child can go into the hypertension. So whenever we are choosing the intermittent hemodialysis in such a high urea condition, we should target initial session of 30% correction and slower correction. Like we'll target a not fully will correct. We'll keep a target of lesser correction so that we can avoid this condition. And in such scenarios, SLADE also comes to our mind. If we'll see the other basket of choices like PD and CRRT, PD is never an option here because we have such a high urea, along with that dyselectrolytemia, fluid is also there. So, and another option is continuous renal replacement therapy. Continuous renal replacement therapy is not that much beneficial here because child is almost hemodynamically stable and there is need of anticoagulation in here. There is also higher cost. So my first preference here will be intermittent hemodialysis.
Okay, thank you, Dr. Shubhranshu. So here in this case, what is important to remember is that, so patient here is hypertensive and is having acute kidney injury and is becoming oliguric and followed by almost anuria has developed and is having a refractory metabolic acidosis and hyperkalemia, not amenable to medical management. So yes, we are going for a KRT, and considering the hemodynamic profile, older child, the best modality here would be an intermittent hemodialysis. But yes, you must remember that, so it is not like that peritoneal dialysis is never an option, because in any scenario where you are having a uremia, AKI in this kind of context, if you don't have the facility and the expertise available for any other modality of KRT, be it an intermittent hemo, CKRT or SLADE, so you can still do peritoneal dialysis. It will be less effective, but in multiple such scenarios, when PD has been started, it has saved lives. Okay. Okay, so we move ahead now to scenario 4. So our scenario 4 is D, 3-year-old boy with a weight of 12 kg, a case of sepsis with septic shock and ARDS on mechanical ventilation on 3 inotropes and BP just holding at 5th centile with 18% fluid overload at day 3 of PICU stay, coagulopathic, and with an ABG showing a metabolic acidosis with a pH of 7.1, bicarb of 10, that is after IV sodium bicarbonate correction, anuric, potassium of 6.3 despite medical management. So my question to Dr. Sumantro Kumar Raut, so does this child require a KRT? If so, which modality and why?
Okay, so hi everyone. So to start with the scenario, we still have 30 minutes. So the indication was already explained by Dr. DRC. So can we request also the audience at least one indication from this chart for KRT? We had a night session earlier yesterday at Apollo regarding KRT. Any audience? So this is a success. Correct one. Number 2. Number 3. So probably we are not required here. They are enough to tell the reason. So a single child can have multiple reasons for KRT. On this child, the the indications as Dr. DRC told, AEIOU, acidosis, dyselectrolytemia, everything as an adjective, either it is unable to correct or refractory. I is IEM or toxin or poisoning, maybe a non-renal indication. O is overload, fluid overload. That might be a cardiac failure, gallop, or may sometimes maybe only just a positive balance or a fluid overload of 10% or 15% or 20%, whatever our institute make a marker. And IOU is uremic manifestations, means not only the urea is 200 or 400 or 600, but along with pericarditis or some pericardial hiccups or maybe some uremic seizure. So only standalone creatinine value does not make an indication. So indication is clear, so I don't need to speak on that. The second option is modalities. As Dr. Subramsu has also highlighted, the modalities, we have two basic modalities. One is the extracorporeal therapy, the intermittent AST, the SLED, the CRRT, the smooth one, intermittent AST, the rough one, and in between SLED. We have parallel the paracorporeal therapy, the PD, always a smoother one, but not a guaranteed one, non-guaranteed one. So any child can undergo any other therapy. That depends on three things. What is the child's criteria? What is the expertise of our things? And what is the logistics available? Maybe for this child, some patient may have some gross contraindication. Just this child is on 3 inotropes. So probably intermittent hemo is out. Any child who is on single inotropes or 2 inotropes with dropping BP, we can't do a gross aggressive therapy like intermittent hemo. We need some gentle thing. Among this gentle, even SLED we can try, but still 3 inotropes with a dropping BP, SLED might be out. So the options tussles between PD and CRRT. So if I am working in a village hospital, a remote hospital, where a simple Foley's catheter or any chest tube is available to me and nothing else, I can't refer out the child, so I can simply do PD. But remember, if the child is in severe shock, PD may or might not work. Why? The child is an ARDS, a high ventilator setting. I cannot put much amount of fluid, 50 ml per kg, into the abdomen. I may put 15 ml or 20 ml, half weight PD and half efficacy. But still it's done. Better than zero, better than placebo. But obviously, if I am in a good hospital like our Medical College Calcutta or in an Apollo hospital where CRRT is also available, we have the expertise also, then better to put the child on CRRT, which will gradually take the fluid over 3 days or 4 days and does not catastrophize the child as per Vitus is concerned. Am I clear, Hope?
Yes. So here another important thing to mention is the kit is coagulopathic. Okay, so if we use CRRT here, so we have to use it for a certain period of time, and in that case we can't use heparin, so we have to use the CRRT with saline flushes, and in that scenario the chances of the circuit clotting becomes much higher. So as Dr. Shumantro mentioned very nicely here, so whenever we are starting any KRT for any patient, we have to take multiple factors into consideration. And most important among those multiple factors are, one is the age and weight of the patient, another is the hemodynamic profile of the patient. That is very, very important. The patient is off inotropes, hypertensive, 2 inotropes, 3 inotropes, etc. And then next important thing to consider is that, so what facilities and things you have available with you. So you may be bound, you don't have any other modality except a PD. Then in that scenario, and you can't refer the patient out, for example, for some reason, then you have to do that only. And lastly, but very, very important, is the finances. So we will come to that part in our next scenarios, because that plays a very important role when we select our modality of KRT2. Okay, so now next we come to the scenario 5. 5-year-old girl with a weight of 15 kg, with the fulminant myocarditis with cardiogenic shock, mechanically ventilated on 2 inotropes, blood pressure holding at 25th centile, day 4 of PICU stay, oliguric with urine output of 0.4 ml per kg per hour, urea 118, creatinine 2.1, fluid overload 12% since PICU admission, ABG pH 7.12, bicarb 12, lactate of 3, as usual after medical management, potassium of 5.2 after medical management. So, and the patient family is not financially that well off. So, my question to Dr. Deblina is, does this child require a KRT? If so, which modality and why?
Yeah, so can we go back to the case scenario, please?
Sure.
So here, as we can see that we have a child with cardiogenic shock whose BP is controlled on 2 inotropes. The child is having severe AKI with oliguria and is having a fluid overload percentage of 12% with metabolic acidosis, right? So I'll come to the financial aspect later. So we are dealing with an oliguric child with fluid overload of 12% and metabolic acidosis. Now, I would like to ask Dr. Kaushik one question. Is the child having pulmonary edema also?
So yes.
Yeah. So if the child is already having pulmonary edema, then the indication is very clear. We have to go for some kind of KRT. If the child is not having pulmonary edema, then there are certain factors to be considered. Now, fluid overload percentage of 10 to 15% is just borderline. Some centers prefer to start at fluid overload more than 10. Some centers prefer to start more than 15%. Now, I have to consider some other factors also. See, this is the child who is having oliguria. So one very important consideration that we should have in our mind before we take the decision for starting CKRT is whether, or KRT, is whether I will be able to deliver nutrition also to this child. So in a child who is oliguric, having a urine output of 0.4 ml per kg per hour, suppose I'm starting this child on a fluid which is equal to insensible loss plus urine output replacement to prevent further fluid overload. My question is, will I be able to provide nutrition also to this child? Because many a times we see that in the PICU, this volume will be made up by the various infusions and antibiotics that we are giving. So I'm not left with any space to give nutrition. And nutrition is extremely, extremely important for determining the long-term morbidity and mortality of these children. So that is an important consideration that we have. And apart from the indications that have already been discussed before, creating fluid space is also an important indication. So, and another thing to be considered is, this is a child who is having cardiogenic shock, is on 2 inotropes. The child is having severe acidosis. If I don't manage this acidosis, if suppose the child becomes, this acidosis becomes refractory to medical management, this can actually worsen the cardiac contractility and worsen the shock. So I would say, even if the child has pulmonary edema, yes, start KRT by all means. If the child does not have pulmonary edema, then also in this scenario, it's better to start KRT. Now the question is, which modality? See, since the child is already having hemodynamic instability, the ideal will be CKRT. So Kaushik, can we move on to the next slides? So the ideal modality will be CKRT, but because it provides a very gentle and controlled removal of fluid and electrolytes round the clock, thereby reducing the burden per unit time, and is also hemodynamically very well tolerated. In fact, the KDIGO recommends that we should, in a child who is having hemodynamic instability, the ideal modality of KRT will be continuous kidney replacement therapy. But look at the cost. If I think that I'm going to run one filter for even 3 days, my per day cost will be around 20,000 rupees, which is difficult to afford. So in that case, I would say, especially in this child whose parents are not that well affording, I would say SLED is a good option. Because SLED, it has been seen hypothetically, it provides good gentle and controlled removal of fluid and electrolytes, a bit inferior to CKRT, but much better than the other modalities that we have. And secondly, SLED is also hemodynamically well tolerated, maybe a bit inferior to CKRT, but better than the other modalities. But what does the evidence say? So there have been multiple RCTs and observational studies across the adult literature, and in the meta-analysis that has been done, it has been shown, Kaushik, can we please move on to the next slide? Yeah, so it has been shown that compared to CKRT, SLED, if we are doing, there is no difference in the robust hard outcome measures like mortality at 90 days, renal recovery, dialysis dependency, and also secondary measures like length of ICU stay and fluid removal. We don't have RCTs in the pediatric literature, but there have been many observational studies coming up which have compared, which have tried to assess the feasibility of SLED, and one of them being notable being a study from AIMS. Next slide, please. So here also they have tried to do SLED in hemodynamically unstable children with severe AKI who are on 1 to 3 inotropes with BP controlled on those inotropes. And they have seen that at least 89% tolerated the SLED well without any premature termination with good fluid and solute removal. So SLED is at least non-inferior to CKRT as far as whatever evidence that we have in the adult literature. So yes, if the patients can afford, I would like to go for SLED, but the per day running cost of SLED is around 6,000 rupees. So if the patients can afford that, well and good. If the parents cannot afford that, then I have the option of going for PD. So in peritoneal dialysis, it has lesser efficacy than CKRT and SLED, but nevertheless, as Dr. Shumamsha already said, something is better than nothing. So PD can work sometimes really well, and we can achieve acceptable removal of fluid and electrolytes with PD also, and it is very, as we are doing it 24 hours, it is very gentle on the kidneys, on the blood pressure. So PD will be a very good option here. And the running costs of PD are, if you are using a rigid catheter, then the cost will be around 3,000 per day. It may be lesser if you are getting things at subsidized rate. And if you are using a soft catheter, it will be around 7,500 per day. Problem with PD is that, as I already told, it has reduced efficacy than CKRT sled. It is unpredictable and it cannot be controlled. You cannot control the fluid. You cannot say that, okay, I want to remove maybe 100 ml in the next 4 hours. You can't always, you may not be able to achieve that in PD. And sometimes we face significant mechanical complications, like there are inflow problems, there are outflow problems, which can actually reduce the downtime. And as we can see, soft catheters, the cost is almost comparable to that of sled. And rigid catheters are ideally not recommended unless there are severe affordability issues. So PD, if the parents are not affording, and if I do not have the sled setup or the machine, or the parents are not affording for sled either, I can think of going for PD. If very poor patients, I can go with rigid PD also. Now, coming to hemodialysis may not be completely out of the scenario in this child if I make some modifications to it. So suppose I make a modification like where I do hemodialysis for the first 1 hour, and then I switch off the dialysis and only take out ultrafiltration. So in the mode called ISO-UF, and I try to take out fluid only gently without doing dialysis over the next 8 hours, then also I can deal with the fluid overload in this child. Only problem is that since I'm doing dialysis for 1 hour, I may not be able to remove the acidosis well, correct the acidosis well, which can have some detrimental effect on the child's cardiac contractility and may worsen the shock later. But suppose in a center where CKRT is not available, sled is not available, PD I tried, but PD didn't work because of some complication. If I have HT machine and expertise, I can still do HT with this modification.
Thank you so much. So the key message to take from this is that, as you see in this slide, it is portrayed that in this index child, so we may opt for all the 4 modalities, but there is a sequence obviously. So the ideal in this scenario would be a CKRT because of the reasons mentioned, and then because patient family is not financially well off, so we might need to go ahead with a sled. So peritoneal dialysis obviously can always be done, but here in this scenario it should be the third option. And this modified intermittent hemodialysis, this is to be the least preferred here because of the reason mentioned. Okay, so now we come to scenario 6. Is F a 10-year-old boy with a weight of 32 kg with fulminant liver failure with hepatic encephalopathy, INR of 4, serum ammonia of 421 after sodium benzoate, on 2 inotropic support and having raised intracranial tension, intubated and mechanically ventilated with anti-raised ICT measures going on. So, my question again to Dr. Deblina is, does this baby require KRT for ammonia removal? So long we have been discussing about urea, creatinine, small molecules, etc. So here we are now discussing about non-renal indications like removal of ammonia and other molecules. So if it is required, then which modality of KRT would be preferred? Why? And also, as an additional question, so can any other alternative modality also be used? And how is PD for the removal of ammonia? So
looking at this scenario, can we go to the scenario, please?
Yes, please.
Yeah. So this is the child having fulminant liver failure with hepatic encave, and the serum ammonia was 421. Even with this ammonia level, I would say yes, KRT is recommended, because KRT recommendations now, according to the latest guidelines, are that we should start KRT when the ammonia is more than 200 micromoles per liter. And because this is mainly based on various studies, especially by a study in King's College Hospital in UK, where they have shown that if we are starting KRT with serum ammonia levels between 150 to 200, then the survival is around 58%, right? Now coming to the ideal modality, so this, even if the child does not have AKI, even with this ammonia level, yes, KRT is indicated. KRT does not mean that we do it only for AKI, we can do it for other indications also. So now in this case, the ideal modality will be CKRT. In fact, KDIGO recommends that CKRT is the modality of choice when a child is having raised intracranial pressure. Because CKRT, as I told earlier, it is very gentle and controlled. It will have very gentle transcellular shifts, so it is very beneficial for a child who is having increased intracranial pressure. Plus, CKRT provides a very controlled removal of ammonia. So it has been seen in studies that if we are able to reduce for every 10% reduction in ammonia at 48 hours compared to the baseline, there is a decrease in mortality by 50%. So CKRT and plus if in case of liver failure with or without AKI, there is significant accumulation of middle molecules also in the body. So if I can add the hemofiltration to it, I can even remove the middle molecules. And as we have seen in the previous talk also, that in acute liver failure, therapeutic plasma exchange cytosorb may be helpful, cytosorb for removal of cytokines because it is a state of it's a pro-inflammatory state, and therapeutic plasma exchange because it can help in removing the albumin-bound toxins. So if needed, I can even combine these modalities with CKRT without having to insert another line. In case of PD also, I can do these modalities, but in that case, I have to do another extra procedure. In CKRT, it's not needed. If suppose the CKRT machine is not available, parents are not affording, or if expertise is not available, I can even go for SLED. SLED also can give me comparable results like CKRT if CKRT is not possible. Then definitely another option is PD. It is third because again, as I said earlier, you cannot control it. The removal may be unpredictable, but something is better than nothing. So if you're sitting in a center where you don't have CKRT, where you don't have SLED, or if the parents are not affording, by all means, please start PD, and maybe you can consider referring the child to a higher center where we can do the CKRT SLED. Hemodialysis is completely out of the question in this child because it's a child we are dealing with has raised intracranial pressure, so hemodialysis will cause problems with that ICP management.
Okay, thank you. So now we come to our last scenario basically, and this scenario will address a very important question, and that question is like, so long we have been discussing about which modality is the right modality for my patient. Initially we discussed in which patient we should do a KRT, and the last thing is that when to do it. So should it be done early? Should it be done late? Okay, or should it be done sometime in between? So G, 5-year-old girl with a weight of 14 kg, pneumonia with AKI and septic shock on 1 inotrope, having pulmonary hemorrhage, Acinetobacter positive in blood culture, urine output of 1.3 ml per kg per hour, having metabolic acidosis with a fluid overload of 11% and POCUS lung showing multiple B lines and ventilator settings gradually worsening, and diuretic infusion tried but leading to hypotension. So I want to ask all the panelists individually, so would you do KRT for this child now? If you do, then would you do now, or will you wait for some time? What are the criteria which you will take into consideration to decide when the KRT should be initiated, and then the modality and why? That I think has already been addressed. Okay, so Dr. Subantro, if you can just elaborate.
Okay, so people have tried to answer this question many times, but there is no conclusive answer. So as Dr. Kaushik has voluntarily kept these options, all the modalities are on for this child. Even intermittent hemo, PD, SLED, CRT, we can do everything on that now or maybe a little bit later. So as the indication Dr. DRC told regarding AE, IOU, all they are rescue indication only. Refractory acidosis, refractory, not just a patient enter a stage 2 AKI or a stage 3 AKI and we did the dialysis. This Elen tried this one. The patient entered into stage 2 plus 8 hours, they started doing dialysis. And this team, all the trials are in adults, and they are very comfortable in doing either intermittent hemo or CRT for even a stable patient. But what they found, that whoever is done early is having a good results. On the same year, on 2016 itself, this Akigi trial came, Akigi 1, and it revealed that there are comparable results, but whoever done early dialysis has more mortality due to the dialysis procedure itself. So everything depends what is the background of the patient, which centers you are working, how much comfortable we are. So for this patient, particular patient, if you can see, there is can you see the case once more?
Sure.
So there is some fluid overload that has not impending heart failure gallop is still not there. But as Dr. Devalina pointed, either you mark it either 10% fluid overload or 15% or 20% as per your hospital policy. But stick to that policy. Don't be dogmatic, but keep a little bit flexibility. So 11% overload can be one of the criteria. If you still need some space, your ICU team needs IVIGs, your ICU team needs huge amount of inotropes, some bleeding profile needs FFP at least 2 to 3 packets per day. To create that space, you may need dialysis now. If the child is on minimum amount of fluid, minimum amount of inotropes, and keeping euvolemic on AKI regimen, then we may delay the dialysis for timing. So whenever at least for India or developing country, we are doing mostly in case of rescue purpose because we have some logistics issue for doing any form of dialysis. So for this patient, we don't have exact answer, but how people have shown that whenever your fluid overload, even if in absence of heart failure, if it is increased from 10 to 15 to 20, your mortality may vary. But if you do the dialysis on the same patient, your final outcome will vary or not, that we are not that sure. So for this answer, we are still inconclusive. You may or may not start dialysis at this point of time. If your facility is quite okay, you are quite comfortable, just go ahead. If something is abnormal, then wait for the last rescue. That is my
Okay. So like this particular scenario has been deliberately been put like that. So
But I think you had put that there were multiple B lines also in the.
Yes, it is there.
So I am not very good with POCUS, but are B lines specific for pulmonary edema or they can be present in something
no,
else
they can be
also?
present in multiple other scenarios also. So I am saying that the ventilator settings are gradually worsening. So plus minus kind of scenario kept where the urine output cutoff is more than 1 ml per kg per hour and fluid overload percentage is borderline. So in resource limited settings particularly, and if we take into consideration the evidence also basically, none of the trials practically indicate that early initiation of RRT is beneficial over late initiation. Rather, sometimes in scenarios where you jump and initiate a KRT early, the process of the dialysis itself is associated with some complications. So at least in our practice also we follow that we initiate KRT mostly for the rescue indications, like which has been mentioned, like refractory hyperkalemia to medical management, refractory metabolic acidosis if it is there. So those are the indications where we usually start. There are observational studies which have shown a definite association between fluid overload percentage increasing and an increase in mortality. But most of the studies are observational studies. So regarding CKRT, like to Dr. Shatarupa, so is there any benefit of initiating CKRT early in critically ill children?
Yes, so definitely there have been not many RCTs, but mainly these are some retrospective studies which shows evidence of initiating CKRT in critically ill children, and they have shown that there are some like predictors of mortality which we can deal with starting with early initiation of CKRT. Can you go to the next slide?
Yes, sure.
So supporting different organs apart from the kidney in patients with sepsis, acute liver failure, ARDS and cardiogenic shock, then mitigating fluid overload and which will support the lungs and the heart, and also removal of some damage associated proteins and cytokines, and also for removal of water soluble products like ammonia and inflammatory molecules. By this we can at least have some mortality benefits.
So the question was regarding the initiation of CKRT early. So again, here also if you see in a study which is a retrospective study, so in the analysis also, so the late initiators had a higher mortality than early initiators with a hazard ratio of 1.56 and the 95% confidence interval is 1.02 to 2.37. That is just almost touching 1. Okay, so here also you don't find that much objective benefit by initiating a CKRT early. And just one last question that I have, that is, suppose we don't have any other rescue indication of initiating the KRT, but only I am finding that the fluid overload percentage is suppose 15%, 18%, 20%, for example 20%. And and you are using diuretics, trying to use a diuretic infusion, patient is not diuresing and progressively the fluid overload is increasing. So based upon whatever evidence you have about the association between increased percentage fluid overload and mortality, would you initiate the patient on CKRT based on only fluid overload criteria?
So I think by this time the answer is known to us because there is no definite benefit from early initiation of KRT. So we can wait till the rescue indications has been shown to us. Otherwise we can wait for that. Number one. Number two, only 10% fluid overload in a ventilated child may not have significant increased mortality. So for that reason, in resource limited setting, we don't jump for early initiation of dialysis. But if KRT is feasible, if there is full resources, if it is feasible, then we can go for it. But it is not recommended at all.
So here, in this situation, perhaps what we look at clinically is whether my fluid overload is affecting the patient in such a way that my lungs are getting progressively wet, affecting my ventilation, or I am having a lot of soft tissue edema affecting my ventilation, distension of the abdomen which is pushing the diaphragm up. So all these scenarios. And if still the fluid overload is contributing so much and I am unable to mitigate the fluid overload by using a diuretic infusion, then in that scenario I might consider initiating a CKRT, but not perhaps like just seeing the percentage of the fluid overload, and if it is 15% and then we start a CKRT immediately at that point of time.
So I would like to make a comment on that. So basically fluid overload percentage is a calculation, right? But that always has to be correlated with whether I have clinical evidence of fluid overload. So it may so happen that suppose a child comes to you with severe dehydration today, you push in fluids. On day 2, if you calculate the percentage fluid overload, it will be high. But does that mean that the child is fluid overloaded? No, we just corrected the deficit which was there. So the fluid overload percentage always has to be correlated with the clinical findings of fluid overload. So if the patient is having pulmonary edema, we have to go for it. Now, I wanted to comment on another thing.
Sure.
You can finish your discussion and then I can comment
yes,
on that.
please go ahead with the comment.
So
Time is also short.
Yeah. So basically, when if we look at the literature, trying to find out what is the optimal timing for starting KRT, if we look at the adult literature, except for the ELANE trial, whatever trials we have, all are saying that, all are pointing towards that you should always start KRT only if there are life-threatening complications or if there is persistence of the AKI, of that deranged renal function for more than 72 hours. Now, as Shatarupati had already shown, in case of children, we don't have any RCT regarding the optimal timing of initiation of KRT, but we have some observational studies, retrospective and prospective, regarding what should be the optimal timing for initiating CRRT. And it says that all these studies are favoring early initiation of CRRT. But you cannot try to compare these two findings. You cannot try to compare the finding of the pediatric literature with the finding of the adult literature, because if you are doing so, we are actually comparing apples with oranges. Why? Because the key is what is your definition of early and late. So in adult, your definition of early is when you are doing it within 12 hours of stage 2 or 3 AKI, and late is when you have already started having life-threatening complications. But in case of the pediatric studies, they have defined this early and late based on the chronological time since the admission of the child in PICU. So some studies say it is 2 days before, 2 days after 2 days. Some studies say it is before 5 days, after 5 days. So they have not, all these studies have actually looked into whether these children actually had indications of kidney replacement therapy. And there was one study which had actually accounted for the fluid overload also, and even when you're adjusting for the fluid overload, then also early initiation of CKRT helps in reducing the mortality. But if I try to summarize the findings, and these two, the pediatric and the adult literature findings are actually complementary. So I would say whatever evidence that we have till now, what we know till now is that we should definitely start KRT when the child is having life-threatening complications. That includes fluid overload more than 15% with or without pulmonary edema. And if pulmonary edema present, by all means you have to start. Second is, if a child is having persistence of severe AKI, even beyond 48 to 72 hours, even if there are no other indications, you should start considering giving KRT, because it has been shown that it can actually lead to increased mortality. And another thing, we often make this mistake in the PICU that we say, okay, creatinine is not this much. It is not that high. Then should we really consider AKI? Always keep in mind that creatinine is a very fallacious marker of GFR. So it may so happen that the creatinine is falsely low because of dilution due to the fluid overload. It is falsely low because the child is malnourished. So just looking at the creatinine, don't decide what is the stage of AKI. Always look at the patient in totality. Even a child with stage 2 AKI can have significant fluid overload and pulmonary edema. So you have to look at the entire picture and then decide.
So very important message, thank you. So we'll just close now with a summary. So while summarizing, I could find these points. So KRT, when used in an individualized manner, can really help to save lives of critically ill children. And many factors influence the modality to be selected for an index child. So as we saw in multiple scenarios which were just now discussed. And in resource limited setting where no other KRT modality is available, doing a peritoneal dialysis can save lives. That's a very important message. So don't say that no, it is not indicated, I will not do. Okay, and there is no consensus about timing of initiation of KRT, especially in children, because we still now till now don't have the enough evidence. Evidence should be coming up gradually, and it should be highly individualized, seeing the individual patient. Thank you.
Very good, enlightening and learning session indeed.
Thank you, sir. Sure, sir. Definitely, sir.
We're running very late, but one of the, I think it a lot depends on where you work.
Yes, sir.
Like in Western literature, the commonest indication for RRG in ICU is to create space.
Yes.
That is the commonest indication. And here, we are a bit hesitant to do it. Why? Because they are very, aggressive on nutrition. Yeah, like not just space, especially for nutrition. Yeah, like Debrina said, what about nutrition? But if you are thinking, doing RRT is such a big thing, and then nutrition goes back. But if you are in a setup where doing RRT is not that much, it's okay, we do it all the time. Then nutrition becomes very important. And then you say, no, nutrition is very important, I need RRT. But here, we still think that RRT, then nutrition goes back. If you are thinking about nutrition, then RRT should come, as the cleaners.
Absolutely.
So we need to prioritize the thing. Once our ICU team decides on nutrition from day one, the nephro team must be ready to do the RRT. And this is a teamwork.
Thank you, presenter and panelists. Can I request all of you to move to the felicitation area and collect your memento? And can I ask everybody else to go to Hall A for the quiz, please? Thank you.